It's an excellent initiative and congratulations to you all. Thank you for inviting me here today for presenting my talk on innovating the path to parenthood. Now, how do I change this? It's not working. No. Yeah. Sorry. Yeah. So I'm. Doesn't seem to be working. Where do I point it? Here. No. So we can't go ahead and look at the innovations that have happened in the path to parenthood without actually looking at our past. Where did I okay, so let's go to the past. We will quickly go through how infertility was viewed and how it has been referred to in our mythology, not only in our mythology, but also in various religions in the past. So there have been many references to infertility in the Bible and in Hindu mythology. Sarah, Rebecca, and Rachel were the three matriarchs who were the first three barren women in the Old Testament. So Genesis 16:2 says that Sarah was married to Abraham, and I'm sure all of us know this story, and she had an Egyptian slave called Hagar. And Sarah was married to Abraham for about 50-60 years without any children. And then she sent her Egyptian slave Hagar to Abraham with the hope that he would inseminate her and she would have a baby through Hagar. What happened after that is a whole long story. Hagar did get pregnant. She gave birth to Ishmael. And this may have been the earliest example of surrogacy. Now, what happens in Hindu mythology? Dasharatha, we all know of him, is perhaps the first reported case of infertility in the world. He conducted the Ashwamedha Yagna, and God sent him a porridge, half of which was given to Kaushalya, and Ram was born. 1/4 was given to Sumitra, and Lakshmana was born. 1/8 was Kaikeyi, Bharat was born, and another 1/8 is again given to Sumitra, out of which Shatrughna was born. So there are many instances of this in the world. But from 1920 to 1960s saw a lot of progress in the field of infertility. So 1923, medical researchers identified the female fertility hormone estrogen, which has become a commonplace name for us, and we take it for granted now. In 1929, progesterone was found out. 1943, hormone supplements were developed for infertility. 1950s, IVF testing was done on mice and rabbits. And 1960s, drugs used to boost infertility, especially clomiphene citrate, which is our household name, was developed. 1968, researchers first retrieved and fertilized human eggs, and 1969, medical researchers first fertilized the human egg cell. Again, in 1970s was an era of mega progress. There were initial attempts at IVF on humans. In Monash in Australia, they did have the first human IVF pregnancy, but unfortunately that miscarried within a few days of the patient having conceived. Dr. Patrick Steptoe, who was the gynecologist, and Dr. Robert Edwards, who was the embryologist, performed the IVF procedure in England, resulting in the historic birth of Louis Brown on July 25th, 1978. 1980s, IVF became mainstream. In the 1980s, by the 1990s, more than 1,000 babies were born in the UK itself. So here, I do not know okay. So here this is the baby, the lovely Louise, and it was the result, and that's Louise there, who is now older, and she has got her own 2 children. So Patrick Steptoe and Robert Edwards performed the procedure in England, and she was born in 1978. Dr. Subhash Mukherjee, who was the gynecologist, and Professor Sumit Kumar Mukherjee produced India's first test tube baby and the world's second IVF baby. Unfortunately, this was not very well documented scientifically, and hence he was not given the credit. Her name was Kanupriya Agarwal, also called as Durga, who was born on October 3rd, 1978. Now, this was further by the doctor who went there and who looked at all the documents, and later on, much after Subhash Mukherjee passed away, did claim that this could have been the the world's second IVF baby. In 1986, India's first scientifically documented test tube baby, Harsha, was born in Mumbai. And South India's first IVF baby was born on December 5, 1988 in Gunashila Hospital, Bangalore. So in only 40 years, thank you, a technology miracle has come to be seen as a cure for all fertility problems. So again, we go back to the milestones. 1960, gonadotrophins, which are the mainstay of fertility treatment, were invented. 1970, gonadotrophins and IVF. 1980, cryopreservation came in, which is called as freezing of the eggs, freezing of the embryos. So that was when it started. And 1990, recombinant gonadotrophins, again, which have become the mainstay. Recombinant the FSH and H were made from Chinese hamster cells using recombinant technology, and ICSI was developed. Now, this is how an oocyte looks on the left-hand side. And if you can see, I don't know if I can use this as a pointer, I'm not too sure. But on the right-hand side, you can see the egg, and you can see these sperms. Does this pointer work? I'm not too sure. Okay. So you can see the sperms that are surrounding the egg. Now, this is a example. This is a small video of ICSI, how ICSI is done. So this is the egg. I think we need to play the video. The video is not playing. Yeah, so you can see the needle going there. The needle has the sperm inside it, and it's pushing the oocyte membrane, that is the egg membrane. And if you can see the small rounded structure which goes back and comes back and is deposited inside the egg. So this is intracytoplasmic sperm injection, and this is just a video showing you exactly what happens in the lab. So this was actually initially by accident. It was discovered that this could be done by Palermo in 1990 in the University of Brussels, and the first successful birth took place in 1992. And this was the start of a lot of IVF technology. Now, what are the indications for this? It could be a male factor where a man has sperm which is not satisfactory. It could either be non-motile, or they could have very few sperm, or they could have abnormal sperm. Or you could have surgically retrieved sperms in men who do not have any sperms in the ejaculate, or you could use it in frozen sperm as well. When you talk about non-male factor, it is unexplained infertility, poor quality eggs, poor quality yield, so you don't get enough number of eggs. You need at least 12 to 15 eggs to have a good, successful IVF outcome. So advanced maternal age, prior fertilization failure with conventional IVF. Also, if you want to do pre-implantation genetic testing, IVM, and also for cryopreserved gametes, frozen gametes. So this is just some statistics that we have got. With IVF and ICSI, they do pretty well. The fertilization rate is higher in an ICSI cycle, but finally the number of blastocysts, that is day 5 embryos that are produced, is pretty much the same, and the frozen pregnancy rate is 62% in IVF and 58% in ICSI. Now coming to the present, so where are we? Now here in the present, we have got in vitro maturation of oocytes, we have got long-acting gonadotrophins, fertility preservation in cancer patients, and that could be extended to women who are really not interested in settling down. It is also called social freezing. And then we also looking at single embryo transfers, rapid freezing of the gametes, of both eggs and semen, and as well as pre-implantation genetic diagnosis or testing. I can't talk about everything. The topic is too vast, so I've just chosen a few topics. So we're going to talk about time-lapse system, genetics and infertility, which includes pre-implantation genetic testing, in vitro maturation, and few others. So Embryoscope is an incubator which has incorporated a lot of AI in it. It is a special incubator with a built-in camera for looking at real-time imaging of the embryos. So once the egg is inseminated with the sperm, then the embryo is kept inside this incubator, and the incubator takes pictures of the embryos every 20 minutes. So you get a real-time imaging of these embryos. Now embryos are supposed to actually go by a timetable. So within so many hours they should have fertilized, within 4 hours they should have the first division and then the second division, so everything is pretty much time bound. So this not only looks at the time but also looks at the quality of the embryos. So this is actually, we have all read about cell division in our textbooks. You can actually see this happening real time with the embryoscope. A lot of AI has been involved over here, and it takes a little time. It's a little bit of a long video, but it's beautiful to see. So I don't know if you can actually make out, but you can see that the one cell has divided into two cells, and this is the birth start of life. And again, you'll have the 2 cells dividing into 4 pretty soon. Yeah, you can see that it is divided again. And the cells should be equal, they should be symmetric, they should be equal in volume and size and shape. And this is what would be a day 2 embryo, where you have 4 cell stages. And then as it keeps on, shall we say, dividing, it becomes a ball of cells. And this is something which we got the embryoscope in 2011 or 2012, and now it is a day 4 embryo where the cell stages merge and it becomes a ball of cells, and soon after this it becomes what is called as a day 5 embryo, which is called as a blastocyst. So blastocyst is the stage where usually the most robust embryos reach. You can see it is forming a blastocyst here. The middle portion is water, and the water pushes the cells to the side. So you can see that happening. And if you put this into the uterus and this goes and gets stuck inside the uterus, or what is called as implantation, it forms the baby. So this is a beautiful blastocyst, and you can make out at the, so we say 4 o'clock or 5 o'clock position that it is hatching. So this is how AI has come in here in a big way, where they're trying to look at whether they can identify the blastocysts or the embryos with the best potential of forming a pregnancy. Now, pre-implantation genetic screening, it is also coming up in a big way. Now, this is basically used to ensure the genetic health of the embryos before they are transferred back into the uterus. So PGTA is used to screen embryos for chromosomal numerical normality. So we all have 46 chromosomes, so we should not have 46 and a half or 47 or 45, in which case the pregnancy doesn't really do well. So it can identify whether an embryo has too few or too many chromosomes, and the first report of genetic testing was published in 1990, but technology has grown by leaps and bounds since then. So PGTM, what is PGTM? We have families where people have married in the family, and they have diseases that can be passed on in generations in these families, like for example thalassemia, sickle cell disease, Duchenne muscular dystrophy. So these PGTM is a technology where you look for these specific genetic problems in the embryo even before it is transferred into the uterus. HLA typing is employed by parents who have, like for example, thalassemic child, where they have multiple blood transfusions, and these babies could benefit from some sort of tissue transplant like bone marrow transplant. Now, what are the indications when patients come with recurrent miscarriages? Advanced maternal age, 38 years and older, recurrent implantation failure, they have had multiple failed IVF cycles despite putting in good embryos, severe male factor. And what is the advantage? Best embryos can be chosen. Pregnancy rates increase by about 5 to 10%, and the time to get pregnant is much shorter, and hence cuts out the distress and emotional physiological problems that the couple undergoes. And I'm very happy to say that Gunchila Hospital was the first IVF center to start an in-house genetic lab at affordable rates with top quality standards, and it's called as Tatwa Gene. It was started in 2015. Now, this is how we do an embryo biopsy. So how do you do a PGTA? We have to take some cells from a day 5 embryo, and the number of cells that are taken are about 5 to 8, and we laser every embryo has a shell, so you make an opening in the shell by using the laser shot, which is the green and the red thing that you see, and then you suck out a few cells, and these cells are sent to the genetic lab for further diagnosis. So that is what they're saying. That's what they're doing over here. You can see that the hole has been made in the zona. Zona is the outer shell, and the cells are being sucked out. This does not harm the embryo, and what cells we are sucking out is from the area of cells that is further destined to produce a placenta. This is not the tissue that is going to be the embryo or the baby. So you can see that, and that goes, those cells, that portion of cells goes to the lab. So we have PGTA, where we look for the number of chromosomes, and that is basically in advanced maternal age, repeated implantation failure, recurrent miscarriages, male factor infertility. PGTM is in women or couples who are known carriers of a genetic disease or have had babies who have had genetic problems. And the PGT-SR, there are a small percentage, about 2 to 3% of infertile couples who have a abnormal chromosome genetic makeup, but they are okay, but when they pass it on to their offspring, they end up in abortions. So again, we have now with PGTA pregnancies, embryos, we have now doing single embryo transfers, and we're getting a pregnancy rate of about 50%. And with double embryo transfers, although I personally don't like twins, because it is very difficult for both the patient as well as the doctor to continue a twin pregnancy, and most of our ladies who get pregnant come back to us. Some of them insist that they want 2 embryos to be transferred, and when we do that, we are getting a pregnancy rate of about 70%. So one of the main advantages of PGT, pre-implantation genetics testing, that is, you test the embryos even before you put them for before you transfer them into the uterus for genetic normality, is to decrease the time to pregnancy and also miscarriages. Now, what is in vitro maturation? In vitro maturation is when you take out immature eggs from the ovary and you mature them outside for 24 hours outside the body in the lab, and then inject the sperm into the egg, and then the rest of it continues as a normal IVF. So you would do them in women who are producing too many oocytes, like for example, in polycystic ovarian syndrome, women who are poor responders, oocyte donation program, or in also fertility preservation in cancer patients where there is paucity of time. So I'm not going to go into this because this is a little bit more technical. This is, okay, it's playing anyway. This is an ovary showing number of follicles. It is a very, shall we say, it is a difficult procedure, IVM, because the follicles are very small, and it is very difficult to get into each of the follicles and retrieve the oocytes. Sometimes we get about 60, 70 oocytes, which we don't get in a normal IVF cycle. We don't want to get that many also. It's a difficult procedure, very time consuming, uses a lot of media, very time consuming for both the clinician as well as for the embryologist. Now, going on to TISA and micro-ICSI, I must say something about the sperm. So this is mainly for men who do not produce enough sperm in their ejaculate. They can the sperm can be retrieved by an open surgical biopsy or by a percutaneous procedure. And micro-TISA would be where you actually use an operating microscope and open up the layers of the testis. And the testis has plenty of very, 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 very fine tubules, and you retrieve only those tubules that are slightly swollen, and you hand it over to the lab, from where they will be able to retrieve the sperm. Now, where are we heading to now? Fertility preservation in cancer patients. I want to also let you know that we had our first IVM baby in March 2004, and this was 4 years before UK, actually in Oxford, they had their first IVM baby. So we have, as of now, we have the highest number of patients who have come for IVM. We have about 600 odd patients, and our pregnancy rates with IVM are now touching somewhere between 45 to 48%. Fertility, now where are we heading? We are heading towards fertility preservation in cancer patients. We do this because we have taken it up as a, I was telling Mr. Vijay that we have taken it up as a charity concern, where we are freezing sperm and eggs and ovarian cortical tissue free of charge for 10 years in men and women who have been afflicted with cancer, because once they start their cancer treatment, it could be either chemotherapy or radiotherapy, their ovarian reserve falls, their oocytes or sperms get destroyed. So we currently have the highest data in the country. We have about 600 men who have come and frozen their sperm free, and about 40 women who have frozen either their eggs, their embryos, or their cortical ovarian tissue, all for free. Now, we are heading towards restoring ovarian function, postponing menopause, robotic ICSI. So I do not know whether actually embryologists are going to be necessary in the coming years. Robotic ICSI is pretty much there. Immunology of pregnancy is where they try to prevent miscarriages. That is also, we are heading by leaps and bounds towards that. So all progress is based upon a universal innate desire of every organism to live beyond his means. So the future, what do we have in the future? Future looks very exciting, and according to me, future is going to be genetic based. So genetics in infertility is CRISPR and designer babies, ovarian rejuvenation, which is postponing the menopause, producing artificial ovaries and artificial gametes. And this is gene editing, the CRISPR technology, where actually if they find that somebody has a genetic disorder, they will take out that bit of chromosomes and that bit of the genes where there is a problem, that bit of DNA, and replace it with healthy DNA, or they will reattach the DNA strand. So that is also there. It has been done, but is not commercially available, and it is not in the mainstream. Designer babies, so you want blue eyes, fair skin, tall, intelligent, well-built, Aishwarya Rai types of babies. Yes, you can have them. And a baby whose this is a designer baby, is a baby whose genetic makeup has been artificially selected by genetic engineering to ensure the presence or absence of particular genes or characteristics. Now, this is Dr. Kawamura, who actually helped in ovarian rejuvenation. So this was a lady who had a low ovarian reserve or no ovarian reserve, and he actually had a technology where he took the ovary, cut it up into bits, put it into a solution with a lot of growth factors and activating factors with the help of somebody in Stanford, put it back into the patient, and she gave birth to a child. So this is simply amazing. It's happening in Japan. And anti-aging medicine and reproductive health is a new category of preventive medicine that is fast evolving in Japan. And here, when women are unable to have children, they have been given a new hope with scientists trying to create an artificial ovary. So this is all going to come. This is going to come, and not very long. We don't have to wait very long. It's almost there. So artificial ovary, how it works is the 3D printer makes a synthetic ovary from gelatin, egg cells and are inserted into it, and this newly built ovary could be implanted into an infertile woman, allowing her to begin ovulating. Now, they have made a synthetic ovary which allowed female rice which start to function, and they put it into female mice that had been surgically sterilized to reproduce. And this may be one of the things that people are looking at in the future, and it would be amazing, because I find that the trend nowadays is that a lot of young Indian women are losing their fertility, and the reasons for that could be numerous. That's a whole talk by itself. It's called as endocrine disruptors. We won't go into that, but that could be a way in the future. So sperms are being made from human bone marrow, and they have made immature sperm cells from human bone marrow samples, and if these can be grown into fully developed sperm, which researchers hope to do within 5 years, they may be used in fertility treatments. Then we may not need men. Men may become obsolete. So really, no, they won't, but then we can still get sperm from men who are azospermic. Stem cell technology again is coming out in a big way, trying to develop eggs and ovaries, eggs and sperms from stem cells. Also, they're trying to rejuvenate the lining of the womb in the that is called as the endometrium in women who have had tuberculosis or in women whose lining has been ravaged by infections. Artificial gametes are now being made from adult cells, men with azospermia, that means no sperm in their semen sample, and women with ovarian failure may have the hope of getting their own genetic offsprings. Right now we have to depend upon donor eggs or donor sperm. That may be, hopefully it will kind of fade away if this technology comes in. And monkeys born with artificial gametes, Roku and Hex. And this is something that I picked up from the internet. It is highly borrowed, and here they have a pod where the company is called as Ectolife, and they are saying that babies could be placed in this pod, and it is like a womb. It will simulate the womb. It has the amniotic fluid. It has what shall we say, filters which take out the waste from the baby, the nitrogen, urea, uric acid, ammonia, etc., and then put in the oxygen, amino acids, etc., into the baby. And apparently you can have an app where the parents are looking at the baby, they can sing to the baby, they have sensors attached to the baby's head, so the baby will hear the parent's voice, and all sorts of things like that, which is very futuristic. It's like from a sci-fi novel or a sci-fi movie, Carl Sagan or one of these Steven Spielberg, but we do not know. That seems to be coming, and they have actually developed, put a sheep into an artificial womb and have actually tried to grow it. Do not know exactly what happened to the conclusion, but the future, I want to say, is very exciting, especially with producing artificial ovaries and stem cell coming up to rejuvenate the ovaries as well as the testes. And I think there are exciting times ahead for the public in general. The choices are going to be numerous. Of course, it is ridden with a lot of ethical issues and a lot of ethical problems. So the future holds a lot of exciting possibilities, and looking forward to the same. And I thank you very much for having given me an opportunity to present this talk and give you an insight about what the future holds. Thank you so much again.
Hello. Hi everyone. We started off from the past, we delved into the present, and we really got to know what the future literally has to unfold. Wow. Can we all give a huge round of applause, ladies and gentlemen? Dr. Devika Gunashila ma'am, that was an insightful presentation, but I want you to kindly stay back, for the team has been working day in and day out to let the world know and create awareness about paths to parenthood. So we want you to join us for the release of the book on the theme Path to Parenthood. So I kindly request Dr. Devika Gunashila to kindly join us here, along with Mr. Ravi Kumar, MD and CEO of Newsfirst. Can we all give a huge round of applause and welcome sir onto the desk, please? I also request Mr. Ashutosh Dwivedi, COO of Vyli Health, to join us here on the stage. I also want Urvi Mehta, Senior Vice President of Brand First, to join us here on the stage. Ladies and gentlemen, this particular event is not just restricted for 2 days, but for all of us to take some memories, some learnings, to share it out to the world. So I want all of you to give a huge round of applause and welcome our beloved dignitaries as we're all set to release the book on the theme 7 Paths to Parenthood. I request team 7 Paths to Parenthood to kindly come forward with the book. Perfect. Wow. The first step taken by Newsfirst on creating awareness on paths to parenthood. It really, really matters. Thank you so much, team, for doing this. Can we all give a huge round of applause, ladies and gentlemen? Thank you so much, team. I request Dr. Devika Gunashila to kindly stay back to receive a memento, and I request Mr. Ravi Kumar to kindly give away the memento. Yes, absolutely.
I think it's working, right? Yeah, so I actually spoke to Mr. Vijay and Mr. Pradeep about this, from Vyli, about this 7 paths to parenthood. I think it's a wonderful initiative. It is to actually bring about a lot of awareness amongst the public, which is the need of the hour. Not everyone requires an IVF, not everyone requires an ICSI. Every patient who walks into the clinic just needs to be counseled, their emotions need to be calmed, their anxieties need to be brought down, and they need to be educated. And I think this is a wonderful job in looking at the various ways that people can approach their fertility problems, and it's a stepwise, logical presentation of the problems that people can have and their solutions. Congratulations, and great, it's a great initiative. Congratulations to you, sir. Thank you.
I request Mr. Ravi Kumar and Ashutosh Dwivedi, both of you, to kindly give away a memento to Dr. Devika Gunashila. And I request all of you to kindly give a huge round of applause. As you all know, we have been discussing about 7 paths to parenthood, which are: the first one, natural conception, assisted natural conception, alternative medicine therapies, medically assisted conception, in vitro fertilization, which is IVF, surrogacy, and adoption. And there are also ways of preserving parenthood, which is called egg freezing. So these are the topics which we are delving into since yesterday. And to all of you who are connected with us virtually, please don't forget to watch the entire episode which we had yesterday, and we are also going to have insightful discussions here at Gate 6, Palace Grounds, the Grand Castle. We also have exhibitors who have set up booths, and you can have interactions and get answers to all your queries. As the team is setting up the stage for the panel discussion, we will take a quick break of a couple of minutes for networking. We're going to get started with the next segment, which is going to be a panel discussion. We want to acknowledge our support system, our sponsors, exhibitors who have made this event, Path to Parenthood 2024, a memorable one for all of us, for the ones who are present in person and the ones who are watching us virtually. Path to Parenthood 2024, an initiative by Newsfirst, co-sponsored by Garbhagudi IVF Center, supported by the Ministry of Health and Family Welfare, Government of Karnataka, organized by Brand First, our knowledge partner, Vyli Health. All right. I have a question for all of you, if you are with me. We are talking about fertility treatment outcomes, right? There are several aspects attached to the fertility treatment outcomes. And do you also know that emotional stress also plays a prominent role in the fertility treatment outcomes? Yes, the upcoming discussion that we're going to have is going to be crucial to understand the emotional side of the fertility journey. So let us delve into the panel discussion on navigating the emotional challenges of infertility. We are excited to have a distinguished group of experts with us today. The panel discussion is going to start in the next 2 minutes. So I want all of you to quickly finish your bio break and settle down. For we are going to discuss about the topic, navigating the emotional challenges of infertility. Thank you. Welcome back, everyone. It's time for a panel discussion on navigating the emotional challenges of infertility. We have distinguished group of experts with us today. First and foremost, let me welcome Dr. from Aster CMI Hospital. A warm welcome to you, ma'am, onto the stage. Can we all give a huge round of applause and welcome Dr. Sushma Gopalan, ladies and gentlemen. I also welcome Dr. Archana Karthik from Womb Care Fertility and Research Center onto the stage. Can we all welcome Dr. Archana Karthik? We also have a warm welcome to you, ma'am. We also welcome Dr. Rashmi Yogesh from Kushi Fertility. A warm welcome to you, ma'am, onto the stage. And to moderate this session, we have with us senior journalist Ms. Archana Ravikumar. Let us all put our hands together and welcome Ms. Archana Ravikumar for moderating this session. Over to you, panel and moderator.
Okay, no? Hello. Hello. Good morning, all of you.
Very good morning.
Good morning. To start with, actually, fertility itself is kind of a nightmare. I was just talking to some unmarried people here. They already feel fertility. If they have fertility problems, it can be difficult. So it can be, we can just imagine the plight of couple who already have fertility problems. I'm sure it must be a nightmare through them.
Sure. I feel infertility is like a hidden story, and a lot of times women don't want to disclose either to their parents or their family what they're actually going through. And when women face problems, it gets very difficult because they start placing themselves too low in their own eyes and in the place of their family. At the same time, when men have problems, I think they also go through equal emotional challenges, but unfortunately, men are not really attended to. So I feel it's a couple problem, and both husband and wife go through a lot of emotional challenges. It's a very, very turmoiling journey of emotions, and psychological aspect of dealing with fertility, I think, is the first and foremost thing that has to be addressed.
Yes, true, doctor. Actually, navigating through emotional journey, challenges is the biggest thing for now.
True.
Let's begin with Dr. Archana. So what are the kind of face as a couple when they come over to you? How do you actually go through the treatment with such couple?
See,
As soon as they see that they are infertile or they are not able to conceive, we don't say them infertile, but fertility is a problem with them. So when they come to a hospital, before itself they'll be worried about what may be the reason and whether it will be treatable or not treatable. First, as soon as they come from reception till my consultation room, everybody should be very friendly to them, because they are already into kind of anxiety, and some people might have already gone through so many treatments or they would have come to us. So give a hope from there itself, and once they walk into your chamber or your consultation room, you should just read their mind. Where are they? Are they into like open up with all the kind of treatment or whatever you're counseling, and where is their situation now? They have gone through, do they have any knowledge about fertility and what is required and all that? Based on that, you should always counsel them that whatever is the issue, we'll tackle. Initially, you should give them little hope and then start with their counseling and history taking. When you take, it's not just a history taking which is related to menstruation or fertility issues. It's about how pressurized they are about their fertility, how many years of infertility they are going through. So based on that, you should always plan their fertility treatment, their investigations, and everything should start with counseling them about the normal physiology of menstruation, physiology of fertility, and then make their things clear. Like whatever the fertility issues they have, we have a kind of treatment or we can help them at each stage. So that's how we start with counseling and the treatment after realizing their mental status.
Dr. Rashmi, yours is Kushi fertility treatment.
Yeah.
So ಈಗ ಎಮೋಷನಲ್ ಬ್ಯಾಗೇಜ್ ಇಟ್ಕೊಂಡು ಬರ್ತಾರೆ, ಖುಷಿಯಾಗಿ ಹೇಗೆ ಹೋಗ್ತಾರೆ ನಿಮ್ಮ ಫರ್ಟಿಲಿಟಿ ಸೆಂಟರ್?
See,
ಹೇಗೆ ಅಡ್ರೆಸ್ ಮಾಡ್ತಾರೆ?
what I feel is it's a journey from pain to happiness. And that's why I think it's all about that word khushi and happiness in their lives for which they strive. And I've heard some people telling me, I've interacted with men who have told, Doctor, I've achieved so much in my life, I've grown so much in my career, but then if I don't have a child, it's like my life is zero. When a man tells like that, it really hurts. And women, their tears are most of the times not attended to by family members, unfortunately, despite education being so high in certain families, and that is something that really pinches me. And the most important thing when it comes to fertility is that fertility treatment or the journey of fertility is that there has to be a lot of understanding between the lady and the man in her life. And I see the wrinkles around her eyes, the happiness that she shows, all these things are related to the kind of man she has in her life. In case she doesn't get that kind of support from her husband, then she starts feeling very lonely, and that's the most difficult journey for a lady. If her husband is somebody who can understand what pain she's going through and says, don't worry, even if you don't have a child, let's be a child to each other, that sentence will make her really strong. So I feel despite all the support we give, it is the husband who plays a very important role in the entire journey, and the lady should be made to feel that what is more important is companionship between husband and wife and not just having a child. So I feel the most important thing is to understand the kind of relationship you are dealing with. If you have a couple who has come to you for the treatment of fertility, the first thing I do in Kushi is try to understand what is the kind of relationship the husband and wife are sharing. And if I feel there is a trouble there, I try to address that before starting the fertility treatment. And I feel that's the most important, the crucial crux point in the treatment.
Dr. Sushma, as a psychologist, how does infertility affect mental health?
For example, if I tell right now, ladies and gentlemen, for the next half an hour, don't think about an elephant. Trust me, for the next half an hour, the only thing that you will try your best is you will be thinking about an elephant. The word don't will not be registered in the mind, only elephant will be registered. So the same thing happens when we tell them, don't worry, don't do this. What happens is the don't is taken away and the worry takes over, because they feel that's the most important thing. Like you mentioned sometime back, even unmarried women, girls and men, boys are thinking, okay, do I have an issue? So it's already set in that, okay, there is going to be a problem. So what is supposed to be a normal journey, what is supposed to be a part of the journey becomes an entire journey in itself. And that focus is what leads to a lot of emotional turmoil. For example, marriage and the life of a husband and wife is a huge journey. It's a huge thing where parenthood is also a very important part of it. So when there's so much focus on this, right from the time they get married, what happens is, for example, the natural mode gets hampered. So what is supposed to be a very, a divine process, a very smooth process, becomes so stressful, and emotionally there's so much of baggage attached that it becomes a goal-oriented process. Every month, yes, every month there is like lot of, they check, and it removes the essence from the entire this thing. So that negative emotion is something that we should not be fostering. So that is what happens when they come to the gynecologist also. I think most of the gynecologists also tell them, and then they are also sent to us so that we can also counsel them and talk to them and understand what is the mental frame that they are in currently.
Yeah, as soon as they come to us, they'll ask us, Nana, lane problem illa alva. After you explain so many things, they'll say, problem illa alva, doctor, 100% agatte alva. This 100% scares a doctor also. And we should counsel them that everything is just a try. We can't assure 100% that even at IVF, even in IVF where the embryos are beautiful, lining is very good, we can't assure 100% results there. So we should prepare them mentally for positive, negative, both the things. And even the treatment line also we should plan based on their emotions also. We can't directly say an IVF for a person who is totally stressed. We have to give some simple treatments and prepare them mentally, even though we know they are not the candidates for IUI or simple treatments, but still we should read their mind and plan their treatment.
Yeah, completely agreed. I'm sorry, because energy matters a lot. See, when you come in thinking that do I have a problem, the only thing they want to hear is no, there's no problem with you, it will happen the next month. Which is not going to happen. So they need to come with an energy that, okay, let me see what next. So that patience is something that is required at that time, and that's the hardest to have at that moment, because you want an instant gratification, which is not going to happen. So very, very important for couples who are into the fertility treatment is to have a mental framework which is strong. I'm not saying full positive where you know things are going to work out. What I'm saying is to have the strength and stamina to know that whatever happens, I'm sure there is a next step to it. It is not the be all and end all of everything.
Correct. Dr. Archana, many people like infertility, actually treatments. How do you address such couple? Repeated failure adaga, how do you address them?
See, my counseling starts even before the treatment starts. So I prepare them mentally when I start the treatment itself. When take it for an IUI or IVF, I'll tell them what is the success rate in each. If it is IUI, I'll say maximum based on individualized success rate. 15 to maximum is 20% in an IUI. So I'll tell them, for you I can give this much of success rate. And what is the drawback in IUI? It's a semi-natural procedure. We can't see the egg quality. We don't know what is the egg quality. What we see is only the fluid around the egg. So I can't comment 100% your egg quality is very good. Some people think, oh, egg release ಆಯಿತು, ನನ್ನ egg ತುಂಬ ಚೆನ್ನಾಗಿತ್ತು ಡಾಕ್ಟರ್, ಎಲ್ಲ ಚೆನ್ನಾಗಿತ್ತು, ಬಟ್ ಯಾಕೋ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗಲಿಲ್ಲ. ಡಾಕ್ಟರ್ ಹೇಳಿದರು ಎಲ್ಲ ಚೆನ್ನಾಗಿದೆ, egg ಅಂತೂ ತುಂಬ ಚೆನ್ನಾಗಿದೆ. Then I'll counsel them from there itself. And even when they do an HSG or tubal patency test, we don't know the function of the tube as such. We know whether it's blocked or unblocked. We can make out grossly whether it is healthy or unhealthy, but really whether it is functioning well, we don't know. Even the unblocked tubes in given ectopic pregnancy, or they may not even function well. Avaga, our counseling makes an effort there that they should not have too much of hopes for positive results also, and that doesn't mean that they should not have hopes at all. So I'll counsel them in such a way that they'll be able to take negatives also. As you said, repeated negatives is very difficult to treat. There we need Sushma, because that counseling is little on a higher side of counseling, where their emotions are taken care of. And as madam said, husband should be very supportive. First thing is husband, then comes the in-laws. If they repeatedly ask them, oh, hereditary negative, ninde no problem, though it is male or female, we should not point out whose problem it is. Then they can take the results in a positive way. Whether it is negative or positive, we have to try. It's only the try from their side and our side. Nobody can give 100% results. That they should be mentally prepared, which we start even before their treatment. Once it is negative, I'll tell them, okay, it is negative. You want to take a break for a month, you take it. Relax, but don't leave the try. In that month also, naturally you try. In that break, so many people conceive because they don't have the pressure of treatment and to come for a scan or timed intercourse. When you say timed intercourse, it's very difficult for them because emotions are involved there. That becomes a more stressful act rather than the treatment itself. So their patients will relax. So in between, always give a break for them once it is negative. Don't do a back-to-back treatment. And counseling from beginning is very important. That's how we tackle patients. And I always ask husband, this is the place where you have to support, and your in-laws also to support her, because she is taking so many treatments. It's only a sperm which is given to the patient, but pregnancy or the injections or whatever the medicine she is taking already. So she's already under emotions. So you have to support. Family and friends are very much important there.
So basically, family is a support tank. Dr. Rashmi, a long-term on the couple, how do you address them emotionally?
See, long-term procedures in the sense, I think you're talking about segmental IVF, where most of the times we do an ovum pickup and we are not able to do the embryo transfer immediately. A lot of people come with the concept that the moment they come for treatment, then within a month IVF will be done and they'll get pregnant the same month. So it takes a lot to make them understand that not every woman who goes through an IVF will have her embryo transfer done in the same month. So we'll have to do ovum pickup, then wait for the endometrial lining of the uterus to come up properly, and only then we do the embryo transfer. Some of them do have challenges with the lining of the uterus coming up, and they take about 2 months, 3 months, even more, and they'll have to go through procedures.
Sorry to interrupt, but generally what is the time frame?
Usually, suppose the ovum pickup is done in the month of Jan, then either Feb or March they can go through the transfer if everything goes on well, and if we are planning for a frozen transfer or not a fresh. And depending on the situations, we decide whether we do a fresh or a frozen transfer. And as you said, sometimes the treatment goes on prolonged. Now the burning issue in today's generation is women who have reduced ovarian reserve. For instance, today morning I did ovum pickup on a lady who had absolutely no follicles in her ovaries, and then after some medications and of course after doing the intra-ovarian platelet-rich plasma therapy, she had a follicle propping up. And today when I did her ovum pickup, the moment she woke up and I told her we retrieved one oocyte, she started almost jumping on the bed, and she was so much excited that she's got one oocyte. Just imagine the kind of anticipation with which they come, and they're just waiting for that one oocyte to come out of them. So this reduced ovarian reserve has become a very big thing, and with women not trying for pregnancy early, it's a very difficult thing for us when we see patients. They delay their pregnancy so much. I see some couples married for 6 years, 7 years, and they would have started trying, say, past 6 months, 7 months. When I ask them, why is that you waited for 5 years to start trying for pregnancy, and that too when you're married beyond 30 years? Surprisingly, 50% of them answer, we wanted to be sure that we're going to stay together. And that is something that is valid, isn't it? So that is the trend now. They want to be sure that they're going to stay together, only then start trying for pregnancy. And when they start trying for pregnancy, the worst part is some of them actually tell us, we wanted to be well settled in life before we start trying for pregnancy. And you know what is the definition of settled for these couples? Getting a house and buying a vehicle or a four-wheeler is what is called settled.
So that they can take their baby
back. I tell them, see, you were waiting for your bank balance to go up. And what happened eventually? Your bank balance went up, but your ovarian reserve and your egg balance came down. So you'll have to strike a balance and decide when to start trying for pregnancy. I think in the yesteryears, the moment you get married, it was that, oh, I'm got married, now the next thing is I should have a child. But that's not the thing now. Women are focused, they want to be financially independent, and they want to be sure that they have the right partner in their life, and only then they want to start trying for pregnancy. With all of these, trying for pregnancy is something that is happening after a few years of marriage, and the ovarian reserve is drastically coming down, and there are a lot of autoimmune problems, and post-COVID, a lot of autoimmune problems are propping up, because of which the ovarian reserve is actually coming down, and that's adding to the infertility rates. You know, the incidence of CA breast all over the world is 1 in 9, but the incidence of infertility or subfertility, what we should say, is about 1 in 6. So I think everywhere, in every house, in every family, there will be somebody who is either an inmate of the family or somebody whom they closely know who is dealing with this problem and is not exposed. So I really feel addressing infertility despite the population explosion is a very, very important aspect.
Dr. Sushma, actually grief and loss is quite common in infertility. How do you address such people?
Any emotion, generally when they come out of a gynecologist's office, talking to them at that moment will not help, because the emotions are so high that they will not be in a position to listen or talk. So we have to give them that space to settle down. So generally what happens is they need to be directed to come back after some time to talk. Because in most of the cases what happens is the need to talk to someone is so high, but they don't have someone whom they can share. For example, the spouse also might be under, a lot of emotional turmoil, so they don't know who to talk to. Sometimes the family will not be capable of handling such situations due to so many challenges even they are facing. Probably they're not able to support in the way that they can. So what we always tell them is once they go through this phase where there is loss, there is trauma, there is grief, there's always a chance for them to come back and talk to us. We always counsel them. Generally what happens is a clinical assessment can be done, but it will show up a high amount of depression and grief. So what happens is we enter into therapy where we talk to them, counsel them, and the most important thing that is most underrated nowadays is communication with comprehension. They need someone they can talk to who is there to listen with no judgment, not giving them solution or advice. They just want someone to talk to and tell them that it's okay, it's fine, let's go to the next step. Not that yes, it's going to happen or it's not going to happen. Just that I'm here for you, I'm here to listen. Download all your negatives to us so that you go back empty so that you can fill it in with something positive. And in many cases what happens is we come from a culture where there's a lot of family involvement. So it is not just the husband and wife's journey. I have had cases where the in-laws have come for separate counseling because they are not able to take it. They don't know what to do. So the emotion is always cascaded to somebody else. So I'm not happy, I'll give it to you. You're not happy, you give it to somebody else. The pattern keeps rotating until someone is able to hold it and say, you know what, we'll just keep it down. That's where we come into picture. So talk therapy and various kind of therapies are given so that couples find that space to download their emotions and also the family. In many cases, there are family therapies involved where we connect to everybody in the family. And we talk to all of them so that there is a balance and emotional settlement that happens over there. Because all of us come with different baggages and each family is not the same. Whatever the wife is going through, husband is going through, it differs from case to case. So we have to give them the time and patience.
Patients, they think as soon as you reveal what is the cause for infertility, you should be very careful. It's a sensitive thing. See, whether you say it is oligospermia or something to do with the sperm quality, then maybe the female start blaming husband because of you have to go through so much. So even if it is a small issue with a female, we should always point out that also, though you not highlight it, but you should always say both the problems. Whatever the small issue with the other partner also should be highlighted, and once it is revealed, you should say that they start thinking, why me? ನನಗೆ ಯಾಕೆ ಬಂತು ಡಾಕ್ಟರ್, ನಮ್ಮ ಫ್ಯಾಮಿಲಿಲಿ ಯಾರಿಗೂ ಇಲ್ಲ, ನನಗೆ ಏನಕ್ಕೆ ಆಗ್ತಿದೆ ಇದು ಏನು? Then you should tell them it's not that you have to think about, you should just think what to do next. That is where is the solution. It's not that thinking, ಅಯ್ಯೋ ನನಗೆ ಹಿಂಗೆ ಆಗೋಯ್ತು, ನನಗೇನಕ್ಕೆ ಆಯಿತು, ನನಗಿಲ್ವಾ ಪ್ರಾಬ್ಲಮ್, ಯಾರಿಗೂ ಇಲ್ಲದೆ ಇರೋದು ನನಗೆ ಬಂತು, ಅವರಿಗೆ ಆಗೋಯ್ತು 30 ಇಯರ್ಸಿಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಯಿತು, ನಮ್ಗೆ 40 ಆದರೂ ಆಗ್ತಿಲ್ಲ, ಅವ್ರಿಗೆ 42 ಆಯಿತು, ನನಗೆ 40 ಆದರೂ ಆಗ್ತಾಯಿಲ್ಲ. These comparisons should not be there. We should always tell them each individual is different. Counseling is too much. I spend almost 30-35 minutes, ma'am knows. We spend so much on counseling rather than on treatment. Treatment is hardly for 5 minutes, but what we talk to them is very important to take the results. As we know, results are not 100%.
Yeah, that's why I think emotionally they should be very well prepared before the treatments actually. And how do you actually address people who are like, for instance, like how do you address stress first thing when the couple come to you? If they're really stressful, how does it actually hinder your process in fertility treatments?
Of course, stress has a lot of effect on a fertility treatment. It may, as we say, adrenals and the hormones, the stress hormones have a negative effect on implantation also. That's why we always say don't ever think about the results, and I usually tell them don't quit your job. When they quit their job, their only stress is pregnancy and its results. When they are into job or some other things, if they engage into, their stress is divided, it's not concentrated on one thing, so that they'll not think about too much about the results. So that stress about the results, especially after an IVF, 2 days prior to their blood test, there's so much stress that they can't sleep also. That effect is on a negative side. Even if it is going to implant, it may not allow it to implant because of those hormones. Sushma always says happy hormones. That should be inculcated by counseling, and we should tell them always engage into some music or anything that which diverts their attention towards. And even the couple should be, even husband should be counseling her each and every day that it's okay, whatever the results is, we'll see what to do next. That's how the stress should be managed about the results when I say.
Dr. Rashmi, as you rightly pointed, fertility, the people want to be well settled before they actually go into fertility treatments. Despite that, it is still expensive. Fertility treatments are expensive, as we know. And that is also adds to the stress already. You know, like all the financial stresses adds up more. How do you address such couple?
Yeah, we see that not everybody conceives in the first IVF cycle, and people will have to go through repeated cycles sometimes. That is something which is very difficult on their pockets, especially you see people who are in that age range where they are between the age of 25 to 35 or 40, and that is the time during which they are actually building up their career, trying to pile up some money. Despite having in-laws and parents, they really don't want to be financially dependent on them. So it gets very difficult for them. However, we in the field of fertility have different ways to help them out. Nowadays, insurance also covers for fertility. I think we should push more our insurance companies to try and realize that infertility is not an inborn problem, and it is something which is lifestyle related. When you can cover for surgeries, when you can cover for things that come up in life later, why not for fertility and infertility? Right. They should be covering. I think that is something that will bring down the financial burden and the emotional aspect of the financial burden to a very great extent. At the same time, what we also see is that apart from the financial aspect, there are a lot of other aspects women actually face. They start feeling, I've spoken to women who have told me that sometimes, doctor, when I'm unable to conceive despite repeated embryo transfers, when I look at myself in the mirror, despite being the most beautiful woman in my surroundings and also in my family, I feel I'm not a woman anymore because I'm not able to conceive and give birth to a child. When we hear such statements from women, it really hurts us. And I've also heard some women who have opened up and told me, doctor, when the entire world can conceive with pleasure, why should I conceive with pain? These are certain statements which actually make us feel that they are the people who have to be taken care of, and we as fertility specialists, though the psychologists play a very important role, and sometimes with our kind of work we may not be able to give them that time. When we hear people are in real distress, taking them close to the psychologist is the most crucial task we have to do. So I think it's between the embryologist, fertility specialist, the husband and the psychologist that a lady's circle for this journey is completed. And I think the right panel of people are here.
Yes, Dr. Sushma, actually it is more like parental pressure, societal pressure that the couple undergo. How do you advise such people?
Actually, I would like to add to what Dr. Rashmi made a very important point, because what happens is we take it very personally. See, we all have certain characteristics for a man and a woman. For a man, it's the number of children he sires. For a woman also, her womanly femininity is basically in the number of children she has. So we all keep allocated time also nowadays. They say, okay, after I'm settled, I'll do this. When that doesn't happen, it's a very big question mark in their entire identity. So they feel there's a loss of identity. And when there's a question mark on identity, the self-esteem, the confidence, self-worth, everything comes crashing down. And the entire soul and whole focus is only on getting the child. Now it's more than the child, it's more like a this thing for oneself, where I know I want to prove that yes, I am worthy of it. So when that sets in, that becomes the entire goal, whole, everything. And some of them come with a lot of trauma in life. They have gone through a very difficult childhood and they feel, okay, now it's time for me to enjoy life. And when this also doesn't happen, they take it very personally. I have done something wrong. God is punishing me, or okay, I'm not worthy of it. So there's so many things that is connecting. So psychologically what we do is we go through their entire lifespan to see where they have come now and exactly why, what are they feeling now. That takes quite some time for us. It doesn't happen in one session. So the gynecologists play a very huge role because they pick up these red flags. The way the mother or the father, the wife or the husband is taking this news, the minute they feel something is not right, then they let us know so that they come and talk to us. In many cases, even if everything seems fine, just to have a check if everything is going on okay or not also, then sometimes the reference comes. And when once we start, we come from the childhood thinking what happened through the marriage, everything, and then we look at them as an individual, the husband individually, the wife individually, and then them as a couple, and then we take them through the journey. And no matter what is said and done, the unit in this journey is the husband and wife. That is the first circle. The second circle is all the other family members, and the last is the society. So that's how the counseling
But
goes.
I think society becomes more important these days.
A lot. When they become the first circle, that's where all the problems start. See, we always wonder, what will people think? People will get to know we are struggling. People will feel that we are not doing good. There's so many things associated with what people will think. I don't know who those 4 people are, but we're always worried about the 4 people who are going to talk about us. So somewhere the husband and wife have to know that it is only them both.
That's
And
what
then-
I always tell them, don't answer anybody. If they
Yes.
ask you, just say, yes, I'm under treatment or we are
It's
trying.
going
That's
on.
enough. Don't
Yes.
discuss anything in detail.
Exactly.
They start discussing, the depth is more.
Depth is more, and you never know what's happening behind you. What is the
Correct.
conversation? What's happening? So keep it.
Society mindset has to change because once they're married, everybody asks them when is the good news
Yes.
coming
They
in.
stop going to marriages and functions. They
Exactly.
think everybody
Right.
will ask, will not. I say, you go, you attend, you have to mingle with people, but don't answer too much of questions. You just say, yes, we are trying. We'll see when it happens. That's how we should answer. We should not
Yeah.
take everything to our head.
And
And
it's
that
just not
answer-
talking to each other when they meet in social occasions. Now you see any social media, you see Facebook, Instagram, everything is announced. Your wedding, the pregnancy test getting positive, the first scan, the first heartbeat scan, everything is shared. And just imagine when your close friend gets pregnant, they would have done everything at the same time, and when you see your close friend getting pregnant and when she's still trying, that adds to the trauma. I think this peer pressure has come in. The
Social media pressure has to be added up to
peer
the
pressure
list
to
now.
get pregnant. I think there are a lot of social issues because of the social media also.
True, doctor.
Agreed. And just to add, if you want to answer someone also, first you need to be grounded. If you need to answer somebody and give them that, okay, you know what, everything's going fine, you need to believe in it. And that's where, you know, that mental strength becomes so important, where you know that, you know what, right now I'm okay, we'll look at the next step, we'll see what happens next. Let's not think too much beyond, and you know, and then answer them. So that grounding becomes very important.
Dr. Archana, for couple who are actually exhausted completely with these treatments and all, what are the strategies you offer emotionally and physically to them?
I usually counsel myself first, and I connect them to a patient who is positive so that they'll know what is their journey. That positive may not be immediate. They might have struggled for 2 years of negatives, and then so many things, so many treatment strategies have been implemented on them, and then last will be positive result. So there are a couple who have tried for 3 years, 3 cycles. I have seen a couple who is a dentist. She did her IVF for 9 times. I stopped her. I told her enough now. 5th cycle is enough. But she went to somebody else. Now 9th cycle she has conceived. That means imagine her mental stability. So basically they should prepare themselves, and our counseling definitely, and when they speak to other couple who is negative, who is positive, they should be connected to both of them so that they'll know how to take a negative also, and the positive is not very easy. They'll know both so that they'll not stop there. They may try, and even if they want to stop, they'll be determined to stop there. So that counseling is very important, and connecting to people is the strategy what I use usually.
Dr. Rashmi, how do you help the couple navigate through the ups and downs of fertility?
See, when it is up and down, dealing with up is very easy because it is all about celebration, and then you all feel happy that there's pregnancy. The downside of IVF treatment is what happens to them after it is negative. The day they are waiting for the beta HCG report is probably the most difficult day in any lady's life. The moment she gets the beta HCG report, and if it is negative, there is such a gloom in her life that she cannot even explain in words. And what happens to her at that point is the most important thing. The counselors have to play a very important role by talking to them one day prior to the beta HCG report and prep her up to face both the ups and downs. At the same time, I would suggest her to be very positive in her approach, and how much ever we tell, it could be positive or negative, but there's so much of anticipation that builds up with the treatment. Even when they try naturally, there is anticipation. Then just imagine when they go through an IVF, the kind of anticipation that is there in their minds. A beta HCG negative, the downside of IVF, difficult day in a lady's life, and it has to be dealt with very, very sensitively, and the husband has to be there with her when she gets the report is something that I specify every lady, that the day the beta HCG report comes, ensure that she's not alone and there's somebody next to her to hold her hands and say, it's okay. that makes a lot of difference. And what I also see is that when women are going through repeated IVF cycles and it is failure, and then ultimately when we have to talk to them something like, if we have to suggest something like a donor egg or a surrogacy, that's the most sensitive part for a lady, to be able to accept somebody else's egg and then have a child. So these are things that are the downside of IVF, and having an IVF child is not abnormal, is something that has to be posed to the entire society. There's nothing wrong in telling the world that I have had a child with an IVF. There's nothing wrong. And now the generation has changed so much. People don't mind wearing Western dresses. People don't mind going to a place where they can have both vegetarian, non-vegetarian food, a place where they can wine and dine. When everything is accepted, why not have a child through an IVF when it is possible? So I think hiding the fact that the child is born through an IVF is something that has to go out of people's mind, and people have to understand that an IVF child is not different from a child who is born naturally, and that is something which I feel all fertility specialists should come out and tell, and also make people realize that they should understand where they stand when they get married, to understand if they can really postpone their pregnancy. That's why we've been propagating, please check your fertility score, check your AMH, and then decide whether it is conception or contraception.
I think as it's better said, IVF, they think it is something, a big thing they have done. It's like cancer treatment. Though it's not like that. For some couple, we have to give IVF as a first line of treatment, and that will give more success for them if we do it at an earlier stage instead of trying a smaller ones which will not help them much. So they should be prepared mentally, and they're so hesitant to say they are going through an IVF. That's why they don't even walk into an IVF center. They go to a general gynecologist. They think IVF they won't do. They won't try an IVF. It's not like that. They should be educated that sometimes that is a first line of treatment for you.
I think when they register the wedding, they should have a fertility test. That should become mandatory. It's a better possibility. Dr. Sushma, when is it the right time to seek help for a psychologist?
Generally, usually we start with marital counseling itself. So before marriage itself,
with the registration psychologist.
Yes, we need to tell them, because sometimes, like ma'am said, it takes a long time. They want to settle down and also get your priorities set. Okay, so sometimes that marital counseling helps, and after that when they come to
sorry to interrupt, I think we should make a psychological counseling as a package with pre-wedding shoot.
Yes, that goes.
Wedding
that
package.
Helps because
we spend so much for pre-wedding shoot. I think a psychological counseling should be added,
I think
as a compliment.
Psychological consultation makes some, yes, completely agree. And also when they come to the gynecologist visit for the first time, probably if there are any issues, anything like that, it makes a lot of difference if they can come talk to us, and at least let them know that we are available to help them. We are there to listen to them, and they can reach out. And the one thing about the counseling is it's going to be confidential, so they can rest assured that trust can be built in this, and they don't have to worry about things going out. So that is one thing that can be, so it has to be part of the entire treatment.
In brief, Dr. Archana, what is your advice to people who are watching this?
Don't get scared whatever it is. Walk to your doctor. Initially, get the knowledge from Google, but Google is not everything. You have to speak to your doctor, open up whatever is the emotional problem with you, and couples should come together whenever there is a treatment. That's how we can support each other.
Dr. Rashmi, your piece of advice?
My piece of advice would be, yes, as I told you earlier, check your fertility score, understand where you stand in your fertility score, check your AMH and then decide. Don't ever think of discontinuing the first pregnancy. My advice to every married couple would be, welcome the first pregnancy, and think whether you can actually take contraception before you actually start doing it. And first trimester abortion for an unwanted pregnancy, when it is the first one, is something that I would say a total no, and would always advise them to welcome the first pregnancy. Apart from that, another very important piece of advice to every couple who is going through the entire fertility journey is the three important things. One is confidence in yourself. Second is trust in the doctor who is treating you. And third, and the most, faith in God. I think these three things are the most important factors that will let any lady fight through anything that she is going through in life.
Yes, Doctor, right. Dr. Sushma, your last piece of advice.
only one thing, it's not a lonely journey. It needn't be a lonely journey. There are people to help, there are people to hold your hand, there are people to just sit with you if you don't want to talk also. It is just that you need to find the right people. So please don't travel in this journey all alone. Please reach out to people who are there to help you so that at least the path becomes a bit bearable.
So I think it's when we've accepted all lifestyle diseases, fertility is also a lifestyle disease and all of us have to accept it. I think people should accept it that way. Thank you so much for being on the panel.
Thank you.
Thank
Thank
you
you
so
so
much.
much. Thank you.
Wow. Thank you so much, doctors. I think folks who are dealing with challenges in infertility, the way they should seek help and how people around them should be a support system. Very well explained. Thank you so much to the panel and the moderators. Can we all give a huge round of applause? I request Mr. Maruti SH, Editor-in-Chief, Newsfirst, to kindly come forward to give away the mementos. I want all of you to give a huge round of applause, for this was an insightful topic, really, really insightful. And parallelly, I'll give you a quick exercise and explain it to you what is it. I want all of you to fake a smile. Can everybody smile like this for 20 seconds, everyone? Yeah. All right. Thank you so much, Dr. Sushma Gopalan from Aster CMI Hospital. Thank you so much. Can we all give a huge round of applause? Dr. Archana Karthik from Womb Care Fertility and Research Center. Dr. Rashmi Yogesh from Kushi Fertility. Ms. Archana Ravikumar, Senior Journalist, thank you so much for moderating this session so well. I request all of you to give a huge round of applause. Thank you so much, team. Well, let me get back to the exercise that we were just talking about. Are you with me, everybody? Are you all with me? Perfect. So all of you, just smile for 20 seconds. I'm asking you all to fake a smile, and then I'll explain why. All right? 1, 2, 3, smile. The ones who are watching us virtually on YouTube, please do this exercise with me. Go. All right. Now you can relax. Now just look at your state of mind. There's something called the facial feedback hypothesis, which says that the act of smiling, even when forced, it can actually send signals to the brains and it releases endorphins, which actually changes your state of mind to a certain extent. Please give a huge round of applause if you could feel a small difference in your mood. Yes or no? Perfect. Thank you so much. Well, it's time for us to move on to our next segment, which is going to be a panel discussion on the essential diagnostics for the parenthood journey. Joining with us are Dr. Prakrita and Dr. Giriraja Velayudham. Both experts are from Aster CMI Hospital. Can we all give a huge round of applause and welcome our panelists onto the dais. A warm welcome to you, doctors. Ladies and gentlemen, a huge round of applause for Dr. Prakrita and Dr. Giriraja Velayudham, both experts from Aster CMI Hospital. Warm welcome. We also welcome Dr. Sushma onto the stage. Please welcome Dr. Sushma Gopalan from Aster CMI Hospital. And to moderate this session, we have Dr. Soumya Lakshmi, consultant in obstetrics and gynecology. Can we all give a huge round of applause and welcome the panel and the moderator? Over to you, team.
Good morning. Are we audible?
Not much, ma'am.
Yes, I think, yeah, are we audible is what she's asking. Yes?
Good morning, everyone. So we are here for a panel discussion on essential diagnostics for a successful parental journey. I think we've had a very comprehensive panel discussion earlier, which makes our job actually very easy. So that was like a big YouTube video, and we'll do this like a shorts. This will be short and crispy. So my first question, Prakrita, to you. What do you think are the essential steps that you would recommend for an infertile couple who comes in?
So it's very important to understand that when a couple is going through their fertility journey, what infertility means or what subfertility means. So a couple starts planning for a pregnancy and they say, okay, let's start trying for a pregnancy. I think it's in common sense that everybody knows that it's not that the very first cycle they go through a successful pregnancy, right, or a successful conception. So it's very important to understand that when a couple starts trying, every month the success is around 10 to 15%, considering that all other parameters are normal. So this is something that holds good to people who have had evaluation, also for those who have not had evaluation. Of course, if there are some issues with some parameters, if there's a problem with the gametes like the egg or the sperm or any other issues, the success rates naturally come down, right? So this understanding is very important. So here we tell the couple that, okay, since every month it's hardly about 10%, hence you try for at least a couple of months, maybe 6 months, depending upon their age, or 12 months or 18 months, after which, of course, if it's not working out, then you reach out to us, right? But it is very important in today's world because of the lot of lifestyle issues, and there are a lot of stress factors being played around, and the burden of infertility is increasing day by day. So very basic things like maybe getting your ovarian reserve testing, that would be probably getting just to know how many follicles are there on your baseline scan. So that is something we call it as a antral follicular scan. It's an imaging test. It's an ultrasound scan which we do on second or third day of the menstrual cycle, just to roughly get an idea as to how good the egg reserve is. Apart from that, there are other blood tests. Again, this is the AMH which has been previously discussed as well. So AMH also indirectly tells us about the quality and directly tells us about the quantity of the eggs. Now this is one of the very important tests which gives us a timeline to work on. So if the AMH is normal, the reserve is good, that means we have a good timeline where we can try with a few cycles where they can probably try naturally, considering that the other factors are good. For the man, of course, it's very important about his gametes as well, the sperm evaluation or the semen analysis. So the semen analysis is a very basic routine testing that is done. So many of the couples just take a step back here because the woman is ready to get tested, all the blood tests, all the imaging, but then ma'am, you get all this done, then we'll see. So it is not that we get all the tests for the women done and then we go ahead with the men. It is always combined testing. So combined testing is very important. It's the couple who has to be evaluated. It's both the man and the woman. It's the husband and the wife. Because if there's any issue in one of either of these which have been overlooked, there is no point of any number of treatments or any number of cycles going ahead. So basic semen analysis and an ovarian reserve testing gives us a lot of information about it. Apart from this, there are supportive blood tests, like probably your hormones like thyroid, prolactin. So these are all going to indirectly affect your fertility potential. If this is corrected, again your fertility potential may increase. So these are supportive blood tests which have to be done for both the husband and the wife.
So in our OPD also, we see a lot of young couples come in, 21 years, 23 years, married 3-4 months back, already they're under pressure to have a baby. And also like sometimes what happens is they're 35 but they're still not ready for a pregnancy. So does age really, do you think age is a factor?
Yes. Age is a very important factor. So of course everybody is aware of something called as a biological clock, and the clock starts ticking after the age of 30 and all these things, right? But age is very important in terms of the quality of your gametes. Age is the most single independent important factor in determining the quality of the egg and the quality of the sperm.
Just to excuse you, age of both partners are important? Or?
Age of both partners are important. Of course, the cutoff is much higher for men. So in men, after the age of 45, the quality is evidently decreasing. Of course, the DNA integrity does get hampered, right? So for the sperm to get selected in a natural way, when the couple is seeking out for a natural conception, it is very important that for a natural selection, the sperm quality has to be a top-notch one. If the sperm is good, only then it's going to get selected, because the survival is the one which is going to be the fittest that is going to survive, right? So what is the best that is going to be chosen. So age is a very important factor. And I want to make a point here, because most of our literature, right, medical literature, everything states it as 40. Right? So if you see in Western countries, in UK or US, they start evaluating a woman at the age of 40, or after the age of 40, they see that they're still trying to conceive naturally. But in our country, everybody pounces upon an IVF. No, it's not like that. So it is evident, there is evidence that women, especially the Asian ethnicity, the Southeast Asian ethnicity, we age prematurely. We age 6 years prematurely. There are multiple papers on this in journals as well. So what is 40 for them is something at 35 or 36 for us. So we need our bell rings early. So we need to be more proactive. You don't have to undergo multiple treatments for it, but just evaluate yourself and know what the timeline is. That is very important. So if something is recommended at the age of 40 or 42, that may be as well recommended here in our country at the age of 34 or 33. That is very important in understanding that why you are undergoing these many tests. So many people have this thing in their mind that, okay, the moment we reach a fertility center, they'll give a huge list of tests, and we are just going through all of it. So it is not that there's a huge list or something. So this is just the basic things that we get to know, and based on this, the further plan is made. So it is also important to understand that this doesn't happen just in one night or one day. It sometimes takes 2-3 cycles to evaluate a couple. It's not that, okay, first cycle they came and we did the testing and the next cycle they get pregnant. It takes a lot of time. Sometimes the first test we do only the imaging and the blood test, then the second cycle we may probably do a patency test. It depends upon what time of their cycle they come to us. So the time to pregnancy also varies from couple to couple, and it's not that today I met the doctor and the next day I'm going to get pregnant. So it takes time. So the couple have to be patient, and they need to understand that why they are going through these tests and how it is going to help them and impact their treatment plan.
Just to complete this, we also have people walking into our OPD at any day of their menstrual cycle.
Yes.
They don't even understand that for us, the day 1 is the start of the cycle. So does the test that you told both for the male and the female, have a specific timeline?
So in females, in the Wise, what we do is basically to know the AFC or the follicular count, antral, that is a baseline scan. So that is something that is done usually on the second or the third day of the menstrual cycle. So that is why we ask the patients to come back or report back to us on day 2 or day 3. There are a few hormones also which are specific to the menstrual cycle. So there are some reproductive hormones that are done specifically on these particular days, which is going to guide us in our treatment plan. And for men, the semen analysis, it is very important to maintain an abstinence period. So this, in relation to the woman's cycle, it may not matter, but an abstinence period of at least somewhere between 3 to 5 days is important, because if the abstinence or the gap is too long, again there will be a problem with the motility, and if the abstinence period is too short, again there may be a problem with the counts. So to get a apt semen analysis report, it is very important that they at least maintain an abstinence period of 3 to 5 days and then come to us so that we can evaluate them.
Dr. Giriraj.
Good afternoon.
It's nice to have a male perspective on fertility. How prevalent is male infertility, do you think? And what are your primary diagnostics to identify male pattern, of subfertility?
So I'm coming for the male prevalence of male fertility. I'd like to explain about some definitions of fertility and male infertility. So what is infertility? Infertility is inability to conceive by a couple, even after trying for more than a year, in spite of having frequent unprotected sex. That is called infertility, and is tried for more than a year. That is called infertility. What do you mean by male infertility? So inability to conceive, inability for the male to make a fertile woman pregnant in spite of having frequent unprotected sex for more than a year is called male infertility. So primary infertility is the couple have never conceived before, and the secondary infertility is the couple have conceived earlier and now they are trying for the second or the third child. So this is the basic definitions for the fertility and male infertilities. So coming to male infertility prevalence, so there is no exact values of these numbers, what is the prevalence of the male infertilities. So to be rough, the male infertility prevalence varies from the region to region and places to places. In US it is different, in European countries it is different. Coming to India, there are 10 to 15% of population are infertile. In the total of, in the 10 to 15% of population, around 20% is mainly due to male infertility causes, solely due to male infertility causes. Around 30 to 40% is both combined male and female factors. So overall, we can add it to 50% male factors. And coming to the evaluation of a male infertility or male patients, when the patient comes to the clinic, is, as madam already told you, it should be a combined approach. Male and female should be evaluated together. And coming to the male things, 3 basic things we do mainly. One is history taking and physical examination, and semen analysis has to be done on at least 2 separate occasions. So this is the basic 3 things we concentrate on: history taking, physical examination, and semen analysis. There are some other special tests we do for special couples, like an ultrasound of the scrotum and hormonal evaluation like FSH, testosterone levels, and sometimes we go for genetic testings like karyotyping and chromosome abnormality test. These are some of the special tests.
Are those done only if the semen analysis is abnormal?
Only special conditions, like maybe suspecting there is a primary testicular failure and there is an azospermic patients, then we can have to do for the further test. Otherwise, routinely it's not required.
We have a lot of couples coming, and one pattern that we've always observed is they're lucky if they get they go to a doctor and they conceive immediately. But you know that infertility or subfertility sometimes takes time. So we've seen a lot of patients who've gone to one doctor, seen her for a couple of months, not had success, go to another doctor, go to a third doctor sometimes, and then they treat again from the same point. So they've really not reached anywhere. They've spent a lot of money, they've spent a lot of time. And in a couple, when somebody wants something and they don't get it, then that small little amount of friction starts. So how do you deal with couples who actually started on this journey happily, but at some point have kind of started to, start to feel a little bit of derisive about each other.
So generally, whenever I see parents, they see, the thing is, when the reason why they change the gynecologist or they change the doctor is because they feel that, okay, might be there's not much of a problem, but they're not able to identify. Let me see if this person is able to do it. Let me see if I get lucky with this person. It comes out of a need or a desire or a want to actually get what they want. So this could also be because of lack of where they're not getting a comprehensive understanding of what exactly is happening. No one can give them 100% assurance and say, you know what, this is going to happen at that time. But they are trying to see if there is somebody who can give it to them, because we all want some control. The minute we know things are not in our control, we are not okay to accept it. So whenever they come for counseling, the first thing that I do is psycho-educate them on the entire process. Not on the medical basis, but completely on the emotional and the plus and minus of what is going to happen. It is a completely uncertain process. So that acceptance is something they need to know. Yes, there is a problem, there is a solution, yes, but how the solution is going to turn out is something they don't know. So they have to trust the system. So they have to do a complete background, they have to talk to the gynecologist, understand the pros and cons, and the first thing they need not do is Google. So whatever questions and doubts they have, they need to talk to the gynecologist. So basically in my session, after psychoeducating, I ask them to write down whatever doubts they have. They take it back to the gynecologist, they ask all those doubts, so that the doubt doesn't remain in them, which makes them go from one person to another.
So when do you propose, should the couple see a psychologist at the start of their journey when they start getting treated, or?
It is better. It is always better. See, just because they come see a psychologist doesn't mean that there is some issue with them. Many of them don't come to a psychologist because the first thing they say is, we are completely fine, we are okay, there's no problem. It is not that you have a problem that you're coming to us. We can anticipate some difficulties in the journey. If you don't have the difficulties, we're very happy. But if you are going to have some difficulties, let us get the coping strategies in place so that you are well equipped to handle the journey. So it is better they see us before they start all this, so that clarity is there in their mind.
Dr. Prakrita, we've also seen, we're talking about young couples not having children, but we also know how, couples who've had one child sometimes have had 2 or 3 children, sometimes also got a, family planning surgery done. And then, during the tsunami, we had patients who had lost 2-3 of their children and they had come back. And we also now, for whatever reasons, people do lose their first child, or sometimes for no reason at all, they've had one child and then they find it difficult to, conceive again. So, what would your advice be for, what is your line of approach for those kind of couples?
So, such couples we label them under the term of secondary infertility, where they've already had one child or even had a pregnancy, but that didn't end up in a live birth. So they might have had abortions, or they might have had live births, and they might have had, like you said, they have lost one of their child, or they have had a child who's having autism or various other issues because of which they want to have another child. So here again, counseling is very important because couples with secondary infertility who have taken treatment for their first pregnancy are more open to undergo a same set of diagnostic model whatever tests or the treatments. But couples who have had previous spontaneous conceptions and then they come. So here the most important reason why they come to us is because of the time constraint, because they have a belief that they have been able to conceive normally previously, and that is something that they could do even now. But then there is a time constraint that, okay, in 6 months I need to get pregnant, in this given timeline I need to get pregnant because I'll be flying to some other nation or something else, there is some other plan. So here it's very important that we again go through all their routine evaluation as well. So it's not that they have conceived normally, it is a definitive proof of their equality. That is what I give them credit for. That you have conceived normally previously, that means nature has trust in your eggs. That means your egg quality is good, your sperm quality has been good at that point of time, and that is the reason you have conceived naturally. But down the line, if the pregnancy has been way long back, say some couples come with a gap of almost 10 years, 12 years, first child at the age of 12 or 13, and they come for a pregnancy because the firstborn wants a sibling, right? So here the parents are, it's a very tricky situation for the couple as well, because it's not easy for them to navigate through this, because they are, for them the family is completed, but then the firstborn keeps asking for a sibling. I want a younger one. So here again, it depends upon what your condition is. Don't force yourself into a pregnancy because your child is asking for it. See how well you are put up with it. Are you emotionally good enough to carry another pregnancy is important. Are you stable in all aspects to carry another pregnancy? That is important. Are you physically fit? Right? That is very important. For example, there are couples who come at the age of 39 or 40 or 42 as well, and they don't want to try any alternative treatments. They only want to try naturally or some supportive treatments, maybe with medications, but of course it should be a natural conception at the age of 42. But their AMH is very poor, the egg reserve is almost declined. So in these cases, a natural conception is more of a miraculous thing, rather than where we see that okay, we can try and help them with some follicular scans or try to see them, but the selection has to be natural. So here making them trying to reach out to them in a realistic way is very important. Giving them realistic expectations is very important. Telling them this is what it is. It is not something that okay, because it was all green the first time, it's not going to be a cakewalk the second time. At the same time, support them and help them to where they want. So there are couples who are very clear that they do not, no matter what, they are okay with a child if they have to go for an IVF or further treatments, higher treatments, they are okay with one child. So give them what they want. It's not what the science advocates or what it is. It's basically more of what the couple wants and what they are seeking. So if somebody who's not open for that kind of a treatment, there is no point in pushing them towards that. At the same time, if there is a history of abortions, now this is even more desperate, right? You are able to conceive, but then you are not able to carry the pregnancy till 9 months, or you are not able to get a healthy child out of it. So this here, the frustration builds up. There's a lot of stress that adds up. Many a times there are couples who have not been able to conceive only because of stress factor. So there are couples who undergo cycles of IVF, and everything is beautiful because they've had a previous conception post tubectomy, like you said. They didn't want to go through the laparoscopic route or the tubal recanalization route, and then they want to end up with an IVF. But then there is extreme stress because they've had a loss of a child, or there are so many other things that is built up in their mind. No matter what, the best of the best endometrial linings, the best of the best embryos is not going to give us a conception. It is the state of the mind that is going to be very important in these conditions. So it is all the more important that we go in depth and analyze what the state of the mind is, and then accordingly tell them this is what realistically you are going to have. Like if your AMH is low and you don't want to go for higher treatments like IVF or anything, then this is what we are going to be dealing with. And if it happens, it's good. But if it doesn't happen, this is something that you need to understand and you need to accept it, right? That is very important.
You know, even a natural conception, when you have one baby, it's a little bit of an adjustment for the first one. And for couples who are having a secondary infertility, the treatment process itself takes a lot of their time, you know, emotional and economical. So how do you think then that couple or that unit should also deal with the baby that they already have, their first child?
Generally, parents, whenever I broach this topic, they say we don't discuss anything in front of the children. But one thing they forget is children pick up on energies. So if the father and mother are not okay, they're unhappy, every time they go to the hospital and come back, there is murmuring, there is small talks. After a point, from the relatives, everybody, the child will get to know that, okay, there is one more baby, and the parents want one more baby. Many a times when I have spoken to the child has said, my parents are not happy. My parents are not happy with me. So the child does not understand why the parents are not happy. The child feels that because he or she is not okay, or something that the child has not done. So the parents have to be extremely mindful of the fact that the child who is watching them doesn't understand what's happening, but is taking everything on oneself. So this journey is something they have to take it as part of their life, not the complete life. The focus should be equally divided with the first child, and also concentrate on the treatment. If the complete focus goes on the treatment, the negative energy not just impacts them, it impacts the child, and it becomes a cyclic loop, because the worry now is, why is my child behaving like this? I'm already going through so much. On top of that, he or she is also troubling me. So it becomes a completely vicious cycle. So when they come for counseling also, the psychoeducation is given and counseling is given. We also talk to the older sibling to understand what is their understanding, so that the parents form a stronger unit with the child and they do this journey together.
Okay, Giraj, can you explain how surgical options such as varicocelectomy can help men in their fertility?
So before knowing the treatment option for the male infertility, it may be conservative management or the surgical options, you have to know the three basic pathophysiology behind the male infertility. So the three basic pathophysiology is, first one is low or altered sperm production. It may be oligospermia, it may be teratospermia, it may be asthenospermia, may be combined. So second one is complete absence of complete failure in the production of the sperm, the azospermia. The third one is obstruction to the passage of the sperm, obstructive azospermia. So these are the three basic pathophysiology behind the male infertility. The reasons are etiology are many, like genetic factors or hormonal factors or an infective factors or a traumatic factors, endocrinology factors, all the etiology. The basic physiology is the three basic pathophysiology behind the male infertility. So male infertility can be divided into three groups depending on the treatment options. One is treatable, one is uncorrectable, one is untreatable. The treatable options include around 12% of the male fertility groups. They are like mainly surgical options like varicocele or obstructive azospermia, where we do a vasovasostomy or vasoepidermostomy. For varicocele, we do a varicocele repair, and sometimes ejaculated duct obstructions will be there. We have to do a resection of the ejaculated duct. These are the surgical options for the male infertility. So uncorrectable causes include some severe oligospermia or teratospermia, where they are not able to be managed or treated, but then be corrected with the ART options, other options like ART. So there are some group called untreatable male infertility groups. This is around 10 to 12%. They are like primary testicular failure, serotolin self syndromes, and there is absence of both the testes, like post-orchidectomy status. So there is no complete treatment there. So they are, even ART also is not possible in these cases. Then we go for other alternative options like donor inseminations or adoptions.
Can you walk us through the essential tests and screening couples must undergo before the IVF process starts?
So IVF is a different ball game, right? So of course the basic tests which we do when a couple come to us when they are seeking for fertility, those are some of the routine tests like we discussed first. Maybe it may be the thyroid profile or your routine sugars, your hemoglobin, and your other few hormones like prolactin. In an IVF, added to these tests, so IVF entails at the end of those 12 to 14 days that you take everyday injections and where we stimulate the ovaries. So at the end of the day, we are going to retrieve those eggs, right? So this is something that is done under anesthesia. It may be a just IV sedation, or it may be general anesthesia itself. So to undergo an anesthetic procedure, you need to be fit. Of course, there will be a thorough pre-operative checkup which is done by our anesthetist as well. to make sure what kind of anesthesia has to be given and what is the nature of the drugs that needs to be given, and is there any constraints in giving any anesthetics, in anesthesia. For example, there might be some other comorbidities for patients like some cardiac disorder, hypertension or uncontrolled sugars, because of which again the nature of the anesthesia may change. So based on this, there are multiple associated tests, like if the comorbidities increase, there may be an advocated 2D echo as well. Apart from that, there are routine testing, pre-operative checkup like your sugars, your hemoglobin, the serology part, all the serology. Many patients question, why are we doing serology here? So this is to protect yourself, to protect your doctor, the support staff, everybody. So serology is very important here as well. And the other, your thyroid hormones, everything that is going to have an impact on you when you undergo the anesthesia. That's the whole point.
So could you just throw some light on treatment of patients with azospermia?
I didn't get you. Azospermia. So as I told, the azospermia can be divided into obstructive azospermia and non-obstructive azospermia. As I already told, obstructive azospermia, it can be managed with the surgical options like vasovasostomy, depending on the cause, vasovasostomy, vasoepidemostomy, ejaculatory duct resections. Coming to non-obstructive azospermia, which majority of times is managed with the ART techniques. Very difficult to manage with the conservative management, so it's managed with the ART techniques. And ART techniques, majority of the task is taken by the gynecologist or the IVF specialist. The andrology role in the ART comes very little role. So the three roles of the andrologist in the ART techniques. So first one is counseling the male. Getting the male to the OPD infertility clinic and making him undergo the investigations and convincing him the male factor behind the cause of the male infertility, and convincing for male to undergo a ART is a very, very serious process. It's mainly done by the partner and the family members and by the gynecologist and IVF specialist. Andrologist doesn't do much in this thing. Only small counseling is been done by an andrologist. And coming to the harvesting of the sperm. So there are many techniques to harvest the sperm. We do a PISA, it's called a percutaneous aspiration of the sperm from the epidermis, or we do a microscopic aspiration of the epidermis for the sperm aspiration. Sometimes we go for testicular biopsy, sometimes we do a micro TISA. These are the techniques of harvesting the sperms. Last comes the sperm cryopreservation or the sperm banking. We counsel male partner for undergoing a cryopreservation for the future purposes. That is the role of andrologist in the ART.
Sushma, we'll sum it up with you. So how do you propose that, couples undergoing, they keep up their resilient spirit, and most of them are also anxious about the results. So how do you kind of, tell them that it's a long journey, but they have to be resilient?
Most of the problems have a solution, and if there is no solution, then there has to be acceptance. And we also have to know that there are some things which are under our control, there are some things which are not under our control. That point is something every single individual, not just in aspect of fertility, but in general, they have to understand. The second most important thing that I suggest to all couples is, let them keep an open mind and not get bogged down by one or two negatives that has happened in their life. So when they come to a gynecologist, when they come to a fertility specialist also, let them come with an open mind and also know that there are some things which is not under their control. So we will do the best we can, and we'll hope the best we can, and we will see what next. More so if there's already a child back home, so that mindfulness has to be even much more. And if this is going to be the first child, then that mindfulness has to be even more so, because it is a part of their life. So let them take control of what they have under this thing. For example, the physical activity, management of their emotions, these are things that's in their control. So if they are able to take charge of all this, this is something, I'm not saying it's going to get solved, but they will be better equipped to handle it. And please reach out if you are not okay. That is one thing that every individual has to do.
Thank you very much. I think that brings us to the end of our discussion.
Thank you.
Thank you. Thank you.
Thank you so much, doctors. Thank you so much to our panelists for providing us such detailed insights into the diagnostic tools available today. May I request Mr. Ashutosh Dwivedi, CEO of Vyli Health, to kindly come onto the stage to give away the mementos for our panelists. Can we all give a huge round of applause, ladies and gentlemen? First and foremost, Dr. Prakrita from Aster CMI Hospital. Thank you so much, doctor. Go fast. Giving the one in lasers. Dr. Giriraja Velayudam. Thank you so much, doctor. Dr. Sushma Gopalan from Aster CMI Hospital as well. Thank you so much, ma'am. Thank you so much, Dr. Soumya Lakshmi, for moderating this session so well. Let's all join together for a group picture. Thank you so much. Team, we are at the Path to Parenthood 2024. What an interesting initiative where we are talking about taboo topics for others, but we are actually taking that first step of creating awareness to people, to couples who actually are seeking to embrace parenthood. And this initiative is by Newsfirst, co-sponsored by Garbhagudi IVF Center, supported by the Ministry of Health and Family Welfare, Government of Karnataka, organized by Brand First, our knowledge partner Vyli Health. Let me tell you all an interesting thing. The most neglected part when it comes to the topic of fertility is the male fertility. And we should all know that male fertility matters, definitely matters. It is an often overlooked but critical part of the equation. To speak about this important topic, we have with us Dr. Santosh Gupta, Clinical Director and Infertility Specialist at Nova IVF, Bengaluru. Let us all put our hands together and welcome Dr. Santosh Gupta onto the stage. A warm welcome to you, ma'am.
Good afternoon, you all. I thank Path to Parenthood to invite me here and have an opportunity to address all the august audience here. So, from morning we are talking about fertility and always we talk about female, and female, but male fertility matters as an individual, and otherwise also why it matters is infertility is a couple problem. It cannot be an individual problem, and it impacts us socially, at a religious point of view, mentally, self-identity and self-confidence. So let us understand why male factor fertility it matters. See, 15% of couple in this world are suffering from infertility. It is a huge population. Almost 50% of them either have associated or isolated male factor issues. Infertility is listed as a disease by WHO, so every person has a right to have a cure for disease. Till today, this problem was women-centric. Either it is a blame game or treatment. So when it comes to blame, when we say women are sufferer, but treatment part, always men are neglected. Men are also equally affected socially and mentally when they do not have children. And most of the men, unfortunately, what I have seen in my practice, they take it very, sperm count is low, they feel it will affect their sexuality, their manhood and personal identity and self-esteem, which is totally a myth. So we need to address this factor, and to bring down the worldwide statistics, why it is more important is, this is a temporal trend in the sperm count. The average sperm count in 1940s was above 100 million per ml, which in 1990 became 66 million per ml. And from 2000 onwards, because of the change in lifestyle, there is a global decline in 2.64% of fertility in men. If this trend continues, by 2060, probably the natural fertility in men will disappear. So this is something we need to address and discuss what we have to do with the men and their fertility. It is really a matter of debate, and all developed countries, because of various issues and male factor also, they are seeing a total fertility decline. Their fecundity has reduced beyond the replaceable population. So that is also, as a country, as a population, as a world, we should be worried about where our future generations are. So today what I am going to talk about is, first and foremost issue is the awareness about the problem and what we can do. Last week also, it's a general thing. I watched a movie. In that one man went for a semen analysis, and the report, it was shown as a oligoasthenospermia. That man has hidden his report, and wife by chance has seen the report, and she thinks my husband cannot conceive, and man also thinks same. That's why he's not sharing the report. And wife goes and seeks a donor semen without his consent. Luckily in India it is not possible, but that's how the story spins us. It tells about the lack of awareness. If men knew that oligoasthenospermia can be corrected or it can be handled through IVF or fertility treatment, he can still be a father. Probably he would have not done. And if wife was aware that these things can be handled, she would have not gone for the donor sperm and other issues. So awareness is the key, and the men should understand that sperm count is not related to their sexuality and manhood. A person can have zero sperm, still can be a completely sexually active male. Then what are the investigation needed? Counseling we have discussed enough from the morning, and treatment option, how to improve the parameters. If parameters are not improvable, then what is the role of ART procedure like IUI, IVF and ICSI procedures? So it's not that today Path to Parenthood has taken this initiative. There are many websites and forums on the internet which talks about him fertility. We always talk about her, madam, or women, or mother. They are talking about him fertility, and they are worried and they are discussing. It is time to tackle the men problem. So it is not we. So I appreciate that initiative for that. And before understanding any problem, a basic thing we have to understand how the male reproductive system works. Spermatogenesis happens in the testicles. From testicles, sperms get collected. They come out through a duct called vas deferens, and it is come out through penile urethra during the sexual process. And it's stuck. And the spermatogenesis happens in the fine tubules in the testis, and the adjacent stromal tissue, the testosterone being produced. Although testosterone influences the spermatogenesis, but in absence of testosterone also, in absence of spermatogenesis, there is enough testosterone in most of the men that we have to understand it well. So whenever we talk about evaluation of male, apart from making him comfortable, we have to take a detailed medical history like any other disease. There has to be a physical examination, because most of the clinics, either it is a fertility clinic or a general OBG clinic, we skip men from history taking and we don't examine the men, and then only we have to subject them to the laboratory investigation. I would put a word here that always talk to couple in a private consultation room. Your consultation room cannot be surrounded by 10 people, lot of staff, lot of your assistant, and 1 or 2 patients walking around, because when we talk about the history, mainly it is the sexual history which you have to ask, their time of intercourse, frequency, whether they are able to be together during fertile period. So unless and until you offer them privacy, they will not open up. You have to ask leading questions in a private and comfortable environment. The sexual dysfunction, there could be a ejaculatory and erectile dysfunction. Again, they need privacy and some kind of comfort to tell you. Use of lubricant jelly, which could be spermicidal. They may be doing everything correctly. Maybe this could be the cause of their fertility problem. Intake of some kind of drugs, like nowadays going to gym is a trend. And the bodybuilders usually do have a very low sperm count or a 0 sperm count, but in a way, because they over-exercise and they take steroids and anabolic steroids, which may reduce their sperm count, and surgery of private parts, hernia, cancer treatment, all these you have to take in the detail, which can provide you some clues towards the treatment. Then the general examination and examination of private parts. So undescended testes, shrunken testes, hydrocele, hernia, you can see examining the scrotal, and the penis, the urethral meatus, hypospadiasis, phimosis. These are the few things which you can rule out by doing a general physical examination. And obviously you have to rule out varicocele. A word of caution, the varicocele is the most abused diagnosis. A clinically palpable varicocele is only varicocele which is clinically significant. Then the is the laboratory investigation. For men, otherwise things are easy. If everything is fine, the semen analysis is the foundation of the laboratory investigation. And what we see in that is the volume, liquefaction, mainly sperm count, sperm motility, and morphology. So when we do a semen analysis, again few things are very, very important. How to collect the semen sample and where. If you have asked from home collection, the semen sample should be collected in an appropriate container, and should reach the center within 30 to 60 minutes. It should be kept at body temperature. Otherwise, best is to do a semen analysis in your clinic and examine there. And your clinic should be well equipped with all kind of equipments. They need a stage warmer also to give a proper motility. So as the sperm counts are falling, I think WHO is doing the task. It is reducing the sperm count and motility as a normal marker. So in today, 2021, where we stand, sample has a 1.4 ml of volume, 16 million per ml concentration, 42% of motility, and 4% of morphology. That is, out of every 100 sperm, only 4 should be normal. Then it is considered as a normal semen sample. But there is a trick in that. See, WHO, although it's a vast organization and globally we are too many, they have taken sample of around 2,000 men, not across all the continent and all geography, and who has recently been father, and they have given us a normal and abnormal range. Just 2,000 with a restricted geography, I think it is an injustice. Suppose if we believe in these semen parameters also, you can see from 5th to 95th percentile, it is considered as a normal semen parameter, but you can see the differences in 5th percentile and 50th percentile. A 5th percentile has 15 million count and 73 million count is the 50th percentile. these are the men who are maximally fertile. So there is a lot of difference. So what we say normal, is it normal or not, we don't know. It's something we have to include more and more men and do further research about it. Just 2,000 men cannot represent a worldwide fertility. Then another interesting point is sperm is a very highly differentiated cell. Its job is to carry a DNA forward to the next generation. To do that job, a normal cell gets specialized. It's a compact nucleus which carries the DNA for the future generation. There is a cap which allows them to penetrate into the egg, and there is a tail which gives lot of motility so that sperm can reach its destination. It's a highly differentiated cell. That's why majority of them are abnormal, and up to 4% also we consider is normal. Again, a word of caution, in today's urban lifestyle and stressful lifestyle, in fact, it is difficult to find men with 4% normal morphology. What semen analysis and parameters we are seeing every day is roughly 2%, 1% of the sperm morphology. So definitely fertility is on decline. Then another important thing is to look for infection. See, when we do a semen analysis, small round cells which otherwise we consider as pus cells can be seen, but this could be immature spermatid or immature sperm. So to confirm that, leukocytes should be confirmed with a peroxidase staining. We do get semen sample and reports from outside where 5 to 6 pus cell, without checking they will write. For a semen sample, if it is more than 1 pus cell per high power field, it is a leukocytospermia. So we have to be mindful about our reports we are generating. And if there is a leukocytospermia, then empirical antibiotic therapy as a first line of treatment we can give, and repeat semen analysis can be performed. And if a person has repeated semen infection, then probably semen culture is required. Otherwise, in general, semen culture is not required. Then come to the blood test. If semen analysis is normal and history and sexual functions are normal, for men in general blood tests are not required. If there are abnormal semen parameters, then endocrine evaluation of the men is required. Like in women, FSH, LH, our pituitary hypothalamus control our ovaries. Like that in men, pituitary hypothalamus control testicular function. So FSH, LH and testosterone and prolactin, these are the 4 hormones. If FSH, LH is high, that means there is a primary testicular failure and pituitary is trying to stimulate the testis is at fault, there is no spermatogenesis. If FSH, LH is normal, then probably it is it could be abnormal spermatogenesis. We should look into further detail. If FSH, LH is very low, and then probably it is a hypogonadism, hypopituitary hypogonadism. That means our pituitary is at fault. If prolactin is high, we have to look for prolactin secreting tumor. These are the specialized tests. Then further advanced tests are not required in everyone, but there are very few specific people where we need further specialized tests. One is the DNA fragmentation index. If there is unexplained infertility, that means all sperm parameters are fine, still couple are not able to conceive, probably you can do a DNA fragmentation index, DFI, or there is a person is smoker, or there is a recurrent semen infection, still we can do. If there is a bilateral obstruction, it's an obstructive azospermia, and there is vas deferens is absent, probably then we can ask for genetic test, CFTR. Some men are curious to know why their semen parameters are so low or why they have 0 sperm. Then you can ask for karyotyping and Y chromosome microdeletion if sperm count is less than 5 million per ml and if motility is very much compromised. Some men, there is something called retrograde ejaculation. Means they are, instead of ejaculating outside, they are ejaculating, the semen sample is going in urine. If you take a careful history, you can find out these patients, and post ejaculation, if you check their urine sample, probably you will find the sperm. And transrectal ultrasound to check for any prostatic pathology, ejaculatory duct obstructions. So these are the few specialized tests which are not required in all men. Then again, let us begin. If we get a 0 sperm count, should that man should be hopeless that I cannot be a father? First, he should know he is not the only one. 1% of all men in this world could be azospermic, which is a very, very high number, because it's such a personal thing, nobody discuss with each other, and we think that he's the only one who has a 0 sperm count. 10 to 15% of infertile male can be azospermic. One semen sample cannot judge a man. You have to do 3 semen sample before labeling him as azospermic. You have to spin that semen sample and you get a palette in that. We have to check that palette, then only we can label it in as a azospermia. So the crux point is the man is not only one, and one semen sample cannot, sometimes if they have fever, there's a poor collection, it could come as a azospermia and very next sample could be normal. So when there is a azospermia, it could be obstructive, it could be non-obstructive. So obstructive azospermia, usually the testicular volume is normal, hormonal profile will be normal, and when we do a surgical extraction, which is very, very simple, it's just a needle prick, it's a very simple procedure, you could do under anesthesia or a local anesthesia. If we retrieve those sperm, a person can father a child using surgically retrieved sperm by means of IVF and ICSI procedure. So again, in today's time of technology, if technology is available, we should be thankful to our stars that we are born in an era, because before 2000 the ICSI was not available. We are born in that era where male factor fertility, even if it is not treatable, can be dealt with advanced technology. Like we all were walking, then cycle came, then car came. When we drive car, we don't feel that we are smaller or we can't walk, we have incapacity. But when we opt for IVF, that feeling is still there among patients that I am lacking something, that's why I have to go through a IVF ICSI. So probably more forums like that create more awareness, and acceptability of these kind of treatment will increase. Then these obstructive azospermias, we can manage very well with the surgical retrieval of the sperm and doing IVF ICSI procedure. If there is a normal ejaculate, but then FSH is very high, testes could be normal or a shrunken testes. These are the one you have to counsel them. They may have spermatogenesis or no spermatogenesis. Sometimes they have a patchy areas of sperm production. So we have to do TISA or micro TISA. We have to tell them that we may retrieve sperm, we may not retrieve sperm. If we retrieve sperm, we have to freeze them. So these kind of procedures should be done in IVF clinics where you can freeze those retrieved sperm and use them later. If we do not retrieve sperm, then adoption or the donor sperms are the other procedure. But we shall not decide only on the basis of high FSH or low normal FSH. Any number of FSH, whether it is normal or high, cannot say that we will not get sperm or we will definitely get the sperm. So we have to do the procedure and then take a call about it. Then any person, if they want to prognosticate whether I will get sperm in my TISA when we do surgical retrieval, so this is the advanced genetic test which is known as Y chromosome microdeletion. If there is a deletion in A and B, we will not get the sperm, and if there is a microdeletion in the C, 50 to 60%, we will chances that we will retrieve the sperm. So these are the sperm retrieval techniques which our doctor in previous panel have discussed, and what I come today is the most correctable part and where we are lacking about is lifestyle. Although we are all following the modern lifestyle, we are adopting a very unhealthy lifestyle. So biggest problem in urban men is obesity. Obesity does not cause only blood pressure and diabetes, it reduces your sperm count and motility as well. So obesity, sedentary lifestyle, your occupation, you may be working in a factory, chemicals and furnace, or sitting always on laptop, wearing the clothes which are too tight. Mind you, nowadays even in clothes lot of plastic is there. Even in the jeans they put plastic. So your clothes, what you are wearing, you have to see smoking and alcohol, which has become like a normal lifestyle today, can cause male factor infertility. Drugs and substance abuse, few medical drugs, otherwise recreational drugs also causes infertility. Steroid and anabolic steroid, we see lot of patients in urban and semi-urban area. There are a lot of gyms cropping up. Everybody wants to have muscles because our movie stars have now all six packs and everything. And these men are the one who have zero sperm count. If they stop taking these steroids and the supplements what they get from gym, it can recover. It can recover. And environmental toxin, we should be aware, minimize use of plastics, synthetic chemicals, perfumes, whatever we can do. We cannot change the earth which we are living, but what is in our hand we should do. So these lifestyles are very, very much important. I had a patient, he had a low sperm count. Then he said, I am taking hair fall medicine. Hair fall medicine has androgens. So when he stopped it, in 3 months his sperm count recover. So these are the lifestyle problem. And whether we believe or not, stress is a modern life phenomena, and today's man is a caged man in his life. He's like a caged animal. And long back I have attended one seminar where a zoologist have spoken. They have compared semen parameters of a chimpanzee and lion in the forest and chimpanzee and lion in the zoo. And there was a chalk and cheese difference, whereas zoo animals were fed nicely, but because they were stressed and they were caged, their semen parameters were very low, including DFI. So we try to liberate ourselves from the stress of our modern life. Then obesity is a known risk factor, 1 to 2 times higher infertility. The sperm count will be lower in the obese men. Why? Because this extra estrogen is produced in our tummy fat, and which increase the estrogen in our body, and this abnormal estrogen and testosterone ratio will reduce the spermatogenesis and sperm motility. So these obese men, after proper counseling, are asked to lose weight, and aromatase inhibitors are the drug which can play some role for these men. But style. Then a word about varicocele. Varicocele is nothing. It is a dilated veins around the scrotum, around the testicle in the scrotum. Most of the men will have varicocele, especially left-sided. So only grade 3 varicocele is important. Don't get influenced by a Doppler finding. Every man will have grade 1 varicocele. So varicocele which is detected only in Doppler has no meaning. When a varicocele surgery has to be done, when it is grade 3 varicocele associated with abnormal semen parameter, there is a normal and treatable female factor infertility. After surgery, it takes long time. If the female partner is old or her AMH is lower or any which way they need IVF, then probably varicocele surgery has no meaning. Then comes the most important part, oligoasthenospermia, what we see every day. That means men has a sperm report, count is less, motility is less, and morphology is less. In general, what we go for is the empirical treatment. Lifestyle matters, but probably empirical treatment has no role. As the doctor in previous panel has said, only 12% of male factors could be treatable. 70 to 80% will remain as such, and another 10 to 12% are untreatable. That means even IVF cannot help them. So these 70 to 80%, we have to counsel them well. We have to evaluate them as a couple. If time do not allow us, we should not waste our time in the empirical treatments. But again, if they are taking testosterone from some doctor that testosterone will increase their sperm production, I think they should stop it. It will reduce the sperm production. Anabolic steroid, again muscle building they take, again it will reduce the sperm production. These are very common drugs which people take. Then clomiphene citrate or if we take these anti-estrogen for a very long time, they also reduce the sperm production. They work in a short period. For long term, they will reduce the sperm production. So for medical management, we can give antioxidant, we can advise some kind of motility enhancing drug, but do not waste the couple's time for that. Another very important where really medical treatment works is the hypogonadism. That means their pituitary is not working, LH is not releasing from pituitary. It takes a very long time, but such patients are given on injectables, HCG and LH and FSH, and they will slowly start showing sperm production. But again, there's a lot of counseling required. Then the key message is empirical treatment for idiopathic oligospermia is not recommended. Infertile men with hypogonadism, their treatment work. In that, HCG is the treatment of choice. Then comes the unexplained infertility, where everything is normal, still the couple is not conceiving. Always we blame women, but probably we should do a DNA fragmentation index for the men if it is high. If it is high, it says in a trying naturally and probably in IUI pregnancy rates are less, but ICSI is able to bypass the impact of DNA fragmentation. And for the sperm sorting nowadays, some advanced kind of sorters are available, which I'll talk about. So sperm DNA fragmentation index could be high because of high ROS or high oxygen free radical. So putting them on antioxidant therapy, lifestyle modification, if there is a varicocele, if there is an infection, treat them and consider ICSI as a treatment. And when we are giving treatment, handle that sperm sample well. If you keep it for very long time, probably DFI will increase. Short abstinence, ask that man to ejaculate at shorter period, process the semen sample as appropriate as soon as possible, provide them appropriate temperature. Incubation should not exceed for more than 4 hours. And when you are using them for treatment, these are certain kind of equipments, kits available, MACS and PIXI. These are the techniques for sorting sperm which have lesser DNA fragmentation index, and we can use this sperm for further treatment. ROS also, there are tests available you can detect. Otherwise, put them on antioxidant, and putting antioxidant blindly may not solve the purpose. Probably you have to look for the causes of reactive oxygen species, which could be stress, varicocele, infection, smoking, drug abuse, pollution, or obesity also. So my thing is, if sperm count and motility is less, you try for a short while. If it is not improving, then ART is the answer. We should not shy away from accepting the ART. IVF ICSI has changed the way male factor infertility is looked upon. Before late 90s, even severe oligoacinospermia, because ICSI was not there, IVF was all about pouring an egg around lot of motile sperm. So even IVF couldn't solve that problem. So we should be blessed that today we are dealing with the patient with the technique of ICSI. And this is something for male factor. Our doctor has tried to divide them into 5 groups, and these groups just to address male factor infertility in a more precise manner, so that we should not blindly treat them. It is beyond to discuss them in detail. I think it is not on this forum, but just for the awareness, the 5 groups are there, and you can treat your patient in a more precise way. So I end up in my talk with this kind of take-home message. I think awareness is the key. Treatment comes later. Awareness is the key. That's why these forums play a very important role. Treatable male factor is only 18-20%. Uncorrectable subfertility, it is not absolute infertility. Subfertility is 70-80%, where timely intervention of ART is the best option. Appropriate counseling of the couple to choose right treatment, right time is important, and it is not blame game. Always welcome a couple in your counseling chamber and is your consultation chamber as well. Thank you very much. Thank you very much.
Thank you so much, Dr. Santosh Gupta, for highlighting the significance of male fertility in the parenthood journey. Yes, awareness is the key. I request Urvi Mehta, Senior Vice President, Brand First, to give the token of gratitude to Dr. Santosh Gupta. I request Urvi Mehta to kindly come forward to give a token of appreciation to Dr. Santosh Gupta. I request Ravi Kumar sir to kindly come forward to give away the token of appreciation to Dr. Santosh Gupta. Can we all give a huge round of applause, ladies and gentlemen? I request Urvi Mehta to kindly join us here on stage. Can we all give a huge round of applause? Urvi Mehta, Senior Vice President, Brand First. Now, we are keen to hear more about how Ayurveda integrates with modern IVF techniques, enhancing IVF success rates with Ayurveda's support. Please welcome Dr. Shweta Suvarna, Ayurveda gynecologist and medical superintendent at Apollo Ayurved. A warm welcome to Dr. Shweta Suvarna. Over to you, ma'am.
Thank you, Mr. Gokul. Good afternoon, everybody. Since morning, we have been hearing the experts from IVF. We had experts on male infertility. We had experts speaking on psychological counseling. So here I am, right, standing in front of you to talk about the contribution of Ayurveda in improving the success rate of IVF. I come from Apollo Ayurved, which, it's not moving. I come from Apollo Ayurved. We've been here in the healthcare system for the last 2 decades, being the pioneers in integrative medicine as well as the leaders in precision Ayurveda. We are proud to say that we have a patient satisfaction rate of 98.6%. That's because the way we deal with our patients, we empower our patients, which is the major role played in infertility management as well. We are the most awarded hospital, chain of hospitals. We were the first one to be awarded DL Shah National Quality Award, and the first Ayurveda hospital to be NABH accredited in India. We have a 20 years of heritage in Ayurveda Chikitsa excellence, having 15 centers across India. Now, coming to the topic where I am speaking on how Ayurveda can enhance the success rate of IVF. Before me, there was a lot of discussion happening around the IVF, the success rate, and how psychology, how male factor, all contribute to the success of IVF. Here, we know that IVF has been a boon to the infertile couple in terms of getting the better outcomes. Though there are certain areas where there are IVF failures. We've seen that through the Society of Assisted Reproductive Techniques says that the IVF success rate is 55.6 for the couples under the age of 35, and it is 40.8 for the couples between 35 and 37 years, and only 4.1% for the couples above 42 years of age. So we can see that the success rate is not 100% anywhere. And also, it takes at an average, the National Institute of Health says it takes at an average of 3.6 IVFs to have a successful pregnancy outcome in most of the patients. So this gives us a scope to see how we can improve this success rate through Ayurveda. Majorly, if we see the reasons or the causes why there is IVF failure, the first and the foremost would be the poor ovarian reserve, the second being the egg and the sperm quality, third being the endometrial receptivity and implantation issues, and fourth, majorly which was discussed in the previous sessions as well, is the stress and the lifestyle issues. So major failure revolves around these 4 factors as the key causes for failure of IVF. So in Apollo Ayurveda, we have taken up a task of, I'm sure most of the IVF specialists and the gynecologists who presented here before me would agree that some percentage of their patients are already under Ayurveda treatment. But the difference here when we say integrative management at Apollo Ayurveda is, we have a dialogue with the consultant, that is the IVF consultant or the gynecologist themselves. The doctors are aligned. The doctors discuss what is the outcome that we are looking at and what are the areas where each one of us can contribute. So this gives a better outcome to the patient rather than the patient themselves going and opting for different systems of medicine. In Ayurveda, we say there are 4 factors. It is called as Dhruvam Chaturnam. That means 4 factors that are responsible for healthy conception is Rutu, Kshetra, Ambu and Bija. Along with this, our acharyas have mentioned that to have a healthy pregnancy, it's also important to have a Saumanasyam Garbhadharanam. That is a pleasant mind, which contributes to most of our hormonal variation and unexplained quality, is the pleasant mind, or the Saumanasyam is a key factor for healthy conception. So we saw in the previous slide that there are 4 reasons which Ayurveda states for a healthy conception, and here we are talking about the 4 factors which we saw for the IVF failure. So all this factor nothing but boils down to the 4 factors which Ayurveda mentions. That is Rutu, Kshetra, Ambu and Bija. So when we are talking about Rutu means nothing but the appropriate time for conception or the ovulation period, and also about the reserve, ovarian reserve that is there. So Ayurveda gives specialized techniques how we can improve the Rutu factors. Next is the Kshetra. Kshetra is nothing but the uterine factors, how healthy uterus can contribute to a healthy conception. So this other factors, the third factor is Ambu, which talks about the hormonal alignment and the circulation within the uterus, which are again the factors which are very, very important during the IVF. The triple lining that is important during the IVF. All of this comes under these 4 major factors. Next is the Bija. Bija is nothing but the male and the female gametes, that is the sperm and the ovum. A healthy sperm and the ovum can contribute to a successful IVF. So these are the 4 factors which Ayurveda has mentioned as how it can be improved through some of the Ayurveda techniques, and how we can achieve a healthy conception even if the patient is going through IVF or through a natural conception. How do we bring about these 4 factors, improvement or enhance these 4 factors for the patient? So at Apollo Ayurveda, we have a personalized care that is designed for the patient, where there will be a diet planning, there will be a lifestyle planning for the patient, individualized plan for the diet and lifestyle changes through their ahar they take, the lifestyle that they live, and the medicines, which are purely herbal medicines that is particularly selected for their condition, and through some of the Panchakarma therapies. So these is, and the major part, we saw in our previous discussion, most of the discussion revolved around the psychological well-being and the counseling that is required. So in Ayurveda, we have a special way of understanding the body type of the person, which is called as Prakriti. Based on this, they will have certain nature for their physical as well as the mental attributes. So that can be corrected through their diet, through some of their lifestyles, and through the counseling and the medications. So when we are talking about the people who are going through IVF, there's a lot of apprehension because IVF is physical, mental, and a financial drain to the patients, and there's a lot of societal pressure that they go through when they are going through the IVF procedure. In Ayurveda, not only the Panchakarma procedures, but we also help them through different other procedures like yoga, meditation, and music therapy to overcome such psychological apprehensions. So now talking about the Panchakarma procedures in detail, majorly when a patient is going through the IVF procedures, there are chances of improving certain factors of fertility in them through the Panchakarma procedures. When I say Panchakarma, it is 5 procedures that will help to take care of the body as a whole. It is not just looking at the fertility factor, because we know that certain times even metabolic factors like obesity and all this can contribute to the low fertility score in both the couples. So going through a Panchakarma, a person can have benefits even if it is due to some of the metabolic disorders or due to some of the not only the hormonal correction but also metabolic correction can happen through the Panchakarma procedures. Majorly the Panchakarma procedures that will be employed for an IVF, for a couple who are looking for IVF or success through IVF would be Vamana, which means using a therapy to cleanse the body through a process of inducing vomiting. The Virechana, a process of inducing purgation, which does the total detox of the body. And Nasya means instillation of medication through the nasal route, majorly helping in bringing in the HPO axis alignment, which is the hypothalamus, pituitary and the ovarian axis alignment, which majorly is the hormonal play in fertility. Next is the Basti. Basti is a rectal enema which is designed to bring about the improvement in the sperm as well as the ovum quality. And a specialized technique in Ayurveda called as Uttarabasti, which is equally employed for male and female infertility, where a medicated substance is introduced into the uterus or into the penis in male. So through our last 2 decades of work, where we have worked closely with the infertility experts, we have seen gynecologists and the infertility experts, we have seen that Ayurveda can contribute great in terms of improving the low AMH, in improving the poor ovarian response, in inadequate endometrial lining, where the patient is going through IVF but there are these concerns. Ayurveda can definitely help in these stages. In epigenetic factors, we see that there's a lot of health conditions that we see in the newborns or the kids of late. That is because of the epigenetic changes that happens. Epigenetics means it can be altered because of our diet, because of the environment around us, and because of the stress that we undergo. So Ayurveda can definitely bring about a major change in the epigenetic factors, also improve the quality of the sperm and the ovum, and also in conditions like oligospermia, azospermia, there can be a great contribution through the Panchakarma, the Ahara, that is the diet, and the Vihara, that is the lifestyle changes that can be advised through the Ayurvedic principles. Not only disease specific or the condition specific infertility, but also as a whole person care, Ayurveda can contribute in management of stress levels, weight management, diet and lifestyle corrections, which are the major contribution for most of the infertility. That was the contribution what Ayurveda can do in enhancing the IVF success. Now I'm talking about the preconception care. Preconception care is a concept where both the couples who are in the path of parenthood looking out for a total detox for their body, because to improve the sperm and the ovum quality. That is, everybody desires to have a happy and a healthy child. When anyone is looking for a happy and a healthy child, we know that because of our lifestyle, maybe because of the work stress or the lifestyle that we are leading, there's a lot of factors which has been derailed in our body. To align those, Ayurveda has a concept of preconception care that the couples undergo even before they plan their pregnancy, which brings in a major change in the quality of the sperm and ovum and can prevent a lot of disease condition that can be passed through the next generation through the sperm and ovum. So this is a boon to the couples if they want to see that the next generation is not carried on because of the lifestyle what the parents have had. So I would say Ayurveda can contribute not only for natural conception or improving the quality of sperm and ovum, that also improving the preconceptional chances of couples having a healthy pregnancy, but also improve the IVF success rates through the proper implementation of the Ayurvedic principles of Ahara, Vihara, Aushadha and the Panchakarma therapies. Thank you.
Thank you so much, Dr. Shweta, for giving us an insightful look into how traditional and modern medicine can work hand in hand. Can we all give a huge round of applause to Dr. Shweta? I request Maruti SH, Editor-in-Chief, Newsfirst, to kindly come forward to give away a memento to Dr. Shweta. Thank you so much, ma'am. Thank you so much. Well, I want all of you to be seated. Please don't leave the venue because this is going to be a very, very interesting segment for all of us. In times, in times where people don't come forward and share their stories about IVF, I think this is that segment where we have someone who's going to share his personal story amongst us. So I want to introduce, first of all, Hoopsters, a first of its kind hybrid non-academic educational platform. The goal is to create a community of change catalysts who are well informed, aware, empathetic and proactive. They provide the right resources, curated programs and continued engagement to help achieve these goals. Hoopsters integrates multiple domains and subject matters with a special focus on mental health, parenting, life skills and sustainability. This platform is designed for individuals of all age groups from toddlers to senior citizens. To know more about Hoopsters and to learn about their special programs, go and log on to www.hoopsters.in. As a part of creating awareness, we have with us Mr. Sachin, who will share his personal experiences with fertility treatments. Can we all give a huge round of applause and welcome Mr. Sachin?
Good afternoon, everyone. I hope I'm audible, and it's a wonderful afternoon that we have here. But more wonderful than the afternoon is the event that's happening here. Who am I and why am I here? Okay, I won't say me, but I will say we. We are Sachin and Radhika. My better half is not here today with us, but she's busy with something else. But I'm here, and we've been married for 19 years now. Yeah, 19 years is a big time. Though it feels like 50, but at least 19 is there. Yeah. We are blessed with a daughter and a son. They are twins. Okay. Radhika is a banker who's earned a professor and still teaching banking is still teaching banking. I've been in sales and marketing for the last close to 30 years now. I worked in the pharma, in the FMCG, and for the last 24 years I've been in the building industry in sales and marketing. But that's not what brings me here. What brings me here is, you know, that we are talking on something which is never spoken about. Matter of fact, when I was called upon and said that you can come here and speak about this, even I was hesitant. The only reason I was hesitant is because what I find is most communities speak inwards. You know, you find doctors speaking to doctors, counselors speaking to counselors, but the people who are affected, are they speaking to each other? And when they speak, there are only whispers. There are no bold talks. There is nobody who speaks aloud about it. And why don't they speak about it? Because they carry sort of a stigma. I hope what I share with you today, my journey, our journey, Radhika and my journey, it helps people who are looking out for that ray of hope, and they catch on that and they are able to improve themselves. Okay. With that, let me start. I'm actually going to say that there is hope in art. When you say art, it means ART. ART stands for artificial reproductive techniques. Okay, and it engulfs everything. It engulfs something where you just counsel to going in for some high-end treatments too. Okay, but I'll not be talking more about ART. I'm talking about our journey. Radhika and me got married in 2005, and when we got married, you know, our priorities were very different. Our priority was not to expand our family at that time, but our priority at that time was probably to set our lives well, set the stage well for the life to be better. It took us 3-4 years before we could even think of conceiving. In 2008, okay, that's when we first thought that we should start conceiving. We started trying. Believe me, 2008, 2009, 2010, 2011, it took us 3-4 years to realize that it is not just about us, but we might need some assistance. And in those times, assistance, was it available? Yes. But as I said, it was all undercovers, not something that was very open, not something that I could go and speak to my friend who is sitting next to me, but I had to keep it very, very quiet, you know, and that's where we started. Is there something wrong about looking at assistance? I don't think so. But the problem is that we cannot speak about it. And that's what I would say to people who are actually looking out for assistance, that the first thing that you need to do is accept that you need this assistance. This assistance is not bad. It only helps you to live better, to become better. When we started going to doctors, we went to many doctors. Believe me, we went to many doctors. Some doctors pointed us in a certain direction, some others pointed in a different direction, but it took us some time to settle out and meet with a doctor who also became our friend over a period of time. And this is when we were in Pune. I'm talking of about 2011-12, and that's when the doctors started speaking to us. They shown us that, you know, it is possible, you can go through it, and you all will be successful, you all can conceive. With that hope, we started. We went through many things. We went through IUIs, multiple IUIs. We went through, I don't even know the name of the treatment, but we went through one more treatment, and then we also went through IVF. And when all these things failed, then the doctor said there is something else. We need to delve a little deeper. A deeper study showed us that, you know, there was a small medical condition which needed some treatment. And once that treatment is done, then we could probably look at IUI again. And that's exactly the time when my job got transferred from Pune to Bangalore, and we had to shift to Bangalore. We came to Bangalore, but we still continued consultation with the doctor. We took a reference back in Bangalore over here. She gave a very good reference, and we met up with that gynec as well. The gynec said, okay, you go out, finish this small treatment and come back. We went. That treatment takes 6 months. That was a 6 months treatment. We shifted here in September of 2013. We started the treatment somewhere, I think, in the Jan of 2014. And in the June of, towards the end of June or July, towards the end of June, I think, yes, we finished that treatment of 6 months. And after that, we went in for another round of IUI. And believe me, this time it was very, very difficult. It was difficult not only from the perspective of what we went through, but also what my wife went through at that point in time. And that's where I would say that this is something that I would share to all husbands, to all partners who want to conceive together. You have to be with your partner. There was not one IUI, not one IVF, not one treatment where Radhika has gone alone. I was always there with her. Was it easy? Absolutely not. You manage your profession, you manage your family, you manage your priorities, you have to manage this part of your partnership also. Is it easy? Easy? Absolutely not. But you still need to do it. And I think that is where the commitment comes. You need to be persistent about this. You cannot say, ke, aaj hua, kal nahi hua. And then, so you just leave it at somewhere in between. The moment you lose that persistence, you will lose hope. And the moment you lose hope, you find a dead end. But you continue doing what the doctors are guiding you to do, somewhere you will find that spark coming through. It took us 3-4 years to do this. At a point when, as I was saying, the last treatment that the IUI we went through, at that point, Radhika and me were at our wits' end, and we were at a point that if it doesn't happen this time, we will move from this and probably look at options of probably adoption. That is a time when we had got so worked up that we said we need a trip. So we went out for a trip. We went off to Coorg. We went off on a off-roading trip over there. We did all those things. We came back, and Radhika was in a lot of pain. And that is when we went to the doctor, and we got a earful from the doctor, because the doctor said, you all don't have brains, you all have conceived, and you all have been going around on off-roading trips. Believe me, what we didn't know was that all the hope that we carried had borne fruit, but it is just that we were about to give up hope. So all that I'm saying is, when you look at ART, when you look at artificial reproductive techniques, there are so many which are available. But the one thing which you need to have inside of you is something called as hope, and keep that hope alive. And that hope is not only about the wife holding it or the husband holding it. It's about both holding it together. Sometimes the husband goes down, the wife holds him together. Sometimes the wife goes down, the husband holds her together. But isn't that called a family? Isn't that a partnership? And I think that's what I wanted to share with you all. That keep your hope alive. And I'm very sure that many people can benefit from this. I worked in the pharma industry. I know how the pharma industry is developing more and more techniques with which this can become even more easier. But at the same time, with nature and with the type of lifestyles we live. I was hearing the doctor just before my speech, and she was talking about lifestyles, she was talking about diets, she was talking about so many things over here. And I'm very sure that today couples are wanting to conceive, but they are not wanting to look at the other aspects of it. And we had to look at all these aspects to just reach a point where we conceive. And beyond conception is another journey. But I think that's left for another time to speak about. But today my speech is all about hope, and hope in ART. I hope I have given some inspiration to somebody who's been looking out, and with that I'm done. Back to the host. Thank you so much.
Thank you so much, Sachin. I think in times where we have to openly speak about such topics, normalize such things, people who have actually got benefits from IVF and other fertility techniques, they literally don't want to share it out of the world. But thank you so much, Mr. Sachin, for taking time out and for coming forward and sharing with us, so that many other Sachins can come forward and share their story and everybody can avail the benefits of artificial techniques as well. Perfect. Thank you so much. I now request Archana Ravikumar ma'am to kindly come forward to give away a memento to Mr. Sachin. Can we all give a huge round of applause? This testimonial was very, very important, ladies and gentlemen. This was very much important, and thank you so much, Sachin, for coming forward. Thank you so much, ma'am. Ladies and gentlemen, and the ones who've been watching us virtually, you all have been an excellent audience. I'm going to tell you the second half of the day before we break for lunch is going to be amazing. I want all of you to stay back. As responsible citizens of the country, we also need to know about donors, surrogacy, legal frameworks, child adoption. All these things will be discussed post-lunch. We are also going to discuss about optimal weight management for better and natural assisted pregnancy success. And the most important segment, which is child adoption, that will also be covered post-lunch. So I request all of you to kindly stay back. The lunch is served, so you all can break for lunch now. We are at The Path to Parenthood by Newsfirst Prime, an initiative by Newsfirst Prime, co-sponsored by Garbhagudi IVF Center, supported by the Ministry of Health and Family Welfare, Government of Karnataka, organized by Brand First, knowledge partner Vyli Health. Thank you so much, everyone. Let's all break for lunch now.
Good morning. First of all, I'd like to thank Newsfirst, Mr. Ashutosh and his team, and all the various companies, Brand First, Vyli, etc., etc. So many companies have come together to put together this wonderful initiative, Path to Parenthood, which I think is focusing on bringing about a lot of awareness to the public. And I think it's an excellent initiative, and congratulations to you all. Thank you for inviting me here today for presenting my talk on innovating the path to parenthood. Now,
ಪೋಷಕರಾಗೋಲಕ್ಕೆ ಇರುವಂತಹ ಹಾದಿಯಲ್ಲಿ ಸವಾಲುಗಳು ಸಾಕಷ್ಟಿರುತ್ತೆ. ಆ ಸವಾಲುಗಳನ್ನ ಎದುರಿಸೋದು ಹೇಗೆ, ಎಮೋಷನಲಿ ಅವುಗಳನ್ನ ಆ ಎಮೋಷನ್ಸ್ಗಳನ್ನ ಯಾವ ರೀತಿಯಾಗಿ ಬ್ಯಾಲೆನ್ಸ್ ಮಾಡಬೇಕು, ಈ ಎಲ್ಲ ವಿಚಾರಗಳ ಬಗ್ಗೆ ತಿಳಿಸ್ಕೊಡೋದಕ್ಕೆ ನಮ್ಮ ಜೊತೆಗೆ ಪಾತ್ ಟು ಪೇರೆಂಟ್ಹುಡ್ ನ ಕಾರ್ಯಕ್ರಮದ ಮುಖ್ಯ ಅತಿಥಿಯಾಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಯೋಗೀಶ್ ಅವರಿದ್ದಾರೆ. ಅವ್ರನ್ನ ಮಾತನಾಡಿಸ್ತಾ ಹೋಗ್ತೀನಿ. ಖುಷಿ ಫರ್ಟಿಲಿಟಿ MD ಕೂಡ ಹೌದು ಅವರು. ಅವ್ರನ್ನ ಮಾತನಾಡಿಸ್ತಾ ಹೋಗ್ತೀನಿ. ಮೇಡಮ್ ಹಾಯ್. ಮೊದಲನೇದಾಗಿ ತುಂಬಾ ಚೆನ್ನಾಗಿ ಬ್ಯೂಟಿಫುಲ್ ಆಗಿ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡಿದ್ರಿ. ಸೊ ಈ ಬಂಜೆತನಕ್ಕೆ ಆಗುವಂತಹ ಸಮಸ್ಯೆಗಳೇನು?
ಮೊದಲನೇದಾಗಿ ಬಂಜೆತನ ಅಂತ ವರ್ಡೇ ನನಗೆ ಇಷ್ಟ ಆಗೋದಿಲ್ಲ. ಹೆಣ್ಮಕ್ಳಿಗೆ ಮಗು ಆಗೋದಕ್ಕೆ ತೊಂದರೆ ಆದ್ರೆ ಅಥವಾ ಒಂದ್ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಸಮಯ ತಗೊಂಡ್ರೆ ಅದಕ್ಕೆ ಅವಳಿಗೆ ನಿನ್ಗೆ ಮಗು ಆಗ್ತಾ ಇಲ್ಲ ಅಂತ ಯಾರಾದ್ರೂ ಹೇಳಿದ್ರೆ ಅದೇ ಒಂದು ದೊಡ್ಡ ಅಪರಾಧ ಅನ್ಸುತ್ತೆ. ಎಷ್ಟು ಒಂದು ಹೆಣ್ಣಿನ ಮನಸ್ಸಿಗೆ ಇದರಿಂದ ನೋವಾಗುತ್ತೆ ಅನ್ನೋದು ನಾವು ಶಬ್ದಗಳಲ್ಲಿ ಹೇಳಕ್ ಆಗೋದಿಲ್ಲ. ಯಾವುದೇ ಒಂದು ಜನ್ಮ ಅಂತ ತಾಳ್ಕೊಂಡಾಗ ನಮ್ಮ ದೇಹಕ್ಕೆ ಯಾವುದಾದ್ರೂ ಒಂದು ತೊಂದರೆ ಬಂದೇ ಬರುತ್ತೆ. ಇವತ್ತಿಲ್ಲೋ ನಾಳೆ ಬರುತ್ತೆ ನಮ್ ಲೈಫ್ ಸ್ಪ್ಯಾನ್ ಅಲ್ಲಿ. ಅದೇ ತರಹ ಎಲ್ಲಾ ಈ ತೊಂದರೆಗಳಿರ್ತವೆ. ಮಧುಮೇಹ, ಡಯಾಬಿಟೀಸು, ಮತ್ತೆ ಬ್ಲಡ್ ಪ್ರೆಷರ್ ಜಾಸ್ತಿ ಇರೋದು, ಹೈಪರ್ ಟೆನ್ಷನ್, ಇವ್ ಎಲ್ಲಾ ಪ್ರಾಬ್ಲಮ್ ತರ ಹೆಣ್ಮಕ್ಳಿಗೆ ಮಗು ಆಗೋದಕ್ಕೆ ಕಷ್ಟ ಆಗೋದು ಒಂದು ಸಹಜ. ಇವಾಗ ಇರೋ ಲೈಫ್ ಸ್ಟೈಲ್ ಇಶ್ಯೂಸ್ ಗಳಿಂದ ಹೆಣ್ಮಕ್ಳಿಗೆ ಅಂಡಾಣುಗಳ ಸಂಖ್ಯೆ ತುಂಬಾ ಬೇಗ ಕಡಿಮೆ ಆಗ್ತಾ ಇದೆ. ಅದರಿಂದ ಅವ್ರಿಗೆ ತುಂಬಾ ಕಷ್ಟ ಆಗ್ತಾ ಇದೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗೋದಕ್ಕೆ, ಎಸ್ಪೆಷಲಿ ವೆನ್ ದೇ ಆರ್ ಪೋಸ್ಟ್ಪೋನಿಂಗ್ ದಿಯರ್ ಪ್ರೆಗ್ನೆನ್ಸಿ. ಹೆಣ್ಮಕ್ಳಿಗೆ ಮೊದಲು 15-16 ವರ್ಷದಲ್ಲಿ ಆ ಟೈಮಲ್ಲಿ ಅವ್ರಿಗೆ ಹೆಣ್ಮಕ್ಳು ವಯಸ್ಸಿಗೆ ಬರ್ತಾ ಇದ್ರು. ಇವಾಗ 10 ವರ್ಷದ ವಯಸ್ಸಲ್ಲಿ, 9 ವರ್ಷದ ವಯಸ್ಸಲ್ಲಿ ವಯಸ್ಸಿಗೆ ಬರ್ತಾ ಇದ್ದಾರೆ. ಕೆಲವೊಂದ್ಸತಿ ನಾವು ಕೆಲವೊಂದು ಇಂಜೆಕ್ಷನ್ಸ್ ನ ಕೊಟ್ಟು ಈ ವಯಸ್ಸಿಗೆ ಬಂದಿರೋ ಹುಡುಗಿಯರಿಗೆ ಅವರ ಎಗ್ ರಿಸರ್ವ್ ಇನ್ನೂ ಸ್ವಲ್ಪ ಚೆನ್ನಾಗಿರ್ಬೇಕು ಅಂತ ಕೆಲವೊಂದು GnRH ಅಗಾನಿಸ್ಟ್ ಇಂಜೆಕ್ಷನ್ ನ ಮಂತ್ಲಿ ಒನ್ಸ್ ಕೊಟ್ಟು ಅವರ ಪೀರಿಯಡ್ಸ್ ಸ್ಟಾರ್ಟ್ ಆಗೋದನ್ನ ಡಿಲೇ ಕೂಡ ಮಾಡ್ತಾ ಇದೀವಿ. ಇಂಥ ಪರಿಸ್ಥಿತಿಗೆ ನಾವು ಯಾಕೆ ಬಂದಿದೀವಿ ಅಂತ ಹೇಳ್ಬೇಕಾದ್ರೆ ಇಟ್ ಇಸ್ ಬಿಕಾಸ್ ಆಫ್ ಅವರ್ ಲೈಫ್ ಸ್ಟೈಲ್. ಅವರ್ ಲೈಫ್ ಸ್ಟೈಲ್ ಅನ್ನೋದಕ್ಕೆ ವೆಸ್ಟರ್ನೈಸೇಷನ್ ಆಫ್ ಅನ್ ಇಂಡಿಯನ್ ಲೈಫ್ ಸ್ಟೈಲ್. ನಮ್ಮ ಇಂಡಿಯನ್ ಹೆಣ್ಮಕ್ಳು ಯಾವ ಊಟ ತಿನ್ಬೇಕು, ಯಾವ ತರ ಇರಬೇಕು, ಅದೇ ತರ ಇದ್ರೆ ಅದು ನಮ್ಮ ಜೀನ್ಸ್ಗೆ ಸೂಟ್ ಆಗುತ್ತೆ. ವೆಸ್ಟರ್ನ್ ಹೆಣ್ಮಕ್ಳು ಆಲ್ಕೋಹಾಲ್ ತಗೋಬಹುದು, ಸಿಗರೆಟ್ ಸ್ಮೋಕ್ ಮಾಡಬಹುದು, ಆದ್ರೆ ಅದರಿಂದ ಅವ್ರಿಗೆ ಅಷ್ಟು ಬೇಗ ಎಗ್ ರಿಸರ್ವ್ ಕಡಿಮೆ ಆಗೋದಿಲ್ಲ. ಅವ್ರ ಜೀನ್ಸ್ಗೆ ಅದು ಸೂಟ್ ಆಗುತ್ತೆ. ನಮ್ಮ ಇಂಡಿಯನ್ ಹೆಣ್ಮಕ್ಳಿಗೆ ಆಲ್ಕೋಹಾಲ್ ತಗೊಳ್ಳೋದಾಗ್ಲಿ, ಸಿಗರೆಟ್ ಸೇದೋದಾಗ್ಲಿ, ಅದು ನಮ್ಮ ಜೀನ್ಸ್ಗೆ ಸೂಟ್ ಆಗೋದಿಲ್ಲ. ಇದರಿಂದ ಸಿಗರೆಟ್ ಸ್ಮೋಕಿಂಗ್ ಇಸ್ ಒನ್ ಆಫ್ ದ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಕಾಸ್ ಫಾರ್ ರೆಡ್ಯೂಸ್ಡ್ ಓವೇರಿಯನ್ ರಿಸರ್ವ್. ಎವ್ರಿ ಗರ್ಲ್ ಶುಡ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ದಿಸ್. ಒಂದ್ ಪಬ್ಗೆ ಹೋಗ್ಬಿಟ್ಟು ಆಲ್ಕೋಹಾಲ್ ತಗೊಂಡು ಸಿಗರೆಟ್ ನ ಸ್ಮೋಕ್ ಮಾಡ್ಬಿಟ್ರೆ ಅವರು ಮಾಡರ್ನ್ ಆಗೋದಿಲ್ಲ. Modern in their way of thinking is required, but not showing this as modern, because it is not suiting us and it is not doing any help to us. You will not believe cosmetics, nail polish, hair color, all of these are doing harm, because of which their ovarian reserve or egg reserve is coming down. Idana artha ಮಾಡ್ಕೊಳ್ಳೋದು ಅತಿ ಮುಖ್ಯ. ಹೆಣ್ಣು ಮಕ್ಕಳು ಚಿಕ್ಕ ವಯಸ್ಸಿನಿಂದನೇ ಇದನ್ನೆಲ್ಲ ಅರ್ಥ ಮಾಡ್ಕೊಂಡ್ರೇನೆ ನಮ್ಗೆ ಈ ಹೆಣ್ಮಕ್ಳು ಬೇಗ ವಯಸ್ಸಿಗೆ ಬರೋದನ್ನ ನಾವು ತಡಿ ಹಿಡಿಬಹುದು. ಏನಕ್ಕಂದ್ರೆ ಹೆಣ್ಮಕ್ಳು ದೇ ಆರ್ ಬಾರ್ನ್ ವಿತ್ ಅ ಫಿಕ್ಸ್ ನಂಬರ್ ಆಫ್ ಓಸೈಟ್ಸ್. ಇವತ್ತು ನಮ್ಗೆ ಇಷ್ಟು ಎಕ್ಸ್ ಇದೆ ಅಂತಂದ್ರೆ ನಮ್ಮ ಇಡೀ ಜೀವಮಾನಕ್ಕೆ ಅಷ್ಟೇ ಎಕ್ಸ್. ಬೇಗ ಮುಟ್ಟು ಸ್ಟಾರ್ಟ್ ಆಗ್ಬಿಟ್ರೆ ಬೇಗ ಮುಟ್ಟು ನಿಂತು ಹೋಗುತ್ತೆ. ಬೇಗ ಮುಟ್ಟು ಸ್ಟಾರ್ಟ್ ಆದ್ರೆ ಮಗು ಬೇಕು ಅಂತ ಆಸೆ ಇರೋರು ಬೇಗ ಮಗು ಮಾಡ್ಕೊಳ್ಬೇಕು ಅಂತ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳೋ ಸಮಯ ಇದು. ಹೆಣ್ಣು ಮಕ್ಕಳಿಗೆ ಈ ನಾಲೆಜ್ ಕೊಡೋದೇ ನಮ್ಮ ಕರ್ತವ್ಯ. Path to Parenthood. This is a very, very good initiative with which we are trying to tell the world that taking treatment for infertility or subfertility is nothing but path to parenthood. You are actually walking towards a good cause. You are trying to have a child. There is nothing to hide. There is nothing to feel bad that you are entering into a fertility center. You are doing something good. You're trying to create a family. And what is wrong in trying to create a family? You can create a family with your own eggs and sperms. So why not go ahead? And we have so many advancements nowadays. Regenerative medicine in the intra-ovarian PRP, intra-ovarian stem cell therapy, idella ಮಾಡ್ಬಿಟ್ಟು reduced ovarian reserve ಗೂ ನಾವು ಮತ್ತೆ egg reserve ಹೆಚ್ಚಿಗೆ ಮಾಡೋ ತರ ಮಾಡ್ಬಿಟ್ಟು ಅವರು ಸ್ವತಃ eggs and sperms ಅಲ್ಲಿ ಮಗು ಮಾಡಕ್ಕೆ ಎಷ್ಟೆಲ್ಲ ಸೌಲಭ್ಯಗಳು ಇರುವಾಗ I don't think somebody should get scared or feel ashamed to enter into a fertility center. It's my right to have a child, and if I want to do something for myself, why should I hesitate? ಈ ಮಾಡರ್ನ್ ಥಿಂಕಿಂಗ್ ಬರಬೇಕೇ ಹೊರತು ಬೇರೆ ಮಾಡರ್ನ್ ಮೆಥಡ್ಸ್ ಶುಡ್ ನಾಟ್ ಕಮ್ ಇನ್ ಟು ದಿಯರ್ ಮೈಂಡ್ಸ್.
ಮ್ಯಾಮ್ ನಿಮ್ಮ ಮಾತನ್ನ ಕೇಳ್ತಾ ಇದ್ರೆ ಕೇಳ್ತಾನೆ ಇರೋಣ ಅನ್ಸುತ್ತೆ. ಬಟ್ ನಂದು ಇನ್ನೊಂದು ಕ್ವಶನ್ ಇದೆ. ನೀವು ಮಾತಾಡ್ಬೇಕಾದ್ರೆ ಮೆನ್ಷನ್ ಮಾಡಿದ್ರಿ ಕುಡಿಯೋದ್ರಿಂದಾಗ್ಲಿ, ಸಿಗರೆಟ್ ಸೇದೋದ್ರಿಂದಾಗ್ಲಿ ಅಥವಾ ಕಾಸ್ಮೆಟಿಕ್ಸ್ ಇಂದಾಗ್ಲಿ ಇವೆಲ್ಲವೂ ಕೂಡ ಇನ್ಫರ್ಟಿಲಿಟಿಗೆ ಲೀಡ್ ಮಾಡುತ್ತೆ ಅಂತ. ಸೊ ಅದನ್ನ ಒಂದ್ ಸ್ವಲ್ಪ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡ್ಬೋದಾ? ಕುಡಿಯೋದು ಮತ್ತೆ ಕಾಸ್ಮೆಟಿಕ್ಸ್ ಯಾವ ತರ ಸಮಸ್ಯೆ ಆಗುತ್ತೆ ಅಂತ.
ಆಕ್ಚುಲಿ ನಾನು ಹೇಳ್ದಂಗೆ ಸಿಗರೆಟ್ ಸ್ಮೋಕಿಂಗ್ ಇಂದ, ಈ ಟೊಬ್ಯಾಕೋ ಇಂದ AMH ಕಡಿಮೆ ಆಗುತ್ತೆ. AMH ಅಂದ್ರೆ ಇಟ್ ಈಸ್ ಲೈಕ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡಿಂಗ್ ವಾಟ್ ಈಸ್ ಯೋರ್ ಬ್ಯಾಲೆನ್ಸ್ ಆಫ್ ಎಗ್ಸ್ ಇನ್ ಯೋರ್ ಬಾಡಿ. ಎಗ್ ಬ್ಯಾಲೆನ್ಸ್ ಕಡಿಮೆ ಆಗ್ಬಿಟ್ರೆ ಬೇಗ ಮುಟ್ಟು ನಿಂತು ಹೋಗುತ್ತೆ ಹೆಣ್ಮಕ್ಳಿಗೆ. ಈ ಎಗ್ ಡಿಸ್ಟ್ರಕ್ಷನ್ ಆಗೋದೇ ಸಿಗರೆಟ್ ಸ್ಮೋಕ್ ಇಂದ. ದಟ್ ಈಸ್ ವೈ ದ ಫಸ್ಟ್ ಥಿಂಗ್ ಅಂಡ್ ದ ಫಸ್ಟ್ ರಿಕ್ವೆಸ್ಟ್ ಟು ಆಲ್ ದ ಲೇಡೀಸ್ ಔಟ್ ಹಿಯರ್ ಇಸ್ ಪ್ಲೀಸ್ ಡೋಂಟ್ ಸ್ಮೋಕ್. ಇಫ್ ಯು ಆರ್ ಎನ್ ಇಂಡಿಯನ್, ಪ್ಲೀಸ್ ಡೋಂಟ್ ಸ್ಮೋಕ್ ಬಿಕಾಸ್ ಇಟ್ಸ್ ನಾಟ್ ಗೋಯಿಂಗ್ ವೆಲ್ ವಿತ್ ಯೋರ್ ಜೀನ್ಸ್. ಎಗ್ ರಿಸರ್ವ್ ನ ಕಾಪಾಡ್ಕೊಳ್ಳೋದು ಬಹಳ ಮುಖ್ಯ. ಅದು ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಥಿಂಗ್. ಎರಡನೇದಾಗಿ ಕೆಲವೊಂದ್ಸತಿ ಕೆಲವೊಬ್ರು ಹೆಣ್ಮಕ್ಳು ಆಲ್ಕೋಹಾಲ್ನ ಒಂದು ಸ್ಟ್ರೆಸ್ ಬಸ್ಟರ್ ತರ ಟ್ರೀಟ್ ಮಾಡ್ತಾರೆ. ಬಟ್ ಇಟ್ ಇಸ್ ನಾಟ್ ದ ಥಿಂಗ್. ಮೊದ್ಲಿನ ಕಾಲದಿಂದ ನಮ್ಮ ಹೆಣ್ಮಕ್ಳು ವೆನೆವರ್ ದೇ ಹ್ಯಾವ್ ಬೀನ್ ಸ್ಟ್ರೆಸ್ಡ್, ಅವ್ರು ಮಾಡಿರೋದೇನು ದೇವಸ್ಥಾನಕ್ಕೆ ಹೋಗಿ ಪೂಜೆ ಮಾಡೋದು ಅಂಡ್ ಟಾಕಿಂಗ್ ಟು ಪೀಪಲ್. ಇವೆರಡೂ ಇಸ್ ದೇರ್ ಇಂಬೈಬ್ಡ್ ಇನ್ ಅಸ್. ದಟ್ ಇಸ್ ವೈ ವಿ ಆರ್ ನೌ ಟೆಲಿಂಗ್ ಪೀಪಲ್, ಮೊದ್ಲಿನ ತರ ನಾವು ದೇವಸ್ಥಾನದಲ್ಲಿ ಹೋಗಿ ಕೂತು ಪೂಜಾರಿಗಳ ಜೊತೆಗೆ ಮಾತಾಡಕ್ ಆಗದೆ ಇದ್ರೆ ಇವಾಗಿನ ಜನರೇಷನ್ ಅಲ್ಲಿ ಯು ಶುಡ್ ಸ್ಟಾರ್ಟ್ ಮೆಡಿಟೇಟಿಂಗ್ and you should start connecting yourself with God, and you should try and talk to counselors. There is nothing wrong in going and approaching a counselor. ತುಂಬಾ ಜನ ಹೆಣ್ಮಕ್ಳು ಇವಾಗ ಏನ್ ಮಾಡ್ತಾರೆ, they don't want to share their problems with anybody because they are all independent, they are working, they are financially independent. ಅವರಲ್ಲಿರೋ negative points na athwa what they are going through, they don't want to expose and tell others. At the same time, they should also realize that there is nothing wrong in going and talking to a counselor, telling what they feel to a counselor who can give them the confidence. And I'm sure every counselor, every psychological counselor has it in them to keep it very confidential. ಅವ್ರಿಗೆ ಹೇಳಿರೋದನ್ನ ಇನ್ನೊಬ್ಬರ ಮುಂದೆ ಅವರು ಖಂಡಿತವಾಗೂ ಶೇರ್ ಮಾಡೋದಿಲ್ಲ. ಇದನ್ನ ಅರ್ಥ ಮಾಡ್ಕೊಂಡು ಕೌನ್ಸಿಲಿಂಗ್ ಅನ್ನೋದನ್ನ ಎಕ್ಸೆಪ್ಟ್ ಮಾಡ್ಕೊಳ್ಳೋದು ಬಹಳ ಮುಖ್ಯ. ಇದರಿಂದ ಸ್ಟ್ರೆಸ್ ಲೆವೆಲ್ಸ್ ಕಮ್ಮಿ ಆಗುತ್ತೆ. ಇವತ್ತಿನ ಜನರೇಷನ್ ಅಲ್ಲಿ ಡಿಪ್ರೆಷನ್ ರೇಟ್ಸ್ ಆರ್ ವೆರಿ ಹೈ. the incidence of suicides have increased so much. ಇದನ್ನೆಲ್ಲ ತಡೆ ಹಿಡಿಬೇಕು ಅಂತಂದ್ರೆ psychological counseling should be given the utmost importance, and I think programs like Path to Parenthood will make every couple realize that going to a fertility center, taking help from psychologists and counselors is something which is very natural and there is nothing wrong in doing it. I feel these are the most important things that have to be focused on in today's date.
Thank you so much. ತುಂಬಾ ಚೆನ್ನಾಗಿ ಮಾತಾಡಿದ್ರಿ. Thank you so much.
Thanks for the opportunity. And yes, people, check your fertility score. Try and understand where you stand in this, whether your ovarian reserve is good and your sperm counts are good, and then only postpone the pregnancy. Think about conception before contraception. This is one message to everybody. And my talk will not be complete if I have not addressed on a very, very important topic. The important topic is erectile dysfunction. Even generationally, because of the stress men go through for the kind of work they do, and because of the targets they have in their professional life, and because of inability to face multifaceted challenges in their life, they have problems with erection, and this is something which is not talked about. Erectile dysfunction is common, but people don't know that it is common because it cannot be openly spoken. That is why men should not hesitate when they have erectile dysfunction, and they should not feel that they are losing their self-esteem in front of their wife and try to avoid having sex at all. That is something which has to be taken as a natural phenomenon. Try to work towards it by doing things like regular exercises. You can take medical help. Try and understand. Sometimes diabetes is a very important cause for erectile dysfunction. People are not aware of this. Erectile dysfunction iddaga, checking your blood sugar levels is the most important aspect that has to be given importance to. That is why seeing a doctor in such situations will make things easier. ಇದು ಒಂದೇ ಒಂದು ಫ್ಯಾಕ್ಟರ್ ಇರೋದಕ್ಕೆ ಹೆಣ್ಮಕ್ಳನ್ನ ಹಾಸ್ಪಿಟಲ್ಗೆ ಕರ್ಕೊಂಡು ಹೋಗ್ಲಾರ್ದೇ ಇದ್ದು ತುಂಬಾ ಸಮಯ ಆದ್ಮೇಲೆ ಹೆಣ್ಮಕ್ಳನ್ನ ಹಾಸ್ಪಿಟಲ್ ಕರ್ಕೊಂಡು ಹೋಗಿ ನಮ್ಗೆ ಮಗು ಬೇಕು ಅಂತ ಕೇಳಿದಾಗ ಹೆಣ್ಮಕ್ಳ ವಯಸ್ಸು ಮೀರಿ ಹೋಗ್ಬಿಡುತ್ತೆ. ಆದ್ರಿಂದ ಇದೆಲ್ಲ ಪ್ರಾಬ್ಲಮ್ಸ್ ನ ಒಂದು ಕಾಮನ್ ಸಿಚುವೇಶನ್ ಅಂತ ಅನ್ಕೊಂಡು trying to shun the ego and going ahead for treatments is something very, very important. And I thought if I don't talk about this, it will not be complete. Thank you.
ಸೊ ಇದಿಷ್ಟು ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಅವರು ನ್ಯೂಸ್ ಫಸ್ಟ್ ಗೆ ಹೇಳ್ತಾ ಇರುವಂತಹ ಮಾಹಿತಿ. ಅಂದ್ರೆ ಕೇಳಿದ್ರಲ್ಲ, ಸ್ಟ್ರೆಸ್ ಅಂತ ಸಿಗರೇಟ್ ಸೇದಬಾರ್ದು, ಫ್ಯಾಷನ್ ಅಂತ ಕುಡಿಯೋಕ್ ಹೋಗ್ಬಾರ್ದು. ಇವೆಲ್ಲವನ್ನ ಮಾಡ್ಕೊಂಡ್ರೆ ಅಂದ್ರೆ ನಮ್ಮ ಲೈಫ್ ಸ್ಟೈಲ್ ನ ಬೇರೆಯವ್ರಿಗೋಸ್ಕರ ಅಥವಾ ಯಾರೋ ನೋಡ್ತಾರೆ ಅಂತ ಚೇಂಜ್ ಮಾಡ್ಕೊಳಕ್ ಹೋದ್ರೆ ಅದು ಕೂಡ ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ಸಮಸ್ಯೆ ಆಗುವಂತಹ ಸಾಧ್ಯತೆ ಇದೆ ಅನ್ನುವಂತಹ ಮಾಹಿತಿಯನ್ನ ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಅವರು ನ್ಯೂಸ್ ಫಸ್ಟ್ ಜೊತೆಗೆ ಹಂಚ್ಕೊಳ್ತಾ ಇದ್ರು. ಕ್ಯಾಮರಾಮನ್ ಚಂದ್ರೇಶ್ ಜೊತೆ ಪ್ರಗತಿ ಶೆಟ್ಟಿ, ನ್ಯೂಸ್ ಫಸ್ಟ್, ಬೆಂಗಳೂರು. ಲೈಫ್ ಸ್ಟೈಲ್ ಬದಲಾಗ್ತಾ ಇರೋ ಈ ಕಾಲದಲ್ಲಿ ಪೋಷಕರಾಗೋದೇ ಒಂದು ದೊಡ್ಡ ಸವಾಲಿನ ಕೆಲಸ ಅಂತ ಹೇಳ್ತಾರೆ. ಆದ್ರೆ ಈ ಹಾದಿಯಲ್ಲಿ ನಮಗೆ ಸಾಕಷ್ಟು ಸೈನ್ಸ್ ಆಗ್ಲಿ, ಟೆಕ್ನಾಲಜೀಸ್ ಆಗ್ಲಿ, ಇವೆಲ್ಲವೂ ಕೂಡ ಸಪೋರ್ಟ್ ಮಾಡ್ತಾ ಹೋಗುತ್ತೆ. ಇದ್ರ ಬಗ್ಗೆ ಮಾತನಾಡೋದಕ್ಕೆ ನನ್ನ ಜೊತೆಗೆ ಫರ್ಟಿಲಿಟಿ ಎಕ್ಸ್ಪರ್ಟ್ ಆಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ಗುಣಶೀಲ ಅವರಿದ್ದಾರೆ. ಅವ್ರನ್ನ ಮಾತನಾಡಿಸ್ತಾ ಹೋಗ್ತೇನೆ. ಮೇಡಮ್, ಮೊದಲನೇದಾಗಿ ಯಾವ್ಯಾವ ರೀತಿಯಾದಂತಹ ಅಡ್ವಾನ್ಸ್ ಟೆಕ್ನಾಲಜಿ ಅಥವಾ ಸೈನ್ಸ್ ಇವಾಗ ಸದ್ಯ ಇರುವಂತದ್ದು?
ಸದ್ಯಕ್ಕೆ ಇರೋದು ತುಂಬ ಟೆಕ್ನಾಲಜೀಸ್ ಇವೆ. 1990ಸ್ನಲ್ಲಿ 1978ನಲ್ಲಿ ಈ ಪ್ರಪಂಚದಲ್ಲಿ ಫಸ್ಟ್ IVF ಬೇಬಿ ಹುಟ್ಟಿದ್ದು ಲೂಯಿಸ್ ಬ್ರೌನ್ ಅಂತ. ಅದಾದಮೇಲೆ ಸೈನ್ಸ್ ಎಷ್ಟು ಡೆವಲಪ್ ಆಗಿದೆ ಅಂತಂದರೆ ಅದು ಹೇಳೋಕ್ಕೆ ಆಗಲ್ಲ. ಆ್ಯಂಡ್ ಇನ್ನೂ ಮುಂದೆ ಎಷ್ಟು ಡೆವಲಪ್ ಆಗುತ್ತೆ ಅಂತ ಅದನ್ನ ಸುಮ್ಮನೆ ನಾವು ನೋಡಬೇಕು. ಒಂದು ಪಿಕ್ಚರ್ ನೋಡೋ ಹಾಗೆ ಆಗುತ್ತೆ, ಫಿಲ್ಮ್ ನೋಡೋ ಹಾಗೆ, ಸೈನ್ಸ್ ಫಿಕ್ಷನ್ ಫಿಲ್ಮ್ ನೋಡೋ ಹಂಗೆ ಆಗುತ್ತೆ. ಬಟ್ ಅದೇನಂತಂದರೆ ಇವಾಗ ಐ ವಿ ಎಫ್ನಲ್ಲಿ ನಾವು ಒಂದು ಅಂಡನ್ನು ತೊಗೊಂಡು ಅದ್ರ ಮೇಲೆ ಒಂದು ಮೈಕ್ರೋ ಡ್ರಾಪ್ಲೆಟ್ ಅಂದರೆ 50,000 ಅಷ್ಟು ಸ್ಪರ್ಮ್ ನಾವು ಹಾಕ್ತೀವಿ. ಒಂದು ಸ್ಪರ್ಮ್ ಒಳಗಡೆ ಹೋಗಿ ಕೂತ್ಕೋಬೇಕು. ಎಷ್ಟೊಂದು ಸತಿ ಹಂಗೆ ಆಗಲ್ಲ, ಸ್ಪರ್ಮ್ ಹೋಗಿ ಒಳಗಡೆ ಕೂತ್ಕೊಳ್ಳೋದೇ ಇಲ್ಲ. ಸೊ ಅದನ್ನು ಓವರ್ಕಮ್ ಮಾಡೋದಕ್ಕೆ ನಾವು ಇಕ್ಸಿ ಅಂತ ಬಂದಿದೆ. ಇಕ್ಸಿ 1990ನಲ್ಲಿ ಬಂತು, ಸರಿನಾ? ಅದು ಬೆಲ್ಜಿಯಂನಲ್ಲಿ ಅದು ಶುರುವಾಯಿತು. ಆ್ಯಂಡ್ ಅದರಲ್ಲಿ ಅಂಡಾಣು ಒಳಗಡೆ ಆ ವೀರ್ಯನ ನಾವು ಹೋಗಿ ಚುಚ್ತೀವಿ. ಸೊ ಚಾನ್ಸ್ಗೆ ನಾವು ಯಾವುದು ಬಿಡೋಲ್ಲ. ಸೊ ಅದು ಹೋಗಿ ಅಲ್ಲಿ ಕೂತ್ಕೊಂಡು ಅಂಡಾಣು ಜೊತೆಗೆ ಸೇರಬೇಕು. ಸೊ ಅಲ್ಲಿಂದ ಶುರು ಆಗಿ ಇವಾಗ ಎಲ್ಲ ಲ್ಯಾಬ್ಸ್ನಲ್ಲಿ ಇಕ್ಸಿ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಅದ್ರ ಜೊತೆಗೆ ಕೆಲವರಿಗೆ ತುಂಬಾ ಅಂಡಾಣು ಸಿಗುತ್ತೆ. PCO ಪೇಷಂಟ್ಸ್ನಲ್ಲಿ, ಪಾಲಿಸಿಸ್ಟಿಕ್ ಓವರಿ ಪೇಷಂಟ್ಸ್ನಲ್ಲಿ ನಾವು IVF ಮಾಡಬೇಕು ಅಂತಂದರೆ ತುಂಬಾ ಸತಿ ನಾವು ಔಷಧಿ ಹಾಕ್ತೀವಿ. ಔಷಧಿ ಹಾಕಿದಾಗ ಸಿಕ್ಕಾಪಟ್ಟೆ ಜಾಸ್ತಿ ಅಂಡಾಣು ಬರ್ತವೆ. ತುಂಬ ಅಂಡಾಣು ಬರೋದೂ ತಪ್ಪು, ಏನು ಬರದೇ ಇದ್ರೂ ತಪ್ಪು, ಸರಿನಾ? ಸೊ ಹಾಗಾಗಿ ಆ ಥರ ಪೇಷಂಟ್ಸ್ಗೆ ನಾವು ಇಮ್ಮೆಚ್ಯೂರ್ ಎಗ್ಸ್ ಅಂದರೆ ಪೀಚ್ಕಾಯಿ ಥರ ಚಿಕ್ಕ ಇಮ್ಮೆಚ್ಯೂರ್ ಎಗ್ಸ್ ನಾವು ಅಂಡಾಶಯದಿಂದ ತೆಗೆದು ಅದನ್ನು ಲ್ಯಾಬ್ನಲ್ಲಿ ಇನ್ನೂ ಒಂದು ದಿನ ಬೆಳೆಸಿ ಆಮೇಲೆ ಅದಕ್ಕೆ ನಾವು ಸ್ಪರ್ಮ್ ಇಂಜೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ಕ್ಯಾನ್ಸರ್ ಬಂದಿರೋ ಪೇಷಂಟ್ಸ್ಗೆ ಕ್ಯಾನ್ಸರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡೋ ಮುಂಚೆ, ಯಾಕೆಂತಂದರೆ ಕ್ಯಾನ್ಸರ್ ಟ್ರೀಟ್ಮೆಂಟ್ನಲ್ಲಿ ಕೀಮೊಥೆರಪಿ, ರೇಡಿಯೋಥೆರಪಿ ಎಲ್ಲ ಇರುತ್ತೆ. ಅದರಿಂದ ಅವ್ರದ್ದು ಅಂಡಾಶಯದ್ದು ಸ್ಟಾಕ್ ಆಫ್ ಎಗ್ಸ್ ಕಮ್ಮಿ ಆಗುತ್ತೆ, ಅಂಡಾಣುಗಳು ಹಾಳಾಗೋಗ್ತವೆ. ಸೊ ಹಾಗಾಗಿ ಅವ್ರಿಗೆ ನಾವು ಫ್ರೀಸ್ ಮಾಡ್ತೀವಿ ಕ್ಯಾನ್ಸರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡೋ ಮುಂಚೆ, ಫರ್ಟಿಲಿಟಿ ಪ್ರಿಸರ್ವೇಷನ್ ಅಂತ. ಸೊ ಕೀಮೊಥೆರಪಿ ಮಾಡೋ ಮುಂಚೆ ಅಂಡಾಣು ತೆಗೆದು ಫ್ರೀಸ್ ಮಾಡ್ತೀವಿ. ಅಂಡಾಣು ಅಂತಂದರೆ ಮೊಟ್ಟೆ, ವೀರ್ಯಾಣು ತೆಗೆದು ಫ್ರೀಸ್ ಮಾಡ್ತೀವಿ. ಅಥವಾ ಅಂಡಾಶಯ ಮೇಲೆ ಇರೋ ಕಾರ್ಟಿಕಲ್ ಟಿಶ್ಯೂ ಅಂತ, ಆ ಕಾರ್ಟಿಕಲ್ ಟಿಶ್ಯೂನಲ್ಲಿನೇ ಅಂಡಾಣು ಬೆಳೀತಾ ಇರುತ್ತೆ, ಅದನ್ನ ತೆಗೆದು ನಾವು ಫ್ರೀಸ್ ಮಾಡ್ತೀವಿ. ಸೊ ಎಷ್ಟೊಂದು ಇನ್ವೆಷನ್ಸು, ಎಷ್ಟೊಂದು ಪ್ರೋಗ್ರೆಸ್ ಆಗಿದೆ. ಇನ್ನೊಂದೇನಂತಂದರೆ ಕೆಲವು ಫ್ಯಾಮಿಲೀಸ್ನಲ್ಲಿ ಸಿಕ್ಕಲ್ ಸೆಲ್ ಡಿಸೀಸು, ಬ್ಲಡ್ ಪ್ರಾಬ್ಲಮ್ಸು, ಆ ಥರ ಎಲ್ಲ ಇರುತ್ತೆ. ಕೆಲವರಿಗೆ ಸ್ಪೈನಲ್ ಕಾರ್ಡ್ನಲ್ಲಿ ಪ್ರಾಬ್ಲಮ್ಸ್ ಇರುತ್ತೆ, ಸ್ಕೆಲ್ಟಲ್ ಮಸಲ್ನಲ್ಲಿ ಪ್ರಾಬ್ಲಮ್ಸ್ ಇರುತ್ತೆ. ಆ ಫ್ಯಾಮಿಲಿನಲ್ಲಿನೇ ರಿಲೇಷನ್ನಲ್ಲಿನೇ ಮದುವೆ ಆಗ್ತಾ ಇರುತ್ತೆ. ಸೊ ಆ ಥರ ಮಕ್ಕಳು ಹುಟ್ಟುತ್ತವೆ. ಆ ಥರ ಮಕ್ಕಳು ಹುಟ್ಟಬಾರ್ದು ಅಂತ, ಚೆನ್ನಾಗಿರೋ ಮಕ್ಕಳು ಹುಟ್ಟಬೇಕು, ನಮಗೆಲ್ಲರಿಗೂ ಚೆನ್ನಾಗಿರೋ ಮಗುನೂ ಬೇಕು. ಆ ಮಗು ಚೆನ್ನಾಗಿ ಓಡಾಡಬೇಕು, ಮಾತಾಡಬೇಕು, ಎಲ್ಲ ಮಾಡಬೇಕು, ಸ್ಕೂಲಿಗೆ ಹೋಗಬೇಕು. ಸೊ ಆ ಥರ ಮಕ್ಕಳು ಹುಟ್ಟಬೇಕು ಅಂತಂದರೆ ನಾವು IVF ಮಾಡಿ ಆ ಭ್ರೂಣದಿಂದ ಕೆಲವು ಸೆಲ್ಸ್ ತೆಗೆದು, ಆ ಥರ ಪ್ರಾಬ್ಲಮ್ಸ್ ಆ ಭ್ರೂಣ ಹಾಕೋ ಮುಂಚೆನೇ, ಒಳಗಡೆ ಹಾಕೋ ಮುಂಚೆನೇ, ಅದು ಹೋಗಿ ಕಚ್ಕೊಳ್ಳೋ ಮುಂಚೆನೇ, ಮಗು ಆಗೋ ಮುಂಚೆನೇ ಆ ಭ್ರೂಣದಲ್ಲಿ ಆ ಥರ ಜೆನೆಟಿಕ್ ಪ್ರಾಬ್ಲಮ್ಸ್ ಇದೆಯಾ ಇಲ್ವಾ ಅಂತ ನಾವು ನೋಡ್ಬೋದು. ಅಥವಾ ಬುದ್ಧಿಮಾಂದ್ಯತೆ ಬರದೇ ಇರೋ ಹಾಗೆ ಯಾವ ಭ್ರೂಣದಲ್ಲಿ ಆ ಥರ ಬುದ್ಧಿಮಾಂದ್ಯತೆದು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ವೋ ಅದನ್ನು ಚೂಸ್ ಮಾಡಿ ನಾವು ಹಾಕ್ಬೋದು. ಸೊ ಆ ಥರ ಟೆಕ್ನಾಲಜಿ ಎಲ್ಲ ಬಂದಿದೆ. ಅದಕ್ಕೆ PGT ಅಂತ ಹೇಳ್ತೀವಿ, ಅಂದರೆ ಪ್ರೀ ಇಂಪ್ಲಾಂಟೇಷನ್ ಜೆನೆಟಿಕ್ ಟೆಸ್ಟಿಂಗ್. ಅಂದರೆ ಭ್ರೂಣ ಒಳಗಡೆ ಗರ್ಭಕೋಶದಲ್ಲಿ ಹಾಕೋ ಮುಂಚೆನೇ ನಾವು ಟೆಸ್ಟ್ ಮಾಡಿ ಜೆನೆಟಿಕಲಿ ನಾರ್ಮಲ್, ಅದ್ರದ್ದು ವಂಶವಾಹಿ ಸರಿಯಾಗಿದೆಯಾ ಇಲ್ವಾ ಅಂತ ನಾವು ನೋಡಿಕೊಂಡು ಅದನ್ನೇ ನಾವು ಹಾಕ್ಬೋದು.
ಈಗ IVF ಅಂದ್ರೆ ತುಂಬಾ ಪೇನ್ಫುಲ್ ಪ್ರೋಸೆಸ್ ಅಂತ ಕೆಲವರು ಹೇಳ್ತಾರೆ. ಅದ್ರ ಬಗ್ಗೆ ಹೇಳೋದಾದ್ರೆ, ತುಂಬಾ ಜನಕ್ಕೆ ಭಯ ಇದೆ ಆಕ್ಚುಲಿ IVF ವಿಚಾರದಲ್ಲಿ, ಅದ್ರ ಬಗ್ಗೆ ಹೇಳೋದಾದ್ರೆ.
ತುಂಬ ಮಿಸ್ಕನ್ಸೆಪ್ಷನ್ಸ್ ಇವೆ IVF ಬಗ್ಗೆ. IVF ಪೇನ್ಫುಲ್ ಅಂತಂದರೆ ಬಂದು ಇಂಜೆಕ್ಷನ್ಸ್ ತೊಗೋಬೇಕು. ಅದು ಚಿಕ್ಕ ಇಂಜೆಕ್ಷನ್ಸ್, ಅದು ಸ್ವಲ್ಪ ಫಿಸಿಕಲ್ ಡಿಸ್ಕಂಫರ್ಟ್ ಅಷ್ಟೇ ಇರೋ ಹೊರತು ಬೇರೆ ಥರ ಪ್ರಾಬ್ಲಮ್ಸ್ ಇಲ್ಲ. ಬಟ್ ಏನಾಗುತ್ತೆ ಅಂತಂದರೆ IVF ಶುರು ಮಾಡಿದಾಗ ತುಂಬಾ ಜನ ನನಗೆ ಮಗು ಆಗಲೇಬೇಕು ಅಂತ ಬರ್ತಾರೆ. ಅದು ಒಳ್ಳೆ ಪಾಸಿಟಿವ್ ಥಿಂಕಿಂಗ್ ಇಟ್ಕೊಂಡು ಬರ್ತಾರೆ, ಬಟ್ ಎಲ್ಲರಿಗೂ ಆಗಲ್ಲ. ಸೊ ಸೈಕಲಾಜಿಕಲ್ ಡಿಸ್ಟ್ರೆಸ್, ಇಮೋಷ್ನಲ್ ಡಿಸ್ಟ್ರೆಸ್ ಅದು ಜಾಸ್ತಿ. ಫಿಸಿಕಲ್ ಪೇನ್ಗಿಂತ ಎಲ್ಲರೂ ಬಂದು ಇಂಜೆಕ್ಷನ್ಸ್ ತೊಗೊಳ್ತಾರೆ, ಇಂಜೆಕ್ಷನ್ಸ್ ಅಷ್ಟೊಂದು ಪೇನ್ಫುಲ್ ಅಲ್ಲ. ಬಟ್ ಆ್ಯಂಡ್ ಆಲ್ಸೋ ನಾವು ಅಂಡಾಣು ತೆಗೆಯುವಾಗ ನಾವು ಅವ್ರಿಗೆ ಅನೆಸ್ಥೀಸಿಯಾ ಕೊಟ್ಟು ಅವ್ರಿಗೇನೂ ಗೊತ್ತಾಗಲ್ಲ. ಬಟ್ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗುತ್ತಾ ಇಲ್ವಾ ಅಂತ ಆ ಆಂಗ್ಸೈಟಿ ತುಂಬ ಜಾಸ್ತಿ. ಬಟ್ ಪೇನ್ಫುಲ್ ಪ್ರೊಸೆಸ್ ಅಲ್ಲ.
ಮಗು ಆಗುತ್ತಾ ಇಲ್ವಾ ಅನ್ನೋ ಭಯ
ಜಾಸ್ತಿ, ಆಂಗ್ಸೈಟಿ, ಅಯ್ಯೋ ಆಗದೇ ಇದ್ರೆ ನಾನು ಏನು ಮಾಡೋದು ಅಂತ. ಬಟ್ ಏನು ಮಾಡೋದು ಅಂತ ಏನು ಇಲ್ವಲ್ಲ. ಅದು ಅವ್ರಿಗೆ ಸಾಕಷ್ಟು ಮೊಟ್ಟೆ ಬಂದರೆ ಅದನ್ನೆಲ್ಲ ನಾವು ಭ್ರೂಣಗಳು ಮಾಡಿ, ಕೆಲವು ನಾವು ಹಾಕ್ತೀವಿ, 1-2 ಹಾಕ್ತೀವಿ, ಇನ್ನು ಮಿಕ್ಕಿದ್ದು 5-6 ನಾವು ಫ್ರೀಸ್ ಮಾಡ್ತೀವಿ. ಸೊ ಅಕಸ್ಮಾತ್ ಒಂದೇ ಸತಿ ನಾವು ಪ್ರೆಗ್ನೆನ್ಸಿ ನಾವು ಯಾರಿಗೂ ಬಂದ್ಬಿಡಿ 100% ಮಗು ಕೊಟ್ಬಿಡ್ತೀವಿ ಅಂತ ಹೇಳೋಕ್ಕಾಗಲ್ಲ. ಅದೆಲ್ಲ ತುಂಬ ತಪ್ಪು ಆ ಥರ ಮಾತಾಡೋದು. ಸೊ ನಮ್ಮ ಹತ್ರ ಬಂದು ನಾವು 60% ಪ್ರೆಗ್ನೆನ್ಸಿ ರೇಟ್ ಇದೆ, 65%. ಬಟ್ 35 ಜನಕ್ಕೆ ಆಗಲ್ವಲ್ಲ, ಆ 100 ಜನಕ್ಕಲ್ಲಿ 35 ಜನಕ್ಕೆ ಆಗಲ್ಲ. ಸೊ ಮತ್ತೆ ಬರ್ಬೋದು. ಫ್ರೋಸನ್ ಎಂಬ್ರಿಯೋಸ್, ಆ ಎಂಬ್ರಿಯೋಸ್ ನಾವು ಐಸ್ನಲ್ಲಿ ಇಟ್ಟಿರ್ತೀವಿ, ಅದನ್ನ ಹಾಕ್ಸೋದಕ್ಕೆ ಮತ್ತೆ ಬರ್ಬೋದು.
ಮೇಡಮ್, ಅಂದರೆ ಆಗದೆ ಇರೋದಕ್ಕೆ ಚಾನ್ಸಸ್ ಯಾವ ಥರ ಇರುತ್ತೆ ಮೇಡಮ್? ಏನು ರೀಸನ್ಸ್ ಇರುತ್ತೆ?
ತುಂಬ ಕಾರಣಗಳು. ಫಸ್ಟ್ ಆಫ್ ಆಲ್ ಭ್ರೂಣ ಹೇಗಿದೆ, ಓಕೆ, ಭ್ರೂಣ ನೋಡೋಕ್ಕೆ ಚೆನ್ನಾಗಿರ್ಬೋದು, ಬಟ್ ಅದ್ರದ್ದು ವಂಶವಾಹಿ ಸರಿಯಾಗಿರದೇ ಇರ್ಬೋದು, ನಂಬರ್ 1. ಆ್ಯಂಡ್ ಮೆಜಾರಿಟಿ IVF ಯಾಕೆ ಫೇಲ್ ಆಗುತ್ತೆ ಅಂತಂದರೆ, ಒಂದು 60 to 65% ಆಫ್ ದ ಟೈಮ್ಸ್ ಯಾಕೆ ಫೇಲ್ ಆಗುತ್ತೆ ಅಂತಂದರೆ, ಆ ಭ್ರೂಣದ್ದು ಜೆನೆಟಿಕ್ ಮೇಕಪ್ ಅಂತಂದರೆ ಅದ್ರದ್ದು ವಂಶವಾಹಿ ಸರಿಯಾಗಿರಲ್ಲ. ಸೊ ಅದು ಒಳಗಡೆ ಹಾಕಿದಾಗ ಗರ್ಭಕೋಶ ಅದನ್ನ ಆಕ್ಸೆಪ್ಟ್ ಮಾಡಲ್ಲ. ಅದು ಆಕ್ಸೆಪ್ಟ್ ಮಾಡಿದ್ರೂ ಅದು ಮಿಸ್ಕ್ಯಾರೇಜ್ ಆಗುತ್ತೆ. ಸೊ ದಟ್ ಈಸ್ ಒನ್ ಆಫ್ ದ ಮೇನ್ ರೀಸನ್ಸ್. ಸೊ ಒಂದು ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗೋದಕ್ಕೆ ಜವಾಬ್ದಾರಿ ಒಂದು 75% ಭ್ರೂಣದ ಮೇಲೆ ಹೋಗುತ್ತೆ, ಇನ್ನು 25% ಗರ್ಭಕೋಶದ ಮೇಲೆ ಬೀಳುತ್ತೆ. ಸೊ ಗರ್ಭಕೋಶದಲ್ಲಿರೋ ಎಲ್ಲ ವಾತಾವರಣ ಚೆನ್ನಾಗಿರಬೇಕು. ಅದು ಹೋಗಿ ಅಲ್ಲಿ ಕೂತ್ಕೊಳ್ಳುವಾಗ ನಾವು ಹಾಕಿದಾಗ ನಾವು ಹೋಗಿ ಗರ್ಭಕೋಶದ್ದು ಒಳಗಡೆ ನಾವು ಹೋಗಿ ಚುಚ್ಚಕ್ಕಾಗಲ್ಲ, ಬ್ಲೀಡಿಂಗ್ ಆಗಿಬಿಡುತ್ತೆ. ಸೊ ನಾವು ಚಿಕ್ಕದಾಗಿ ಜೆಂಟಲಾಗಿ ನಾವು ಹೋಗಿ ಅಲ್ಲಿ ಬಿಡ್ತೀವಿ. ಅದು ಹೋಗಿ ಗರ್ಭಕೋಶದ ಒಳಪದ್ರ ಜೊತೆಗೆ ಮಾತಾಡಬೇಕು, ಕಾನ್ವರ್ಸೇಷನ್ ಇರುತ್ತೆ. ಅದಕ್ಕೆ ಒಂದು ಸ್ಪೆಸಿಫಿಕ್ ಟರ್ಮ್ ಇದೆ, ಎಂಬ್ರಿಯೋ ಎಂಡೋಮೆಟ್ರಿಯಮ್ ಕ್ರಾಸ್ಟಾಕ್ ಅಂತ. ಅದು ಮಾತಾಡಿಕೊಂಡು ಓಕೆ ನೀನು ಬಂದಿದೆಯಾ, ಓಕೆ ನಾನು ಹಿಡ್ಕೊಳ್ತೀನಿ, ಹೌದು ನಾನು ಬಂದಿದ್ದೀನಿ, ನೀನು ಪ್ಲೀಸ್ ಹಿಡ್ಕೋ ಅಂತ ಮೆಸೆಂಜರ್ಸ್ ಕೆಮಿಕಲ್ಸ್ ಎಲ್ಲ ಎಕ್ಸ್ಚೇಂಜ್ ಆಗುತ್ತೆ. ಆಮೇಲೆ ಅದು ಹೋಗಿ ಅದನ್ನು ಹಿಡ್ಕೊಳ್ಳುತ್ತೆ, ಅದನ್ನು ಬೆಳೆಸಬೇಕು. ಸೊ ತುಂಬ ಕಾರಣಗಳಿವೆ ಅದು ಯಾಕೆ ಫೇಲ್ ಆಗುತ್ತೆ.
ಥ್ಯಾಂಕ್ ಯು ಮ್ಯಾಮ್, ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್.
ಥ್ಯಾಂಕ್ ಯು,
ಬ್ಯೂಟಿಫುಲ್ ಆಗಿ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡಿದ್ದಕ್ಕೆ ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್.
ಥ್ಯಾಂಕ್ ಯು.
ಇದಿಷ್ಟು ಡಾಕ್ಟರ್ ಗುರುಶೀಲಾ ಫರ್ಟಿಲಿಟಿ ಎಕ್ಸ್ಪರ್ಟ್ ಆಗಿರೋರು ನಮ್ಮ ಜೊತೆಗೆ ನ್ಯೂಸ್ ಫಸ್ಟ್ ಜೊತೆಗೆ ಕೊಟ್ಟಿರುವಂತಹ ಉಪಯುಕ್ತವಾದ ಮಾಹಿತಿ, ಬಹುಶಃ ಬಹುತೇಕ ಜನರಿಗೆ ಅವಶ್ಯಕತೆ ಇರುವಂತಹ ಅಗತ್ಯವಾದ ಮಾಹಿತಿ ಇದು. ಸೊ ಮೇಡಮ್, ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್ ಫಾರ್ ದ್ಯಾಟ್. ಕ್ಯಾಮರಾಮನ್ ಚಂದ್ರೇಶ್ ಜೊತೆ ಪ್ರಗತಿ ಶೆಟ್ಟಿ, ನ್ಯೂಸ್ ಫಸ್ಟ್, ಬೆಂಗಳೂರು. ಪೋಷಕರಾಗೋಲಕ್ಕೆ ಇರುವಂತಹ ಹಾದಿಯಲ್ಲಿ ಸವಾಲುಗಳು ಸಾಕಷ್ಟಿರುತ್ತೆ. ಆ ಸವಾಲುಗಳನ್ನ ಎದುರಿಸೋದು ಹೇಗೆ, ಎಮೋಷನಲಿ ಅವುಗಳನ್ನ ಆ ಎಮೋಷನ್ಸ್ ಗಳನ್ನ ಯಾವ ರೀತಿಯಾಗಿ ಬ್ಯಾಲೆನ್ಸ್ ಮಾಡಬೇಕು, ಈ ಎಲ್ಲ ವಿಚಾರಗಳ ಬಗ್ಗೆ ತಿಳಿಸ್ಕೊಡೋದಕ್ಕೆ ನಮ್ಮ ಜೊತೆಗೆ ಪಾತ್ ಟು ಪೇರೆಂಟ್ಹುಡ್ ನ ಕಾರ್ಯಕ್ರಮದ ಮುಖ್ಯ ಅತಿಥಿಯಾಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಯೋಗೀಶ್ ಅವರಿದ್ದಾರೆ. ಅವ್ರನ್ನ ಮಾತನಾಡಿಸ್ತಾ ಹೋಗ್ತೀನಿ. ಖುಷಿ ಫರ್ಟಿಲಿಟಿ MD ಕೂಡ ಹೌದು ಅವರು. ಅವ್ರನ್ನ ಮಾತನಾಡಿಸ್ತಾ ಹೋಗ್ತೀನಿ. ಮೇಡಮ್ ಹಾಯ್. ಮೊದಲನೇದಾಗಿ ತುಂಬಾ ಚೆನ್ನಾಗಿ ಬ್ಯೂಟಿಫುಲ್ ಆಗಿ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡಿದ್ರಿ. ಸೊ ಈ ಬಂಜೆತನಕ್ಕೆ ಆಗುವಂತಹ ಸಮಸ್ಯೆಗಳೇನು?
ಮೊದಲನೇದಾಗಿ ಬಂಜೆತನ ಅಂತ ವರ್ಡೇ ನನಗೆ ಇಷ್ಟ ಆಗೋದಿಲ್ಲ. ಹೆಣ್ಮಕ್ಳಿಗೆ ಮಗು ಆಗೋದಕ್ಕೆ ತೊಂದರೆ ಆದ್ರೆ ಅಥವಾ ಒಂದ್ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಸಮಯ ತಗೊಂಡ್ರೆ ಅದಕ್ಕೆ ಅವಳಿಗೆ ನಿನ್ಗೆ ಮಗು ಆಗ್ತಾ ಇಲ್ಲ ಅಂತ ಯಾರಾದ್ರೂ ಹೇಳಿದ್ರೆ ಅದೇ ಒಂದು ದೊಡ್ಡ ಅಪರಾಧ ಅನ್ಸುತ್ತೆ. ಎಷ್ಟು ಒಂದು ಹೆಣ್ಣಿನ ಮನಸ್ಸಿಗೆ ಇದರಿಂದ ನೋವಾಗುತ್ತೆ ಅನ್ನೋದು ನಾವು ಶಬ್ದಗಳಲ್ಲಿ ಹೇಳಕ್ ಆಗೋದಿಲ್ಲ. ಯಾವುದೇ ಒಂದು ಜನ್ಮ ಅಂತ ತಾಳ್ಕೊಂಡಾಗ ನಮ್ಮ ದೇಹಕ್ಕೆ ಯಾವುದಾದ್ರೂ ಒಂದು ತೊಂದರೆ ಬಂದೇ ಬರುತ್ತೆ, ಇವತ್ತಿಲ್ಲೋ ನಾಳೆ ಬರುತ್ತೆ ನಮ್ ಲೈಫ್ ಸ್ಪ್ಯಾನ್ ಅಲ್ಲಿ. ಅದೇ ತರಹ ಎಲ್ಲಾ ಈ ತೊಂದರೆಗಳಿರ್ತವೆ, ಮಧುಮೇಹ, ಡಯಾಬಿಟೀಸು, ಮತ್ತೆ ಬ್ಲಡ್ ಪ್ರೆಷರ್ ಜಾಸ್ತಿ ಇರೋದು, ಹೈಪರ್ ಟೆನ್ಷನ್, ಇವೆಲ್ಲಾ ಪ್ರಾಬ್ಲಮ್ ತರ ಹೆಣ್ಮಕ್ಳಿಗೆ ಮಗು ಆಗೋದಕ್ಕೆ ಕಷ್ಟ ಆಗೋದು ಒಂದು ಸಹಜ. ಇವಾಗ ಇರೋ ಲೈಫ್ ಸ್ಟೈಲ್ ಇಶ್ಯೂಸ್ ಗಳಿಂದ ಹೆಣ್ಮಕ್ಳಿಗೆ ಅಂಡಾಣುಗಳ ಸಂಖ್ಯೆ ತುಂಬಾ ಬೇಗ ಕಡಿಮೆ ಆಗ್ತಾ ಇದೆ. ಅದರಿಂದ ಅವ್ರಿಗೆ ತುಂಬಾ ಕಷ್ಟ ಆಗ್ತಾ ಇದೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗೋದಕ್ಕೆ, ಎಸ್ಪೆಷಲಿ ವೆನ್ ದೇ ಆರ್ ಪೋಸ್ಟ್ಪೋನಿಂಗ್ ದಿಯರ್ ಪ್ರೆಗ್ನೆನ್ಸಿ. ಹೆಣ್ಮಕ್ಳಿಗೆ ಮೊದಲು 15-16 ವರ್ಷದಲ್ಲಿ ಆ ಟೈಮಲ್ಲಿ ಅವ್ರಿಗೆ ಹೆಣ್ಮಕ್ಳು ವಯಸ್ಸಿಗೆ ಬರ್ತಾ ಇದ್ರು. ಇವಾಗ 10 ವರ್ಷದ ವಯಸ್ಸಲ್ಲಿ, 9 ವರ್ಷದ ವಯಸ್ಸಲ್ಲಿ ವಯಸ್ಸಿಗೆ ಬರ್ತಾ ಇದ್ದಾರೆ. ಕೆಲವೊಂದ್ಸತಿ ನಾವು ಕೆಲವೊಂದು ಇಂಜೆಕ್ಷನ್ಸ್ ನ ಕೊಟ್ಟು ಈ ವಯಸ್ಸಿಗೆ ಬಂದಿರೋ ಹುಡುಗಿಯರಿಗೆ ಅವರ ಎಗ್ ರಿಸರ್ವ್ ಇನ್ನೂ ಸ್ವಲ್ಪ ಚೆನ್ನಾಗಿರ್ಬೇಕು ಅಂತ ಕೆಲವೊಂದು GnRH ಅಗಾನಿಸ್ಟ್ ಇಂಜೆಕ್ಷನ್ ನ ಮಂತ್ಲಿ ಒನ್ಸ್ ಕೊಟ್ಟು ಅವರ ಪೀರಿಯಡ್ಸ್ ಸ್ಟಾರ್ಟ್ ಆಗೋದನ್ನ ಡಿಲೇ ಕೂಡ ಮಾಡ್ತಾ ಇದೀವಿ. ಇಂಥ ಪರಿಸ್ಥಿತಿಗೆ ನಾವು ಯಾಕೆ ಬಂದಿದೀವಿ ಅಂತ ಹೇಳ್ಬೇಕಾದ್ರೆ ಇಟ್ ಇಸ್ ಬಿಕಾಸ್ ಆಫ್ ಅವರ್ ಲೈಫ್ ಸ್ಟೈಲ್. ಅವರ್ ಲೈಫ್ ಸ್ಟೈಲ್ ಅನ್ನೋದಕ್ಕೆ ವೆಸ್ಟರ್ನೈಸೇಷನ್ ಆಫ್ ಅನ್ ಇಂಡಿಯನ್ ಲೈಫ್ ಸ್ಟೈಲ್. ನಮ್ಮ ಇಂಡಿಯನ್ ಹೆಣ್ಮಕ್ಳು ಯಾವ ಊಟ ತಿನ್ಬೇಕು, ಯಾವ ತರ ಇರಬೇಕು, ಅದೇ ತರ ಇದ್ರೆ ಅದು ನಮ್ ಜೀನ್ಸ್ಗೆ ಸೂಟ್ ಆಗುತ್ತೆ. ವೆಸ್ಟರ್ನ್ ಹೆಣ್ಮಕ್ಳು ಆಲ್ಕೋಹಾಲ್ ತಗೋಬಹುದು, ಸಿಗರೆಟ್ ಸ್ಮೋಕ್ ಮಾಡಬಹುದು, ಆದ್ರೆ ಅದರಿಂದ ಅವ್ರಿಗೆ ಅಷ್ಟು ಬೇಗ ಎಗ್ ರಿಸರ್ವ್ ಕಡಿಮೆ ಆಗೋದಿಲ್ಲ. ಅವ್ರ ಜೀನ್ಸ್ಗೆ ಅದು ಸೂಟ್ ಆಗುತ್ತೆ. ನಮ್ಮ ಇಂಡಿಯನ್ ಹೆಣ್ಮಕ್ಳಿಗೆ ಆಲ್ಕೋಹಾಲ್ ತಗೊಳ್ಳೋದಾಗ್ಲಿ, ಸಿಗರೆಟ್ ಸೇದೋದಾಗ್ಲಿ ಅದು ನಮ್ ಜೀನ್ಸ್ಗೆ ಸೂಟ್ ಆಗೋದಿಲ್ಲ. ಇದರಿಂದ ಸಿಗರೆಟ್ ಸ್ಮೋಕಿಂಗ್ ಇಸ್ ಒನ್ ಆಫ್ ದ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಕಾಸ್ ಫಾರ್ ರಿಡ್ಯೂಸ್ಡ್ ಓವೇರಿಯನ್ ರಿಸರ್ವ್. ಎವ್ರಿ ಗರ್ಲ್ ಶುಡ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ದಿಸ್. ಒಂದ್ ಪಬ್ಗೆ ಹೋಗ್ಬಿಟ್ಟು ಆಲ್ಕೋಹಾಲ್ ತಗೊಂಡು ಸಿಗರೆಟ್ ನ ಸ್ಮೋಕ್ ಮಾಡ್ಬಿಟ್ರೆ ಅವರು ಮಾಡರ್ನ್ ಆಗೋದಿಲ್ಲ. Modern in their way of thinking is required, but not showing this as modern, because it is not suiting us and it is not doing any help to us. You will not believe cosmetics, nail polish, hair color, all of these are doing harm, because of which their ovarian reserve or egg reserve is coming down. ಇದನ್ನ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳೋದು ಅತಿ ಮುಖ್ಯ. ಹೆಣ್ಣು ಮಕ್ಕಳು ಚಿಕ್ಕ ವಯಸ್ಸಿನಿಂದನೇ ಇದನ್ನೆಲ್ಲ ಅರ್ಥ ಮಾಡ್ಕೊಂಡ್ರೇನೆ ನಮ್ಗೆ ಈ ಹೆಣ್ಮಕ್ಳು ಬೇಗ ವಯಸ್ಸಿಗೆ ಬರೋದನ್ನ ನಾವು ತಡಿ ಹಿಡಿಬಹುದು. ಏನಕ್ಕಂದ್ರೆ ಹೆಣ್ಮಕ್ಳು ದೇ ಆರ್ ಬಾರ್ನ್ ವಿತ್ ಅ ಫಿಕ್ಸ್ ನಂಬರ್ ಆಫ್ ಓಸೈಟ್ಸ್. ಇವತ್ತು ನಮ್ಗೆ ಇಷ್ಟು ಎಕ್ಸ್ ಇದೆ ಅಂತಂದ್ರೆ ನಮ್ಮ ಇಡೀ ಜೀವಮಾನಕ್ಕೆ ಅಷ್ಟೇ ಎಕ್ಸು. ಬೇಗ ಮುಟ್ಟು ಸ್ಟಾರ್ಟ್ ಆಗ್ಬಿಟ್ರೆ ಬೇಗ ಮುಟ್ಟು ನಿಂತು ಹೋಗುತ್ತೆ. ಬೇಗ ಮುಟ್ಟು ಸ್ಟಾರ್ಟ್ ಆದ್ರೆ ಮಗು ಬೇಕು ಅಂತ ಆಸೆ ಇರೋರು ಬೇಗ ಮಗು ಮಾಡ್ಕೊಳ್ಬೇಕು ಅಂತ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳೋ ಸಮಯ ಇದು. ಹೆಣ್ಣು ಮಕ್ಕಳಿಗೆ ಈ ನಾಲೆಜ್ ಕೊಡೋದೇ ನಮ್ಮ ಕರ್ತವ್ಯ. Path to Parenthood. This is a very, very good initiative with which we are trying to tell the world that taking treatment for infertility or subfertility is nothing but path to parenthood. You are actually walking towards a good cause. You are trying to have a child. There is nothing to hide. There is nothing to feel bad that you are entering into a fertility center. You are doing something good. You're trying to create a family. And what is wrong in trying to create a family? You can create a family with your own eggs and sperms. So why not go ahead? And we have so many advancements nowadays. Regenerative medicine in the intra-ovarian PRP, intra-ovarian stem cell therapy, idella madbittu reduced ovarian reserve gu ನಾವು ಮತ್ತೆ egg reserve ಹೆಚ್ಚಿಗೆ ಮಾಡೋ ತರ ಮಾಡ್ಬಿಟ್ಟು ಅವರು ಸ್ವತಃ eggs and sperms ಅಲ್ಲಿ ಮಗು ಮಾಡಕ್ಕೆ ಎಷ್ಟೆಲ್ಲ ಸೌಲಭ್ಯಗಳು ಇರುವಾಗ I don't think somebody should get scared or feel ashamed to enter into a fertility center. It's my right to have a child, and if I want to do something for myself, why should I hesitate? ಈ ಮಾಡರ್ನ್ ಥಿಂಕಿಂಗ್ ಬರಬೇಕೇ ಹೊರತು ಬೇರೆ ಮಾಡರ್ನ್ ಮೆಥಡ್ಸ್ ಶುಡ್ ನಾಟ್ ಕಮ್ ಇನ್ ಟು ದಿಯರ್ ಮೈಂಡ್ಸ್.
ನಾನು ನಿಮ್ಮ ಮಾತನ್ನ ಕೇಳ್ತಾ ಇದ್ರೆ ಕೇಳ್ತಾನೆ ಇರೋಣ ಅನ್ಸುತ್ತೆ. ಬಟ್ ನಂದು ಇನ್ನೊಂದು ಕ್ವಶನ್ ಇದೆ. ನೀವು ಮಾತಾಡ್ಬೇಕಾದ್ರೆ ಮೆನ್ಷನ್ ಮಾಡಿದ್ರಿ ಕುಡಿಯೋದ್ರಿಂದಾಗ್ಲಿ, ಸಿಗರೇಟ್ ಸೇದೋದ್ರಿಂದಾಗ್ಲಿ ಅಥವಾ ಕಾಸ್ಮೆಟಿಕ್ಸ್ ಇಂದಾಗ್ಲಿ ಇವೆಲ್ಲವೂ ಕೂಡ ಇನ್ಫರ್ಟಿಲಿಟಿಗೆ ಲೀಡ್ ಮಾಡುತ್ತೆ ಅಂತ. ಸೊ ಅದನ್ನ ಒಂದ್ ಸ್ವಲ್ಪ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡ್ಬೋದಾ? ಕುಡಿಯೋದು ಮತ್ತೆ ಕಾಸ್ಮೆಟಿಕ್ಸ್ ಯಾವ ತರ ಸಮಸ್ಯೆ ಆಗುತ್ತೆ ಅಂತ.
ಆಕ್ಚುಲಿ ನಾನು ಹೇಳ್ದಂಗೆ ಸಿಗರೇಟ್ ಸ್ಮೋಕಿಂಗ್ ಇಂದ, ಈ ಟೊಬ್ಯಾಕೋ ಇಂದ AMH ಕಡಿಮೆ ಆಗುತ್ತೆ. AMH ಅಂದ್ರೆ ಇಟ್ ಈಸ್ ಲೈಕ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡಿಂಗ್ ವಾಟ್ ಈಸ್ ಯೋರ್ ಬ್ಯಾಲೆನ್ಸ್ ಆಫ್ ಎಗ್ಸ್ ಇನ್ ಯೋರ್ ಬಾಡಿ. ಎಗ್ ಬ್ಯಾಲೆನ್ಸ್ ಕಡಿಮೆ ಆಗ್ಬಿಟ್ರೆ ಬೇಗ ಮುಟ್ಟು ನಿಂತು ಹೋಗುತ್ತೆ ಹೆಣ್ಮಕ್ಳಿಗೆ. ಈ ಎಗ್ ಡಿಸ್ಟ್ರಕ್ಷನ್ ಆಗೋದೇ ಸಿಗರೇಟ್ ಸ್ಮೋಕ್ ಇಂದ. ದಟ್ ಈಸ್ ವೈ ದ ಫಸ್ಟ್ ಥಿಂಗ್ ಅಂಡ್ ದ ಫಸ್ಟ್ ರಿಕ್ವೆಸ್ಟ್ ಟು ಆಲ್ ದ ಲೇಡೀಸ್ ಔಟ್ ಹಿಯರ್ ಇಸ್ ಪ್ಲೀಸ್ ಡೋಂಟ್ ಸ್ಮೋಕ್. ಇಫ್ ಯು ಆರ್ ಎನ್ ಇಂಡಿಯನ್, ಪ್ಲೀಸ್ ಡೋಂಟ್ ಸ್ಮೋಕ್ ಬಿಕಾಸ್ ಇಟ್ಸ್ ನಾಟ್ ಗೋಯಿಂಗ್ ವೆಲ್ ವಿತ್ ಯೋರ್ ಜೀನ್ಸ್. ಎಗ್ ರಿಸರ್ವ್ ನ ಕಾಪಾಡ್ಕೊಳ್ಳೋದು ಬಹಳ ಮುಖ್ಯ. ಅದು ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಥಿಂಗ್. ಎರಡನೇದಾಗಿ ಕೆಲವೊಂದ್ಸತಿ ಕೆಲವೊಬ್ರು ಹೆಣ್ಮಕ್ಳು ಆಲ್ಕೋಹಾಲ್ನ ಒಂದು ಸ್ಟ್ರೆಸ್ ಬಸ್ಟರ್ ತರ ಟ್ರೀಟ್ ಮಾಡ್ತಾರೆ. ಬಟ್ ಇಟ್ ಇಸ್ ನಾಟ್ ದ ಥಿಂಗ್. ಮೊದ್ಲಿನ ಕಾಲದಿಂದ ನಮ್ಮ ಹೆಣ್ಮಕ್ಳು ವೆನ್ ಎವರ್ ದೇ ಹ್ಯಾವ್ ಬೀನ್ ಸ್ಟ್ರೆಸ್ಡ್, ಅವ್ರು ಮಾಡಿರೋದೇನು ದೇವಸ್ಥಾನಕ್ಕೆ ಹೋಗಿ ಪೂಜೆ ಮಾಡೋದು ಅಂಡ್ ಟಾಕಿಂಗ್ ಟು ಪೀಪಲ್. ಇವೆರಡೂ ಇಸ್ ದೇರ್ ಇಂಬೈಬ್ಡ್ ಇನ್ ಅಸ್. ದಟ್ ಇಸ್ ವೈ ವಿ ಆರ್ ನೌ ಟೆಲಿಂಗ್ ಪೀಪಲ್, ಮೊದ್ಲಿನ ತರ ನಾವು ದೇವಸ್ಥಾನದಲ್ಲಿ ಹೋಗಿ ಕೂತು ಪೂಜಾರಿಗಳ ಜೊತೆಗೆ ಮಾತಾಡಕ್ ಆಗದೆ ಇದ್ರೆ ಇವಾಗಿನ ಜನರೇಷನ್ ಅಲ್ಲಿ ಯು ಶುಡ್ ಸ್ಟಾರ್ಟ್ ಮೆಡಿಟೇಟಿಂಗ್ and you should start connecting yourself with God, and you should try and talk to counselors. There is nothing wrong in going and approaching a counselor. ತುಂಬಾ ಜನ ಹೆಣ್ಮಕ್ಳು ಇವಾಗ ಏನ್ ಮಾಡ್ತಾರೆ, they don't want to share their problems with anybody because they are all independent, they are working, they are financially independent. ಅವರಲ್ಲಿರೋ negative points na athwa what they are going through, they don't want to expose and tell others. At the same time, they should also realize that there is nothing wrong in going and talking to a counselor, telling what they feel to a counselor who can give them the confidence. And I'm sure every counselor, every psychological counselor has it in them to keep it very confidential. ಅವ್ರಿಗೆ ಹೇಳಿರೋದನ್ನ ಇನ್ನೊಬ್ಬರ ಮುಂದೆ ಅವರು ಖಂಡಿತವಾಗೂ ಶೇರ್ ಮಾಡೋದಿಲ್ಲ. ಇದನ್ನ ಅರ್ಥ ಮಾಡ್ಕೊಂಡು ಕೌನ್ಸಿಲಿಂಗ್ ಅನ್ನೋದನ್ನ ಎಕ್ಸೆಪ್ಟ್ ಮಾಡ್ಕೊಳ್ಳೋದು ಬಹಳ ಮುಖ್ಯ. ಇದರಿಂದ ಸ್ಟ್ರೆಸ್ ಲೆವೆಲ್ಸ್ ಕಮ್ಮಿ ಆಗುತ್ತೆ. ಇವತ್ತಿನ ಜನರೇಷನ್ ಅಲ್ಲಿ ಡಿಪ್ರೆಷನ್ ರೇಟ್ಸ್ ಆರ್ ವೆರಿ ಹೈ. The incidence of suicides have increased so much. ಇದನ್ನೆಲ್ಲ ತಡೆ ಹಿಡಿಬೇಕು ಅಂತಂದ್ರೆ psychological counseling should be given the utmost importance, and I think programs like Path to Parenthood will make every couple realize that going to a fertility center, taking help from psychologists and counselors is something which is very natural and there is nothing wrong in doing it. I feel these are the most important things that have to be focused on in today's date.
Thank you so much. Tumba ಚೆನ್ನಾಗಿ ಮಾತಾಡಿದ್ರಿ. Thank you so much.
Thanks for the opportunity. And yes, people, check your fertility score. Try and understand where you stand in this, whether your ovarian reserve is good and your sperm counts are good, and then only postpone the pregnancy. Think about conception before contraception. This is one message to everybody. And my talk will not be complete if I have not addressed on a very, very important topic. The important topic is erectile dysfunction. ಇವತ್ತಿನ ಜನರೇಷನ್ ಅಲ್ಲಿ because of the stress men go through for the kind of work they do, and because of the targets they have in their professional life, and because of inability to face multifaceted challenges in their life, they have problems with erection, and this is something which is not talked about. Erectile dysfunction is common, but people don't know that it is common because it cannot be openly spoken. That is why men should not hesitate when they have erectile dysfunction, and they should not feel that they are losing their self-esteem in front of their wife and try to avoid having sex at all. That is something which has to be taken as a natural phenomenon. Try to work towards it by doing things like regular exercises. You can take medical help. Try and understand. Sometimes diabetes is a very important cause for erectile dysfunction. People are not aware of this. Erectile dysfunction iddaga checking your blood sugar levels is the most important aspect that has to be given importance to. That is why seeing a doctor in such situations will make things easier. ಇದು ಒಂದೇ ಒಂದು ಫ್ಯಾಕ್ಟರ್ ಇರೋದಕ್ಕೆ ಹೆಣ್ಮಕ್ಳನ್ನ ಹಾಸ್ಪಿಟಲ್ಗೆ ಕರ್ಕೊಂಡು ಹೋಗ್ಲಾರ್ದೇ ಇದ್ದು ತುಂಬಾ ಸಮಯ ಆದ್ಮೇಲೆ ಹೆಣ್ಮಕ್ಳನ್ನ ಹಾಸ್ಪಿಟಲ್ ಕರ್ಕೊಂಡು ಹೋಗಿ ನಮ್ಗೆ ಮಗು ಬೇಕು ಅಂತ ಕೇಳಿದಾಗ ಹೆಣ್ಮಕ್ಳ ವಯಸ್ಸು ಮೀರಿ ಹೋಗ್ಬಿಡುತ್ತೆ. ಆದ್ರಿಂದ ಇದೆಲ್ಲ ಪ್ರಾಬ್ಲಮ್ಸ್ ನ ಒಂದು ಕಾಮನ್ ಸಿಚುವೇಶನ್ ಅಂತ ಅನ್ಕೊಂಡು trying to shun the ego and going ahead for treatments is something very, very important. And I thought if I don't talk about this, it will not be complete. Thank you.
ಸೊ ಇದಿಷ್ಟು ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಅವರು ನ್ಯೂಸ್ ಫಸ್ಟ್ ಗೆ ಹೇಳ್ತಾ ಇರುವಂತಹ ಮಾಹಿತಿ. ಅಂದ್ರೆ ಕೇಳಿದ್ರಲ್ಲ, ಸ್ಟ್ರೆಸ್ ಅಂತ ಸಿಗರೇಟ್ ಸೇದಬಾರ್ದು, ಫ್ಯಾಷನ್ ಅಂತ ಕುಡಿಯೋಕ್ ಹೋಗ್ಬಾರ್ದು, ಇವೆಲ್ಲವನ್ನ ಮಾಡ್ಕೊಂಡ್ರೆ ಅಂದ್ರೆ ನಮ್ಮ ಲೈಫ್ ಸ್ಟೈಲ್ ನ ಬೇರೆಯವ್ರಿಗೋಸ್ಕರ ಅಥವಾ ಯಾರು ನೋಡ್ತಾರೆ ಅಂತ ಚೇಂಜ್ ಮಾಡ್ಕೊಳಕ್ ಹೋದ್ರೆ ಅದು ಕೂಡ ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ಸಮಸ್ಯೆ ಆಗುವಂತಹ ಸಾಧ್ಯತೆ ಇದೆ ಅನ್ನುವಂತಹ ಮಾಹಿತಿಯನ್ನ ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಅವರು ನ್ಯೂಸ್ ಫಸ್ಟ್ ಜೊತೆಗೆ ಹಂಚ್ಕೊಳ್ತಾ ಇದ್ರು. ಕ್ಯಾಮರಾಮನ್ ಚಂದ್ರೇಶ್ ಜೊತೆ ಪ್ರಗತಿ ಶೆಟ್ಟಿ, ನ್ಯೂಸ್ ಫಸ್ಟ್, ಬೆಂಗಳೂರು. ಲೈಫ್ ಸ್ಟೈಲ್ ಬದಲಾಗ್ತಾ ಇರೋ ಈ ಕಾಲದಲ್ಲಿ ಪೋಷಕರಾಗೋದೇ ಒಂದು ದೊಡ್ಡ ಸವಾಲಿನ ಕೆಲಸ ಅಂತ ಹೇಳ್ತಾರೆ. ಆದ್ರೆ ಈ ಹಾದಿಯಲ್ಲಿ ನಮಗೆ ಸಾಕಷ್ಟು ಸೈನ್ಸ್ ಆಗ್ಲಿ, ಟೆಕ್ನಾಲಜೀಸ್ ಆಗ್ಲಿ, ಇವೆಲ್ಲವೂ ಕೂಡ ಸಪೋರ್ಟ್ ಮಾಡ್ತಾ ಹೋಗುತ್ತೆ. ಇದ್ರ ಬಗ್ಗೆ ಮಾತನಾಡೋದಕ್ಕೆ ನನ್ನ ಜೊತೆಗೆ ಫರ್ಟಿಲಿಟಿ ಎಕ್ಸ್ಪರ್ಟ್ ಆಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ಗುಣಶೀಲ ಅವರಿದ್ದಾರೆ. ಅವ್ರನ್ನ ಮಾತನಾಡಿಸ್ತಾ ಹೋಗ್ತೇನೆ. ಮೇಡಮ್, ಮೊದಲನೇದಾಗಿ ಯಾವ್ಯಾವ ರೀತಿಯಾದಂತಹ ಅಡ್ವಾನ್ಸ್ ಟೆಕ್ನಾಲಜಿ ಅಥವಾ ಸೈನ್ಸ್ ಇವಾಗ ಸದ್ಯ ಇರುವಂತದ್ದು?
ಸದ್ಯಕ್ಕೆ ಇರೋದು ತುಂಬ ಟೆಕ್ನಾಲಜೀಸ್ ಇವೆ. 1990ಸ್ನಲ್ಲಿ 1978ನಲ್ಲಿ ಈ ಪ್ರಪಂಚದಲ್ಲಿ ಫಸ್ಟ್ IVF ಬೇಬಿ ಹುಟ್ಟಿದ್ದು ಲೂಯಿಸ್ ಬ್ರೌನ್ ಅಂತ. ಅದಾದಮೇಲೆ ಸೈನ್ಸ್ ಎಷ್ಟು ಡೆವಲಪ್ ಆಗಿದೆ ಅಂತಂದರೆ ಅದು ಹೇಳೋಕ್ಕೆ ಆಗಲ್ಲ. ಆ್ಯಂಡ್ ಇನ್ನೂ ಮುಂದೆ ಎಷ್ಟು ಡೆವಲಪ್ ಆಗುತ್ತೆ ಅಂತ ಅದನ್ನ ಸುಮ್ಮನೆ ನಾವು ನೋಡಬೇಕು. ಒಂದು ಪಿಕ್ಚರ್ ನೋಡೋ ಹಾಗೆ ಆಗುತ್ತೆ, ಫಿಲ್ಮ್ ನೋಡೋ ಹಾಗೆ, ಸೈನ್ಸ್ ಫಿಕ್ಷನ್ ಫಿಲ್ಮ್ ನೋಡೋ ಹಂಗೆ ಆಗುತ್ತೆ. ಬಟ್ ಅದೇನಂತಂದರೆ ಇವಾಗ ಐ ವಿ ಎಫ್ನಲ್ಲಿ ನಾವು ಒಂದು ಅಂಡಾಣು ತೊಗೊಂಡು ಅದ್ರ ಮೇಲೆ ಒಂದು ಮೈಕ್ರೋ ಡ್ರಾಪ್ಲೆಟ್ ಅಂದರೆ 50,000 ಅಷ್ಟು ಸ್ಪರ್ಮ್ ನಾವು ಹಾಕ್ತೀವಿ. ಒಂದು ಸ್ಪರ್ಮ್ ಒಳಗಡೆ ಹೋಗಿ ಕೂತ್ಕೋಬೇಕು. ಎಷ್ಟೊಂದು ಸತಿ ಹಂಗೆ ಆಗಲ್ಲ, ಸ್ಪರ್ಮ್ ಹೋಗಿ ಒಳಗಡೆ ಕೂತ್ಕೊಳ್ಳೋದೇ ಇಲ್ಲ. ಸೊ ಅದನ್ನು ಓವರ್ಕಮ್ ಮಾಡೋದಕ್ಕೆ ನಾವು ಇಕ್ಸಿ ಅಂತ ಬಂದಿದೆ. ಇಕ್ಸಿ 1990ನಲ್ಲಿ ಬಂತು, ಸರಿನಾ? ಅದು ಬೆಲ್ಜಿಯಂನಲ್ಲಿ ಅದು ಶುರುವಾಯಿತು. ಆ್ಯಂಡ್ ಅದರಲ್ಲಿ ಅಂಡಾಣು ಒಳಗಡೆ ಆ ವೀರ್ಯನ ನಾವು ಹೋಗಿ ಚುಚ್ತೀವಿ. ಸೊ ಚಾನ್ಸ್ಗೆ ನಾವು ಯಾವುದು ಬಿಡೋಲ್ಲ. ಸೊ ಅದು ಹೋಗಿ ಅಲ್ಲಿ ಕೂತ್ಕೊಂಡು ಅಂಡಾಣು ಜೊತೆಗೆ ಸೇರಬೇಕು. ಸೊ ಅಲ್ಲಿಂದ ಶುರು ಆಗಿ ಇವಾಗ ಎಲ್ಲ ಲ್ಯಾಬ್ಸ್ನಲ್ಲಿ ಇಕ್ಸಿ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಅದ್ರ ಜೊತೆಗೆ ಕೆಲವರಿಗೆ ತುಂಬಾ ಅಂಡಾಣು ಸಿಗುತ್ತೆ. PCO ಪೇಷಂಟ್ಸ್ನಲ್ಲಿ, ಪಾಲಿಸಿಸ್ಟಿಕ್ ಓವರಿ ಪೇಷಂಟ್ಸ್ನಲ್ಲಿ ನಾವು IVF ಮಾಡಬೇಕು ಅಂತಂದರೆ ತುಂಬಾ ಸತಿ ನಾವು ಔಷಧಿ ಹಾಕ್ತೀವಿ. ಔಷಧಿ ಹಾಕಿದಾಗ ಸಿಕ್ಕಾಪಟ್ಟೆ ಜಾಸ್ತಿ ಅಂಡಾಣು ಬರ್ತವೆ. ತುಂಬ ಅಂಡಾಣು ಬರೋದೂ ತಪ್ಪು, ಏನು ಬರದೇ ಇದ್ರೂ ತಪ್ಪು, ಸರಿನಾ? ಸೊ ಹಾಗಾಗಿ ಆ ಥರ ಪೇಷಂಟ್ಸ್ಗೆ ನಾವು ಇಮ್ಮೆಚ್ಯೂರ್ ಎಗ್ಸ್ ಅಂದರೆ ಪೀಚ್ಕಾಯಿ ಥರ ಚಿಕ್ಕ ಇಮ್ಮೆಚ್ಯೂರ್ ಎಗ್ಸ್ ನಾವು ಅಂಡಾಶಯದಿಂದ ತೆಗೆದು ಅದನ್ನು ಲ್ಯಾಬ್ನಲ್ಲಿ ಇನ್ನೂ ಒಂದು ದಿನ ಬೆಳೆಸಿ ಆಮೇಲೆ ಅದಕ್ಕೆ ನಾವು ಸ್ಪರ್ಮ್ ಇಂಜೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ಕ್ಯಾನ್ಸರ್ ಬಂದಿರೋ ಪೇಷಂಟ್ಸ್ಗೆ ಕ್ಯಾನ್ಸರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡೋ ಮುಂಚೆ, ಯಾಕೆಂತಂದರೆ ಕ್ಯಾನ್ಸರ್ ಟ್ರೀಟ್ಮೆಂಟ್ನಲ್ಲಿ ಕೀಮೊಥೆರಪಿ, ರೇಡಿಯೋಥೆರಪಿ ಎಲ್ಲ ಇರುತ್ತೆ. ಅದರಿಂದ ಅವ್ರದ್ದು ಅಂಡಾಶಯದ್ದು ಸ್ಟಾಕ್ ಆಫ್ ಎಗ್ಸ್ ಕಮ್ಮಿ ಆಗುತ್ತೆ, ಅಂಡಾಣುಗಳು ಹಾಳಾಗೋಗ್ತವೆ. ಸೊ ಹಾಗಾಗಿ ಅವ್ರಿಗೆ ನಾವು ಅಂಡಾಣು ಫ್ರೀಸ್ ಮಾಡ್ತೀವಿ ಕ್ಯಾನ್ಸರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡೋ ಮುಂಚೆ. ಫರ್ಟಿಲಿಟಿ ಪ್ರಿಸರ್ವೇಷನ್ ಅಂತ. ಸೊ ಕೀಮೊಥೆರಪಿ ಮಾಡೋ ಮುಂಚೆ ಅಂಡಾಣು ತೆಗೆದು ಫ್ರೀಸ್ ಮಾಡ್ತೀವಿ. ಅಂಡಾಣು ಅಂತಂದರೆ ಮೊಟ್ಟೆ, ವೀರ್ಯಾಣು ತೆಗೆದು ಫ್ರೀಸ್ ಮಾಡ್ತೀವಿ. ಅಥವಾ ಅಂಡಾಶಯ ಮೇಲೆ ಇರೋ ಕಾರ್ಟಿಕಲ್ ಟಿಶ್ಯೂ ಅಂತ, ಆ ಕಾರ್ಟಿಕಲ್ ಟಿಶ್ಯೂನಲ್ಲಿನೇ ಅಂಡಾಣು ಬೆಳೀತಾ ಇರುತ್ತೆ, ಅದನ್ನ ತೆಗೆದು ನಾವು ಫ್ರೀಸ್ ಮಾಡ್ತೀವಿ. ಸೊ ಎಷ್ಟೊಂದು ಇನ್ವೆಷನ್ಸು, ಎಷ್ಟೊಂದು ಪ್ರೋಗ್ರೆಸ್ ಆಗಿದೆ. ಇನ್ನೊಂದೇನಂತಂದರೆ ಕೆಲವು ಫ್ಯಾಮಿಲೀಸ್ನಲ್ಲಿ ಸಿಕ್ಕಲ್ ಸೆಲ್ ಡಿಸೀಸು, ಬ್ಲಡ್ ಪ್ರಾಬ್ಲಮ್ಸು ಆ ಥರ ಎಲ್ಲ ಇರುತ್ತೆ. ಕೆಲವರಿಗೆ ಸ್ಪೈನಲ್ ಕಾರ್ಡ್ನಲ್ಲಿ ಪ್ರಾಬ್ಲಮ್ಸ್ ಇರುತ್ತೆ, ಸ್ಕೆಲ್ಟಲ್ ಮಸಲ್ನಲ್ಲಿ ಪ್ರಾಬ್ಲಮ್ಸ್ ಇರುತ್ತೆ. ಆ ಫ್ಯಾಮಿಲಿನಲ್ಲಿನೇ ರಿಲೇಷನ್ನಲ್ಲಿನೇ ಮದುವೆ ಆಗ್ತಾ ಇರುತ್ತೆ. ಸೊ ಆ ಥರ ಮಕ್ಕಳು ಹುಟ್ಟುತ್ತವೆ. ಆ ಥರ ಮಕ್ಕಳು ಹುಟ್ಟಬಾರ್ದು ಅಂತ, ಚೆನ್ನಾಗಿರೋ ಮಕ್ಕಳು ಹುಟ್ಟಬೇಕು. ನಮಗೆಲ್ಲರಿಗೂ ಚೆನ್ನಾಗಿರೋ ಮಗುನೂ ಬೇಕು. ಆ ಮಗು ಚೆನ್ನಾಗಿ ಓಡಾಡಬೇಕು, ಮಾತಾಡಬೇಕು, ಎಲ್ಲ ಮಾಡಬೇಕು, ಸ್ಕೂಲಿಗೆ ಹೋಗಬೇಕು. ಸೊ ಆ ಥರ ಮಕ್ಕಳು ಹುಟ್ಟಬೇಕು ಅಂತಂದರೆ ನಾವು IVF ಮಾಡಿ ಆ ಭ್ರೂಣದಿಂದ ಕೆಲವು ಸೆಲ್ಸ್ ತೆಗೆದು ಆ ಥರ ಪ್ರಾಬ್ಲಮ್ಸ್ ಆ ಭ್ರೂಣ ಹಾಕೋ ಮುಂಚೆನೇ, ಒಳಗಡೆ ಹಾಕೋ ಮುಂಚೆನೇ, ಅದು ಹೋಗಿ ಕಚ್ಕೊಳ್ಳೋ ಮುಂಚೆನೇ, ಮಗು ಆಗೋ ಮುಂಚೆನೇ ಆ ಭ್ರೂಣದಲ್ಲಿ ಆ ಥರ ಜೆನೆಟಿಕ್ ಪ್ರಾಬ್ಲಮ್ಸ್ ಇದೆಯಾ ಇಲ್ವಾ ಅಂತ ನಾವು ನೋಡ್ಬೋದು. ಅಥವಾ ಬುದ್ಧಿಮಾಂದ್ಯತೆ ಬರದೇ ಇರೋ ಹಾಗೆ ಯಾವ ಭ್ರೂಣದಲ್ಲಿ ಆ ಥರ ಬುದ್ಧಿಮಾಂದ್ಯತೆದು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ವೋ ಅದನ್ನು ಚೂಸ್ ಮಾಡಿ ನಾವು ಹಾಕ್ಬೋದು. ಸೊ ಆ ಥರ ಟೆಕ್ನಾಲಜಿ ಎಲ್ಲ ಬಂದಿದೆ. ಅದಕ್ಕೆ PGT ಅಂತ ಹೇಳ್ತೀವಿ, ಅಂದರೆ ಪ್ರೀ ಇಂಪ್ಲಾಂಟೇಷನ್ ಜೆನೆಟಿಕ್ ಟೆಸ್ಟಿಂಗ್. ಅಂದರೆ ಭ್ರೂಣ ಹಾಕೋ ಒಳಗಡೆ ಗರ್ಭಕೋಶದಲ್ಲಿ ಹಾಕೋ ಮುಂಚೆನೇ ನಾವು ಟೆಸ್ಟ್ ಮಾಡಿ ಜೆನೆಟಿಕಲಿ ನಾರ್ಮಲ್, ಅದ್ರದ್ದು ವಂಶವಾಹಿ ಸರಿಯಾಗಿದೆಯಾ ಇಲ್ವಾ ಅಂತ ನಾವು ನೋಡಿಕೊಂಡು ಅದನ್ನೇ ನಾವು ಹಾಕೋದು.
ಮ್ಯಾಮ್ ಈಗ IVF ಅಂದ್ರೆ ತುಂಬಾ ಪೇನ್ಫುಲ್ ಪ್ರೋಸೆಸ್ ಅಂತ ಕೆಲವರು ಹೇಳ್ತಾರೆ, ಅದ್ರ ಬಗ್ಗೆ ಹೇಳೋದಾದ್ರೆ ತುಂಬಾ ಜನಕ್ಕೆ ಭಯ ಇದೆ ಆಕ್ಚುಲಿ IVF ವಿಚಾರದಲ್ಲಿ, ಅದ್ರ ಬಗ್ಗೆ ಹೇಳೋದಾದ್ರೆ?
ತುಂಬ ಮಿಸ್ಕನ್ಸೆಪ್ಷನ್ಸ್ ಇವೆ IVF ಬಗ್ಗೆ. IVF ಪೇನ್ಫುಲ್ ಅಂತಂದರೆ ಬಂದು ಇಂಜೆಕ್ಷನ್ಸ್ ತೊಗೋಬೇಕು. ಅದು ಚಿಕ್ಕ ಇಂಜೆಕ್ಷನ್ಸ್, ಅದು ಸ್ವಲ್ಪ ಫಿಸಿಕಲ್ ಡಿಸ್ಕಂಫರ್ಟ್ ಅಷ್ಟೇ ಇರೋ ಹೊರತು ಬೇರೆ ಥರ ಪ್ರಾಬ್ಲಮ್ಸ್ ಇಲ್ಲ. ಬಟ್ ಏನಾಗುತ್ತೆ ಅಂತಂದರೆ IVF ಶುರು ಮಾಡಿದಾಗ ತುಂಬಾ ಜನ ನನಗೆ ಮಗು ಆಗಲೇಬೇಕು ಅಂತ ಬರ್ತಾರೆ. ಅದು ಒಳ್ಳೆ ಪಾಸಿಟಿವ್ ಥಿಂಕಿಂಗ್ ಇಟ್ಕೊಂಡು ಬರ್ತಾರೆ, ಬಟ್ ಎಲ್ಲರಿಗೂ ಆಗಲ್ಲ. ಸೊ ಸೈಕಲಾಜಿಕಲ್ ಡಿಸ್ಟ್ರೆಸ್, ಇಮೋಷ್ನಲ್ ಡಿಸ್ಟ್ರೆಸ್ ಅದು ಜಾಸ್ತಿ. ಫಿಸಿಕಲ್ ಪೇನ್ಗಿಂತ ಎಲ್ಲರೂ ಬಂದು ಇಂಜೆಕ್ಷನ್ಸ್ ತೊಗೊಳ್ತಾರೆ, ಇಂಜೆಕ್ಷನ್ಸ್ ಅಷ್ಟೊಂದು ಪೇನ್ಫುಲ್ ಅಲ್ಲ. ಬಟ್ ಆ್ಯಂಡ್ ಆಲ್ಸೋ ನಾವು ಅಂಡನ್ನು ತೆಗೆಯುವಾಗ ನಾವು ಅವ್ರಿಗೆ ಅನಿಸ್ಥೀಸಿಯಾ ಕೊಟ್ಟು ಅವ್ರಿಗೇನೂ ಗೊತ್ತಾಗಲ್ಲ. ಬಟ್ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗುತ್ತಾ ಇಲ್ವಾ ಅಂತ ಆ ಆಂಗ್ಸೈಟಿ ತುಂಬ ಜಾಸ್ತಿ. ಬಟ್ ಪೇನ್ಫುಲ್ ಪ್ರೊಸೆಸ್ ಅಲ್ಲ.
ಅಂದ್ರೆ ಮಗು ಆಗುತ್ತಾ ಇಲ್ವಾ ಅನ್ನೋ ಭಯ
ಜಾಸ್ತಿ, ಆಂಗ್ಸೈಟಿ, ಅಯ್ಯೋ ಆಗದೆ ಇದ್ರೆ ನಾನು ಏನು ಮಾಡೋದು ಅಂತ. ಬಟ್ ಏನು ಮಾಡೋದು ಅಂತ ಏನು ಇಲ್ವಲ್ಲ. ಅದು ಅವ್ರಿಗೆ ಸಾಕಷ್ಟು ಮೊಟ್ಟೆ ಬಂದರೆ ಅದನ್ನೆಲ್ಲ ನಾವು ಭ್ರೂಣಗಳು ಮಾಡಿ ಕೆಲವು ನಾವು ಹಾಕ್ತೀವಿ, 1-2 ಹಾಕ್ತೀವಿ, ಇನ್ನು ಮಿಕ್ಕಿದ್ದು 5-6 ನಾವು ಫ್ರೀಸ್ ಮಾಡ್ತೀವಿ. ಸೊ ಅಕಸ್ಮಾತ್ ಒಂದೇ ಸತಿ ನಾವು ಪ್ರೆಗ್ನೆನ್ಸಿ ನಾವು ಯಾರಿಗೂ ಬಂದ್ಬಿಡಿ 100% ಮಗು ಕೊಟ್ಬಿಡ್ತೀವಿ ಅಂತ ಹೇಳೋಕ್ಕಾಗಲ್ಲ. ಅದೆಲ್ಲ ತುಂಬ ತಪ್ಪು ಆ ಥರ ಮಾತಾಡೋದು. ಸೊ ಒಂದು ನಮ್ಮ ಹತ್ರ ಬಂದು ನಾವು 60% ಪ್ರೆಗ್ನೆನ್ಸಿ ರೇಟ್ ಇದೆ, 65%. ಬಟ್ 35 ಜನಕ್ಕೆ ಆಗಲ್ವಲ್ಲ, ಆ 100 ಜನಕ್ಕಲ್ಲಿ 35 ಜನಕ್ಕೆ ಆಗಲ್ಲ. ಸೊ ಮತ್ತೆ ಬರ್ಬೋದು. ಫ್ರೋಸನ್ ಎಂಬ್ರಿಯೋಸ್, ಆ ಎಂಬ್ರಿಯೋಸ್ ನಾವು ವಯಸ್ಸಲ್ಲಿ ಇಟ್ಟಿರ್ತೀವಿ, ಅದನ್ನ ಹಾಕ್ಸೋದಕ್ಕೆ ಮತ್ತೆ ಬರ್ಬೋದು.
ಮೇಡಮ್ ಅಂದ್ರೆ ಆಗದೆ ಇರೋದಕ್ಕೆ ಚಾನ್ಸಸ್ ಯಾವ ಥರ ಇರುತ್ತೆ ಮೇಡಮ್? ಏನು ರೀಸನ್ಸ್ ಇರುತ್ತೆ?
ತುಂಬ ಕಾರಣಗಳು. ಫಸ್ಟ್ ಆಫ್ ಆಲ್ ಭ್ರೂಣ ಹೇಗಿದೆ, ಓಕೆ, ಭ್ರೂಣ ನೋಡೋಕ್ಕೆ ಚೆನ್ನಾಗಿರ್ಬೋದು, ಬಟ್ ಅದು ವಂಶವಾಹಿ ಸರಿಯಾಗಿರದೇ ಇರ್ಬೋದು, ನಂಬರ್ 1. ಆ್ಯಂಡ್ ಮೆಜಾರಿಟಿ IVF ಯಾಕೆ ಫೇಲ್ ಆಗುತ್ತೆ ಅಂತಂದರೆ ಒಂದು 60-65% ಆಫ್ ದ ಟೈಮ್ಸ್ ಯಾಕೆ ಫೇಲ್ ಆಗುತ್ತೆ ಅಂತಂದರೆ ಆ ಭ್ರೂಣದ್ದು ಜೆನೆಟಿಕ್ ಮೇಕಪ್ ಅಂತಂದರೆ ಅದ್ರದ್ದು ವಂಶವಾಹಿ ಸರಿಯಾಗಿರಲ್ಲ. ಸೊ ಅದು ಒಳಗಡೆ ಹಾಕಿದಾಗ ಗರ್ಭಕೋಶ ಅದನ್ನ ಆಕ್ಸೆಪ್ಟ್ ಮಾಡಲ್ಲ. ಅದು ಆಕ್ಸೆಪ್ಟ್ ಮಾಡಿದ್ರೂ ಅದು ಮಿಸ್ಕ್ಯಾರೇಜ್ ಆಗುತ್ತೆ. ಸೊ ದಟ್ ಈಸ್ ಒನ್ ಆಫ್ ದ ಮೇನ್ ರೀಸನ್ಸ್. ಸೊ ಒಂದು ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗೋದಕ್ಕೆ ಜವಾಬ್ದಾರಿ ಒಂದು 75% ಭ್ರೂಣದ ಮೇಲೆ ಹೋಗುತ್ತೆ, ಇನ್ನು 25% ಗರ್ಭಕೋಶದ ಮೇಲೆ ಬೀಳುತ್ತೆ. ಸೊ ಗರ್ಭಕೋಶದಲ್ಲಿರೋ ಎಲ್ಲ ವಾತಾವರಣ ಚೆನ್ನಾಗಿರಬೇಕು. ಅದು ಹೋಗಿ ಅದಕ್ಕೆ ಕೂತ್ಕೊಳ್ಳುವಾಗ ನಾವು ಹಾಕಿದಾಗ ನಾವು ಹೋಗಿ ಗರ್ಭಕೋಶದ ಒಳಗಡೆ ನಾವು ಹೋಗಿ ಚುಚ್ಚಕ್ಕಾಗಲ್ಲ, ಬ್ಲೀಡಿಂಗ್ ಆಗಿಬಿಡುತ್ತೆ. ಸೊ ನಾವು ಚಿಕ್ಕದಾಗಿ ಜೆಂಟಲಾಗಿ ನಾವು ಹೋಗಿ ಅಲ್ಲಿ ಬಿಡ್ತೀವಿ. ಅದು ಹೋಗಿ ಗರ್ಭಕೋಶದ ಒಳಪದ್ರ ಜೊತೆಗೆ ಮಾತಾಡಬೇಕು, ಕಾನ್ವರ್ಸೇಷನ್ ಇರುತ್ತೆ. ಅದಕ್ಕೆ ಒಂದು ಸ್ಪೆಸಿಫಿಕ್ ಟರ್ಮ್ ಇದೆ, ಎಂಬ್ರಿಯೋ ಎಂಡೋಮೆಟ್ರಿಯಮ್ ಕ್ರಾಸ್ಟಾಕ್ ಅಂತ. ಅದು ಮಾತಾಡಿಕೊಂಡು ಓಕೆ ನೀನು ಬಂದಿದೆಯಾ, ಓಕೆ ನಾನು ಹಿಡ್ಕೊಳ್ತೀನಿ, ಹೌದು ನಾನು ಬಂದಿದ್ದೀನಿ, ನೀನು ಪ್ಲೀಸ್ ಹಿಡ್ಕೋ ಅಂತ ಮೆಸೆಂಜರ್ಸ್, ಕೆಮಿಕಲ್ಸ್ ಎಲ್ಲ ಎಕ್ಸ್ಚೇಂಜ್ ಆಗುತ್ತೆ. ಆಮೇಲೆ ಅದು ಹೋಗಿ ಅದನ್ನು ಹಿಡ್ಕೊಳ್ಳುತ್ತೆ, ಅದನ್ನು ಬೆಳೆಸಬೇಕು. ಸೊ ತುಂಬ ಕಾರಣಗಳಿವೆ ಅದು ಯಾಕೆ ಫೇಲ್ ಆಗುತ್ತೆ.
ಥ್ಯಾಂಕ್ ಯು ಮ್ಯಾಮ್, ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್.
ಥ್ಯಾಂಕ್ ಯು,
ಬ್ಯೂಟಿಫುಲ್ ಆಗಿ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡಿದ್ದಕ್ಕೆ ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್. ಇದಿಷ್ಟು ಡಾಕ್ಟರ್ ಗುಣಶೀಲ, ಫರ್ಟಿಲಿಟಿ ಎಕ್ಸ್ಪರ್ಟ್ ಆಗಿರೋರು ನಮ್ಮ ಜೊತೆಗೆ ನ್ಯೂಸ್ ಫಸ್ಟ್ ಜೊತೆಗೆ ಕೊಟ್ಟಿರುವಂತಹ ಉಪಯುಕ್ತವಾದ ಮಾಹಿತಿ. ಬಹುತೇಕ ಪೋಷಕರಾಗೋಲಕ್ಕೆ ಇರುವಂತಹ ಹಾದಿಯಲ್ಲಿ ಸವಾಲುಗಳು ಸಾಕಷ್ಟಿರುತ್ತೆ. ಆ ಸವಾಲುಗಳನ್ನ ಎದುರಿಸೋದು ಹೇಗೆ, ಎಮೋಷನಲಿ ಆ ಎಮೋಷನ್ಸ್ ಗಳನ್ನ ಯಾವ ರೀತಿಯಾಗಿ ಬ್ಯಾಲೆನ್ಸ್ ಮಾಡಬೇಕು, ಈ ಎಲ್ಲ ವಿಚಾರಗಳ ಬಗ್ಗೆ ತಿಳಿಸ್ಕೊಡೋದಕ್ಕೆ ನಮ್ಮ ಜೊತೆಗೆ ಪಾರ್ಟ್ 2 ಪೇರೆಂಟ್ಹುಡ್ ನ ಕಾರ್ಯಕ್ರಮದ ಮುಖ್ಯ ಅತಿಥಿಯಾಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಯೋಗೀಶ್ ಅವರಿದ್ದಾರೆ. ಅವ್ರನ್ನ ಮಾತನಾಡಿಸ್ತಾ ಹೋಗ್ತೀನಿ. ಖುಷಿ ಫರ್ಟಿಲಿಟಿ MD ಕೂಡ ಹೌದು ಅವರು, ಅವ್ರನ್ನ ಮಾತನಾಡಿಸ್ತಾ ಹೋಗ್ತೀನಿ. ಮೇಡಮ್ ಹಾಯ್. ಮೊದಲನೇದಾಗಿ ತುಂಬಾ ಚೆನ್ನಾಗಿ ಬ್ಯೂಟಿಫುಲ್ ಆಗಿ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡಿದ್ರಿ. ಸೊ ಈ ಬಂಜೆತನಕ್ಕೆ ಆಗುವಂತಹ ಸಮಸ್ಯೆಗಳೇನು?
ಮೊದಲನೇದಾಗಿ ಬಂಜೆತನ ಅಂತ ವರ್ಡೇ ನನಗೆ ಇಷ್ಟ ಆಗೋದಿಲ್ಲ. ಹೆಣ್ಮಕ್ಳಿಗೆ ಮಗು ಆಗೋದಕ್ಕೆ ತೊಂದರೆ ಆದ್ರೆ ಅಥವಾ ಒಂದ್ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಸಮಯ ತಗೊಂಡ್ರೆ ಅದಕ್ಕೆ ಅವಳಿಗೆ ನಿನ್ಗೆ ಮಗು ಆಗ್ತಾ ಇಲ್ಲ ಅಂತ ಯಾರಾದ್ರೂ ಹೇಳಿದ್ರೆ ಅದೇ ಒಂದು ದೊಡ್ಡ ಅಪರಾಧ ಅನ್ಸುತ್ತೆ. ಎಷ್ಟು ಒಂದು ಹೆಣ್ಣಿನ ಮನಸ್ಸಿಗೆ ಇದರಿಂದ ನೋವಾಗುತ್ತೆ ಅನ್ನೋದು ನಾವು ಶಬ್ದಗಳಲ್ಲಿ ಹೇಳಕ್ ಆಗೋದಿಲ್ಲ. ಯಾವುದೇ ಒಂದು ಜನ್ಮ ಅಂತ ತಾಳ್ಕೊಂಡಾಗ ನಮ್ಮ ದೇಹಕ್ಕೆ ಯಾವುದಾದ್ರೂ ಒಂದು ತೊಂದರೆ ಬಂದೇ ಬರುತ್ತೆ, ಇವತ್ತಿಲ್ಲೋ ನಾಳೆ ಬರುತ್ತೆ ನಮ್ ಲೈಫ್ ಸ್ಪ್ಯಾನ್ ಅಲ್ಲಿ. ಅದೇ ತರಹ ಎಲ್ಲ ಈ ತೊಂದರೆಗಳಿರ್ತವೆ, ಮಧುಮೇಹ, ಡಯಾಬಿಟೀಸು, ಮತ್ತೆ ಬ್ಲಡ್ ಪ್ರೆಷರ್ ಜಾಸ್ತಿ ಇರೋದು, ಹೈಪರ್ ಟೆನ್ಷನ್, ಇವೆಲ್ಲ ಪ್ರಾಬ್ಲಮ್ ತರ ಹೆಣ್ಮಕ್ಳಿಗೆ ಮಗು ಆಗೋದಕ್ಕೆ ಕಷ್ಟ ಆಗೋದು ಒಂದು ಸಹಜ. ಇವಾಗ ಇರೋ ಲೈಫ್ ಸ್ಟೈಲ್ ಇಶ್ಯೂಸ್ ಗಳಿಂದ ಹೆಣ್ಮಕ್ಳಿಗೆ ಅಂಡಾಣುಗಳ ಸಂಖ್ಯೆ ತುಂಬಾ ಬೇಗ ಕಡಿಮೆ ಆಗ್ತಾ ಇದೆ. ಅದರಿಂದ ಅವ್ರಿಗೆ ತುಂಬಾ ಕಷ್ಟ ಆಗ್ತಾ ಇದೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗೋದಕ್ಕೆ, ಎಸ್ಪೆಷಲಿ ವೆನ್ ದೇ ಆರ್ ಪೋಸ್ಟ್ಪೋನಿಂಗ್ ದಿಯರ್ ಪ್ರೆಗ್ನೆನ್ಸಿ. ಹೆಣ್ಮಕ್ಳಿಗೆ ಮೊದಲು 15-16 ವರ್ಷದಲ್ಲಿ ಆ ಟೈಮಲ್ಲಿ ಅವ್ರಿಗೆ ಹೆಣ್ಮಕ್ಳು ವಯಸ್ಸಿಗೆ ಬರ್ತಾ ಇದ್ರು. ಇವಾಗ 10 ವರ್ಷದ ವಯಸ್ಸಲ್ಲಿ 9 ವರ್ಷದ ವಯಸ್ಸಲ್ಲಿ ವಯಸ್ಸಿಗೆ ಬರ್ತಾ ಇದ್ದಾರೆ. ಕೆಲವೊಂದ್ಸತಿ ನಾವು ಕೆಲವೊಂದು ಇಂಜೆಕ್ಷನ್ಸ್ ನ ಕೊಟ್ಟು ಈ ವಯಸ್ಸಿಗೆ ಬಂದಿರೋ ಹುಡುಗಿಯರಿಗೆ ಅವರ ಎಗ್ ರಿಸರ್ವ್ ಇನ್ನೂ ಸ್ವಲ್ಪ ಚೆನ್ನಾಗಿರ್ಬೇಕು ಅಂತ ಕೆಲವೊಂದು GnRH ಅಗಾನಿಸ್ಟ್ ಇಂಜೆಕ್ಷನ್ ನ ಮಂತ್ಲಿ ಒನ್ಸ್ ಕೊಟ್ಟು ಅವರ ಪೀರಿಯಡ್ಸ್ ಸ್ಟಾರ್ಟ್ ಆಗೋದನ್ನ ಡಿಲೇ ಕೂಡ ಮಾಡ್ತಾ ಇದೀವಿ. ಇಂಥ ಪರಿಸ್ಥಿತಿಗೆ ನಾವು ಯಾಕೆ ಬಂದಿದೀವಿ ಅಂತ ಹೇಳ್ಬೇಕಾದ್ರೆ ಇಟ್ ಇಸ್ ಬಿಕಾಸ್ ಆಫ್ ಅವರ್ ಲೈಫ್ ಸ್ಟೈಲ್ ಅನ್ನೋದಕ್ಕೆ ವೆಸ್ಟರ್ನೈಸೇಷನ್ ಆಫ್ ಅನ್ ಇಂಡಿಯನ್ ಲೈಫ್ ಸ್ಟೈಲ್. ನಮ್ಮ ಇಂಡಿಯನ್ ಹೆಣ್ಮಕ್ಳು ಯಾವ ಊಟ ತಿನ್ಬೇಕು, ಯಾವ ತರ ಇರಬೇಕು, ಅದೇ ತರ ಇದ್ರೆ ಅದು ನಮ್ ಜೀನ್ಸ್ಗೆ ಸೂಟ್ ಆಗುತ್ತೆ. ವೆಸ್ಟರ್ನ್ ಹೆಣ್ಮಕ್ಳು ಆಲ್ಕೋಹಾಲ್ ತಗೋಬಹುದು, ಸಿಗರೆಟ್ ಸ್ಮೋಕ್ ಮಾಡಬಹುದು, ಆದ್ರೆ ಅದರಿಂದ ಅವ್ರಿಗೆ ಅಷ್ಟು ಬೇಗ ಎಗ್ ರಿಸರ್ವ್ ಕಡಿಮೆ ಆಗೋದಿಲ್ಲ. ಅವ್ರ ಜೀನ್ಸ್ಗೆ ಅದು ಸೂಟ್ ಆಗುತ್ತೆ. ನಮ್ಮ ಇಂಡಿಯನ್ ಹೆಣ್ಮಕ್ಳಿಗೆ ಆಲ್ಕೋಹಾಲ್ ತಗೊಳ್ಳೋದಾಗ್ಲಿ, ಸಿಗರೆಟ್ ಸೇದೋದಾಗ್ಲಿ ಅದು ನಮ್ ಜೀನ್ಸ್ಗೆ ಸೂಟ್ ಆಗೋದಿಲ್ಲ. ಇದರಿಂದ ಸಿಗರೆಟ್ ಸ್ಮೋಕಿಂಗ್ ಇಸ್ ಒನ್ ಆಫ್ ದ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಕಾಸ್ ಫಾರ್ ರೆಡ್ಯೂಸ್ಡ್ ಓವೇರಿಯನ್ ರಿಸರ್ವ್. ಎವ್ರಿ ಗರ್ಲ್ ಶುಡ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ದಿಸ್. ಒಂದ್ ಪಬ್ಗೆ ಹೋಗ್ಬಿಟ್ಟು ಆಲ್ಕೋಹಾಲ್ ತಗೊಂಡು ಸಿಗರೆಟ್ ನ ಸ್ಮೋಕ್ ಮಾಡ್ಬಿಟ್ರೆ ಅವರು ಮಾಡರ್ನ್ ಆಗೋದಿಲ್ಲ. Modern in their way of thinking is required, but not showing this as modern, because it is not suiting us and it is not doing any help to us. You will not believe cosmetics, nail polish, hair color, all of these are doing harm, because of which their ovarian reserve or egg reserve is coming down. ಇದನ್ನ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳೋದು ಅತಿ ಮುಖ್ಯ. ಹೆಣ್ಣು ಮಕ್ಕಳು ಚಿಕ್ಕ ವಯಸ್ಸಿನಿಂದನೇ ಇದನ್ನೆಲ್ಲ ಅರ್ಥ ಮಾಡ್ಕೊಂಡ್ರೇನೆ ನಮ್ಗೆ ಈ ಹೆಣ್ಮಕ್ಳು ಬೇಗ ವಯಸ್ಸಿಗೆ ಬರೋದನ್ನ ನಾವು ತಡೆ ಹಿಡಿಬಹುದು. ಏನಕ್ಕಂದ್ರೆ ಹೆಣ್ಮಕ್ಳು ದೇ ಆರ್ ಬಾರ್ನ್ ವಿತ್ ಅ ಫಿಕ್ಸ್ ನಂಬರ್ ಆಫ್ ಓಸೈಟ್ಸ್. ಇವತ್ತು ನಮ್ಗೆ ಇಷ್ಟು ಎಕ್ಸ್ ಇದೆ ಅಂತಂದ್ರೆ ನಮ್ಮ ಇಡೀ ಜೀವಮಾನಕ್ಕೆ ಅಷ್ಟೇ ಎಕ್ಸು. ಬೇಗ ಮುಟ್ಟು ಸ್ಟಾರ್ಟ್ ಆಗ್ಬಿಟ್ರೆ ಬೇಗ ಮುಟ್ಟು ನಿಂತು ಹೋಗುತ್ತೆ. ಬೇಗ ಮುಟ್ಟು ಸ್ಟಾರ್ಟ್ ಆದ್ರೆ ಮಗು ಬೇಕು ಅಂತ ಆಸೆ ಇರೋರು ಬೇಗ ಮಗು ಮಾಡ್ಕೊಳ್ಬೇಕು ಅಂತ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳೋ ಸಮಯ ಇದು. ಹೆಣ್ಣು ಮಕ್ಕಳಿಗೆ ಈ ನಾಲೆಜ್ ಕೊಡೋದೇ ನಮ್ಮ ಕರ್ತವ್ಯ. Path to Parenthood. This is a very, very good initiative with which we are trying to tell the world that taking treatment for infertility or subfertility is nothing but path to parenthood. You're actually walking towards a good cause. You're trying to have a child. There is nothing to hide. There is nothing to feel bad that you're entering into a fertility center. You are doing something good. You're trying to create a family. And what is wrong in trying to create a family? You can create a family with your own eggs and sperms, so why not go ahead? And we have so many advancements nowadays. Regenerative medicine in the intra-ovarian PRP, intra-ovarian stem cell therapy idella ಮಾಡ್ಬಿಟ್ಟು reduced ovarian reserve ಗೂ ನಾವು ಮತ್ತೆ egg reserve ಹೆಚ್ಚಿಗೆ ಮಾಡೋ ತರ ಮಾಡ್ಬಿಟ್ಟು ಅವರು ಸ್ವತಃ eggs and sperms ಅಲ್ಲಿ ಮಗು ಮಾಡಕ್ಕೆ ಎಷ್ಟೆಲ್ಲ ಸೌಲಭ್ಯಗಳು ಇರುವಾಗ I don't think somebody should get scared or feel ashamed to enter into a fertility center. It's my right to have a child, and if I want to do something for myself, why should I hesitate? ಈ ಮಾಡರ್ನ್ ಥಿಂಕಿಂಗ್ ಬರಬೇಕೇ ಹೊರತು ಬೇರೆ ಮಾಡರ್ನ್ ಮೆಥಡ್ಸ್ ಶುಡ್ ನಾಟ್ ಕಮ್ ಇನ್ ಟು ದಿಯರ್ ಮೈಂಡ್ಸ್.
ಮ್ಯಾಮ್ ನಿಮ್ಮ ಮಾತನ್ನ ಕೇಳ್ತಾ ಇದ್ರೆ ಕೇಳ್ತಾನೆ ಇರೋಣ ಅನ್ಸುತ್ತೆ. ಬಟ್ ನಂದು ಇನ್ನೊಂದು ಕ್ವಶನ್ ಇದೆ. ನೀವು ಮಾತಾಡ್ಬೇಕಾದ್ರೆ ಮೆನ್ಷನ್ ಮಾಡಿದ್ರಿ ಕುಡಿಯೋದ್ರಿಂದಾಗ್ಲಿ, ಸಿಗರೆಟ್ ಸೇದೋದ್ರಿಂದಾಗ್ಲಿ ಅಥವಾ ಕಾಸ್ಮೆಟಿಕ್ಸ್ ಇಂದಾಗ್ಲಿ ಇವೆಲ್ಲವೂ ಕೂಡ ಇನ್ಫರ್ಟಿಲಿಟಿಗೆ ಲೀಡ್ ಮಾಡುತ್ತೆ ಅಂತ. ಸೊ ಅದನ್ನ ಒಂದ್ ಸ್ವಲ್ಪ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡ್ಬೋದಾ? ಕುಡಿಯೋದು ಮತ್ತೆ ಕಾಸ್ಮೆಟಿಕ್ಸ್ ಯಾವ ತರ ಸಮಸ್ಯೆ ಆಗುತ್ತೆ ಅಂತ.
ಆಕ್ಚುಲಿ ನಾನು ಹೇಳ್ದಂಗೆ ಸಿಗರೆಟ್ ಸ್ಮೋಕಿಂಗ್ ಇಂದ, ಈ ಟೊಬ್ಯಾಕೋ ಇಂದ AMH ಕಡಿಮೆ ಆಗುತ್ತೆ. AMH ಅಂದ್ರೆ ಇಟ್ ಇಸ್ ಲೈಕ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡಿಂಗ್ ವಾಟ್ ಈಸ್ ಯೋರ್ ಬ್ಯಾಲೆನ್ಸ್ ಆಫ್ ಎಗ್ಸ್ ಇನ್ ಯೋರ್ ಬಾಡಿ. ಎಗ್ ಬ್ಯಾಲೆನ್ಸ್ ಕಡಿಮೆ ಆಗ್ಬಿಟ್ರೆ ಬೇಗ ಮುಟ್ಟು ನಿಂತು ಹೋಗುತ್ತೆ ಹೆಣ್ಮಕ್ಳಿಗೆ. ಈ ಎಗ್ ಡಿಸ್ಟ್ರಕ್ಷನ್ ಆಗೋದೇ ಸಿಗರೆಟ್ ಸ್ಮೋಕ್ ಇಂದ. ದಟ್ ಈಸ್ ವೈ ದ ಫಸ್ಟ್ ಥಿಂಗ್ ಅಂಡ್ ದ ಫಸ್ಟ್ ರಿಕ್ವೆಸ್ಟ್ ಟು ಆಲ್ ದ ಲೇಡೀಸ್ ಔಟ್ ಹಿಯರ್ ಇಸ್ ಪ್ಲೀಸ್ ಡೋಂಟ್ ಸ್ಮೋಕ್. ಇಫ್ ಯು ಆರ್ ಎನ್ ಇಂಡಿಯನ್, ಪ್ಲೀಸ್ ಡೋಂಟ್ ಸ್ಮೋಕ್ ಬಿಕಾಸ್ ಇಟ್ಸ್ ನಾಟ್ ಗೋಯಿಂಗ್ ವೆಲ್ ವಿತ್ ಯೋರ್ ಜೀನ್ಸ್. ಎಗ್ ರಿಸರ್ವ್ ನ ಕಾಪಾಡ್ಕೊಳ್ಳೋದು ಬಹಳ ಮುಖ್ಯ. ಅದು ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಥಿಂಗ್. ಎರಡನೇದಾಗಿ ಕೆಲವೊಂದ್ಸತಿ ಕೆಲವೊಬ್ರು ಹೆಣ್ಮಕ್ಳು ಆಲ್ಕೋಹಾಲ್ನ ಒಂದು ಸ್ಟ್ರೆಸ್ ಬಸ್ಟರ್ ತರ ಟ್ರೀಟ್ ಮಾಡ್ತಾರೆ. ಬಟ್ ಇಟ್ ಇಸ್ ನಾಟ್ ದ ಥಿಂಗ್. ಮೊದ್ಲಿನ ಕಾಲದಿಂದ ನಮ್ಮ ಹೆಣ್ಮಕ್ಳು ವೆನೆವರ್ ದೇ ಹ್ಯಾವ್ ಬೀನ್ ಸ್ಟ್ರೆಸ್ಡ್, ಅವ್ರು ಮಾಡಿರೋದೇನು ದೇವಸ್ಥಾನಕ್ಕೆ ಹೋಗಿ ಪೂಜೆ ಮಾಡೋದು ಅಂಡ್ ಟಾಕಿಂಗ್ ಟು ಪೀಪಲ್. ಇವೆರಡೂ ಇಸ್ ದೇರ್ ಇಂಬೈಬ್ಡ್ ಇನ್ ಅಸ್. ದಟ್ ಇಸ್ ವೈ ವಿ ಆರ್ ನೌ ಟೆಲಿಂಗ್ ಪೀಪಲ್, ಮೊದ್ಲಿನ ತರ ನಾವು ದೇವಸ್ಥಾನದಲ್ಲಿ ಹೋಗಿ ಕೂತು ಪೂಜಾರಿಗಳ ಜೊತೆಗೆ ಮಾತಾಡಕ್ ಆಗದೆ ಇದ್ರೆ ಇವಾಗಿನ ಜನರೇಷನ್ ಅಲ್ಲಿ ಯು ಶುಡ್ ಸ್ಟಾರ್ಟ್ ಮೆಡಿಟೇಟಿಂಗ್ and you should start connecting yourself with God, and you should try and talk to counselors. There is nothing wrong in going and approaching a counselor. ತುಂಬಾ ಜನ ಹೆಣ್ಮಕ್ಳು ಇವಾಗ ಏನ್ ಮಾಡ್ತಾರೆ, they don't want to share their problems with anybody because they are all independent, they are working, they are financially independent. ಅವರಲ್ಲಿರೋ negative points na ಅಥವಾ what they are going through, they don't want to expose and tell others. At the same time, they should also realize that there is nothing wrong in going and talking to a counselor. telling what they feel to a counselor who can give them the confidence. And I'm sure every counselor, every psychological counselor has it in them to keep it very confidential. ಅವ್ರಿಗೆ ಹೇಳಿರೋದನ್ನ ಇನ್ನೊಬ್ಬರ ಮುಂದೆ ಅವರು ಖಂಡಿತವಾಗೂ ಶೇರ್ ಮಾಡೋದಿಲ್ಲ. ಇದನ್ನ ಅರ್ಥ ಮಾಡಿಕೊಂಡು ಕೌನ್ಸಿಲಿಂಗ್ ಅನ್ನೋದನ್ನ ಎಕ್ಸೆಪ್ಟ್ ಮಾಡ್ಕೊಳ್ಳೋದು ಬಹಳ ಮುಖ್ಯ. ಇದರಿಂದ ಸ್ಟ್ರೆಸ್ ಲೆವೆಲ್ಸ್ ಕಮ್ಮಿ ಆಗುತ್ತೆ. ಇವತ್ತಿನ ಜನರೇಷನ್ ಅಲ್ಲಿ ಡಿಪ್ರೆಷನ್ ರೇಟ್ಸ್ ಆರ್ ವೆರಿ ಹೈ. The incidence of suicides have increased so much. ಇದನ್ನೆಲ್ಲ ತಡೆ ಹಿಡಿಬೇಕು ಅಂತಂದ್ರೆ psychological counseling should be given the utmost importance, and I think programs like Path to Parenthood will make every couple realize that going to a fertility center, taking help from psychologists and counselors is something which is very natural, and there is nothing wrong in doing it. I feel these are the most important things that have to be focused on in today's date.
Thank you so much. ತುಂಬಾ ಚೆನ್ನಾಗಿ ಮಾತಾಡಿದ್ರಿ. Thank you so much.
Thanks for the opportunity. And yes, people, check your fertility score. Try and understand where you stand in this, whether your ovarian reserve is good and your sperm counts are good, and then only postpone the pregnancy. Think about conception before contraception. This is one message to everybody. And my talk will not be complete if I have not addressed on a very, very important topic. The important topic is erectile dysfunction. ಇವತ್ತಿನ generation ಅಲ್ಲಿ, because of the stress men go through for the kind of work they do, and because of the targets they have in their professional life, and because of inability to face multifaceted challenges in their life, they have problems with erection, and this is something which is not talked about. Erectile dysfunction is common, but people don't know that it is common because it cannot be openly spoken. That is why men should not hesitate when they have erectile dysfunction, and they should not feel that they are losing their self-esteem in front of their wife and try to avoid having sex at all. That is something which has to be taken as a natural phenomenon. Try to work towards it by doing things like regular exercises. You can take medical help. Try and understand. Sometimes diabetes is a very important cause for erectile dysfunction. People are not aware of this. Erectile dysfunction iddaga checking your blood sugar levels is the most important aspect that has to be given importance to. That is why seeing a doctor in such situations will make things easier. ಇದು ಒಂದೇ ಒಂದು ಫ್ಯಾಕ್ಟರ್ ಇರೋದಕ್ಕೆ ಹೆಣ್ಮಕ್ಳನ್ನ ಹಾಸ್ಪಿಟಲ್ಗೆ ಕರ್ಕೊಂಡು ಹೋಗ್ಲಾರ್ದೇ ಇದ್ದು ತುಂಬಾ ಸಮಯ ಆದ್ಮೇಲೆ ಹೆಣ್ಮಕ್ಳನ್ನ ಹಾಸ್ಪಿಟಲ್ ಕರ್ಕೊಂಡು ಹೋಗಿ ನಮ್ಗೆ ಮಗು ಬೇಕು ಅಂತ ಕೇಳಿದಾಗ ಹೆಣ್ಮಕ್ಳ ವಯಸ್ಸು ಮೀರಿ ಹೋಗ್ಬಿಡುತ್ತೆ. ಆದ್ರಿಂದ ಇದೆಲ್ಲ ಪ್ರಾಬ್ಲಮ್ಸ್ ನ ಒಂದು ಕಾಮನ್ ಸಿಚುವೇಶನ್ ಅಂತ ಅನ್ಕೊಂಡು trying to shun the ego and going ahead for treatments is something very, very important. And I thought if I don't talk about this, it will not be complete. Thank you.
ಸೊ ಇದಿಷ್ಟು ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಅವರು ನ್ಯೂಸ್ ಫಸ್ಟ್ ಗೆ ಹೇಳ್ತಾ ಇರುವಂತಹ ಮಾಹಿತಿ. ಅಂದ್ರೆ ಕೇಳಿದ್ರಲ್ಲ, ಸ್ಟ್ರೆಸ್ ಅಂತ ಸಿಗರೇಟ್ ಸೇದಬಾರ್ದು, ಫ್ಯಾಷನ್ ಅಂತ ಕುಡಿಯೋಕ್ ಹೋಗ್ಬಾರ್ದು. ಇವೆಲ್ಲವನ್ನ ಮಾಡ್ಕೊಂಡ್ರೆ ಅಂದ್ರೆ ನಮ್ಮ ಲೈಫ್ ಸ್ಟೈಲ್ ನ ಬೇರೆಯವ್ರಿಗೋಸ್ಕರ ಅಥವಾ ಯಾರೋ ನೋಡ್ತಾರೆ ಅಂತ ಚೇಂಜ್ ಮಾಡ್ಕೊಳಕ್ ಹೋದ್ರೆ ಅದು ಕೂಡ ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ಸಮಸ್ಯೆ ಆಗುವಂತಹ ಸಾಧ್ಯತೆ ಇದೆ ಅನ್ನುವಂತಹ ಮಾಹಿತಿಯನ್ನ ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಅವರು ನ್ಯೂಸ್ ಫಸ್ಟ್ ಜೊತೆಗೆ ಹಂಚ್ಕೊಳ್ತಾ ಇದ್ರು. ಕ್ಯಾಮರಾಮನ್ ಚಂದ್ರೇಶ್ ಜೊತೆ ಪ್ರಗತಿ ಶೆಟ್ಟಿ, ನ್ಯೂಸ್ ಫಸ್ಟ್, ಬೆಂಗಳೂರು. ಪೋಷಕರಾಗೋಲಕ್ಕೆ ಇರುವಂತಹ ಹಾದಿಯಲ್ಲಿ ಸವಾಲುಗಳು ಸಾಕಷ್ಟಿರುತ್ತೆ. ಆ ಸವಾಲುಗಳನ್ನ ಎದುರಿಸೋದು ಹೇಗೆ, ಎಮೋಷನಲಿ ಅವುಗಳನ್ನ ಆ ಎಮೋಷನ್ಸ್ ಗಳನ್ನ ಯಾವ ರೀತಿಯಾಗಿ ಬ್ಯಾಲೆನ್ಸ್ ಮಾಡಬೇಕು, ಈ ಎಲ್ಲ ವಿಚಾರಗಳ ಬಗ್ಗೆ ತಿಳಿಸ್ಕೊಡೋದಕ್ಕೆ ನಮ್ಮ ಜೊತೆಗೆ ಪಾತ್ ಟು ಪೇರೆಂಟ್ಹುಡ್ ನ ಕಾರ್ಯಕ್ರಮದ ಮುಖ್ಯ ಅತಿಥಿಯಾಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಯೋಗೀಶ್ ಅವರಿದ್ದಾರೆ. ಅವ್ರನ್ನ ಮಾತನಾಡಿಸ್ತಾ ಹೋಗ್ತೀನಿ. ಖುಷಿ ಫರ್ಟಿಲಿಟಿ MD ಕೂಡ ಹೌದು ಅವರು. ಅವ್ರನ್ನ ಮಾತನಾಡಿಸ್ತಾ ಹೋಗ್ತೀನಿ. ಮೇಡಮ್ ಹಾಯ್. ಮೊದಲನೇದಾಗಿ ತುಂಬಾ ಚೆನ್ನಾಗಿ ಬ್ಯೂಟಿಫುಲ್ ಆಗಿ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡಿದ್ರಿ. ಸೊ ಈ ಬಂಜೆತನಕ್ಕೆ ಆಗುವಂತಹ ಸಮಸ್ಯೆಗಳೇನು?
ಮೊದಲನೇದಾಗಿ ಬಂಜೆತನ ಅಂತ ವರ್ಡೇ ನನಗೆ ಇಷ್ಟ ಆಗೋದಿಲ್ಲ. ಹೆಣ್ಮಕ್ಳಿಗೆ ಮಗು ಆಗೋದಕ್ಕೆ ತೊಂದರೆ ಆದ್ರೆ ಅಥವಾ ಒಂದ್ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಸಮಯ ತಗೊಂಡ್ರೆ ಅದಕ್ಕೆ ಅವಳಿಗೆ ನಿನ್ಗೆ ಮಗು ಆಗ್ತಾ ಇಲ್ಲ ಅಂತ ಯಾರಾದ್ರೂ ಹೇಳಿದ್ರೆ ಅದೇ ಒಂದು ದೊಡ್ಡ ಅಪರಾಧ ಅನ್ಸುತ್ತೆ. ಎಷ್ಟು ಒಂದು ಹೆಣ್ಣಿನ ಮನಸ್ಸಿಗೆ ಇದರಿಂದ ನೋವಾಗುತ್ತೆ ಅನ್ನೋದು ನಾವು ಶಬ್ದಗಳಲ್ಲಿ ಹೇಳಕ್ ಆಗೋದಿಲ್ಲ. ಯಾವುದೇ ಒಂದು ಜನ್ಮ ಅಂತ ತಾಳ್ಕೊಂಡಾಗ ನಮ್ಮ ದೇಹಕ್ಕೆ ಯಾವುದಾದ್ರೂ ಒಂದು ತೊಂದರೆ ಬಂದೇ ಬರುತ್ತೆ. ಇವತ್ತಿಲ್ಲೋ ನಾಳೆ ಬರುತ್ತೆ ನಮ್ ಲೈಫ್ ಸ್ಪ್ಯಾನ್ ಅಲ್ಲಿ. ಅದೇ ತರಹ ಎಲ್ಲ ಈ ತೊಂದರೆಗಳಿರ್ತವೆ. ಮಧುಮೇಹ, ಡಯಾಬಿಟೀಸು, ಮತ್ತೆ ಬ್ಲಡ್ ಪ್ರೆಷರ್ ಜಾಸ್ತಿ ಇರೋದು, ಹೈಪರ್ ಟೆನ್ಷನ್, ಇವೆಲ್ಲ ಪ್ರಾಬ್ಲಮ್ ತರ ಹೆಣ್ಮಕ್ಳಿಗೆ ಮಗು ಆಗೋದಕ್ಕೆ ಕಷ್ಟ ಆಗೋದು ಒಂದು ಸಹಜ. ಇವಾಗ ಇರೋ ಲೈಫ್ ಸ್ಟೈಲ್ ಇಶ್ಯೂಸ್ ಗಳಿಂದ ಹೆಣ್ಮಕ್ಳಿಗೆ ಅಂಡಾಣುಗಳ ಸಂಖ್ಯೆ ತುಂಬಾ ಬೇಗ ಕಡಿಮೆ ಆಗ್ತಾ ಇದೆ. ಅದರಿಂದ ಅವ್ರಿಗೆ ತುಂಬಾ ಕಷ್ಟ ಆಗ್ತಾ ಇದೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗೋದಕ್ಕೆ, ಎಸ್ಪೆಷಲಿ ವೆನ್ ದೇ ಆರ್ ಪೋಸ್ಟ್ಪೋನಿಂಗ್ ದಿಯರ್ ಪ್ರೆಗ್ನೆನ್ಸಿ. ಹೆಣ್ಮಕ್ಳಿಗೆ ಮೊದಲು 15-16 ವರ್ಷದಲ್ಲಿ ಆ ಟೈಮಲ್ಲಿ ಅವ್ರಿಗೆ ಹೆಣ್ಮಕ್ಳು ವಯಸ್ಸಿಗೆ ಬರ್ತಾ ಇದ್ರು. ಇವಾಗ 10 ವರ್ಷದ ವಯಸ್ಸಲ್ಲಿ, 9 ವರ್ಷದ ವಯಸ್ಸಲ್ಲಿ ವಯಸ್ಸಿಗೆ ಬರ್ತಾ ಇದ್ದಾರೆ. ಕೆಲವೊಂದ್ಸತಿ ನಾವು ಕೆಲವೊಂದು ಇಂಜೆಕ್ಷನ್ಸ್ನ ಕೊಟ್ಟು ಈ ವಯಸ್ಸಿಗೆ ಬಂದಿರೋ ಹುಡುಗಿಯರಿಗೆ ಅವರ ಎಗ್ ರಿಸರ್ವ್ ಇನ್ನೂ ಸ್ವಲ್ಪ ಚೆನ್ನಾಗಿರ್ಬೇಕು ಅಂತ ಕೆಲವೊಂದು GnRH ಎಗಾನಿಸ್ಟ್ ಇಂಜೆಕ್ಷನ್ ನ ಮಂತ್ಲಿ ಒನ್ಸ್ ಕೊಟ್ಟು ಅವರ ಪೀರಿಯಡ್ಸ್ ಸ್ಟಾರ್ಟ್ ಆಗೋದನ್ನ ಡಿಲೇ ಕೂಡ ಮಾಡ್ತಾ ಇದೀವಿ. ಇಂಥ ಪರಿಸ್ಥಿತಿಗೆ ನಾವು ಯಾಕೆ ಬಂದಿದೀವಿ ಅಂತ ಹೇಳ್ಬೇಕಾದ್ರೆ ಇಟ್ ಈಸ್ ಬಿಕಾಸ್ ಆಫ್ ಅವರ್ ಲೈಫ್ ಸ್ಟೈಲ್ ಅನ್ನೋದಕ್ಕೆ ವೆಸ್ಟರ್ನೈಸೇಷನ್ ಆಫ್ ಅನ್ ಇಂಡಿಯನ್ ಲೈಫ್ ಸ್ಟೈಲ್. ನಮ್ಮ ಇಂಡಿಯನ್ ಹೆಣ್ಮಕ್ಳು ಯಾವ ಊಟ ತಿನ್ಬೇಕು, ಯಾವ ತರ ಇರಬೇಕು, ಅದೇ ತರ ಇದ್ರೆ ಅದು ನಮ್ ಜೀನ್ಸ್ಗೆ ಸೂಟ್ ಆಗುತ್ತೆ. ವೆಸ್ಟರ್ನ್ ಹೆಣ್ಮಕ್ಳು ಆಲ್ಕೋಹಾಲ್ ತಗೋಬಹುದು, ಸಿಗರೆಟ್ ಸ್ಮೋಕ್ ಮಾಡಬಹುದು, ಆದ್ರೆ ಅದರಿಂದ ಅವ್ರಿಗೆ ಅಷ್ಟು ಬೇಗ ಎಗ್ ರಿಸರ್ವ್ ಕಡಿಮೆ ಆಗೋದಿಲ್ಲ. ಅವ್ರ ಜೀನ್ಸ್ಗೆ ಅದು ಸೂಟ್ ಆಗುತ್ತೆ. ನಮ್ಮ ಇಂಡಿಯನ್ ಹೆಣ್ಮಕ್ಳಿಗೆ ಆಲ್ಕೋಹಾಲ್ ತಗೊಳ್ಳೋದಾಗ್ಲಿ, ಸಿಗರೆಟ್ ಸೇದೋದಾಗ್ಲಿ ಅದು ನಮ್ ಜೀನ್ಸ್ಗೆ ಸೂಟ್ ಆಗೋದಿಲ್ಲ. ಇದರಿಂದ ಸಿಗರೆಟ್ ಸ್ಮೋಕಿಂಗ್ ಇಸ್ ಒನ್ ಆಫ್ ದ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಕಾಸ್ ಫಾರ್ ರೆಡ್ಯೂಸ್ಡ್ ಓವೇರಿಯನ್ ರಿಸರ್ವ್. ಎವ್ರಿ ಗರ್ಲ್ ಶುಡ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ದಿಸ್. ಒಂದ್ ಪಬ್ಗೆ ಹೋಗ್ಬಿಟ್ಟು ಆಲ್ಕೋಹಾಲ್ ತಗೊಂಡು ಸಿಗರೆಟ್ ನ ಸ್ಮೋಕ್ ಮಾಡ್ಬಿಟ್ರೆ ಅವರು ಮಾಡರ್ನ್ ಆಗೋದಿಲ್ಲ. Modern in their way of thinking is required, but not showing this as modern, because it is not suiting us and it is not doing any help to us. You will not believe cosmetics, nail polish, hair color, all of these are doing harm, because of which their ovarian reserve or egg reserve is coming down. ಇದನ್ನ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳೋದು ಅತಿ ಮುಖ್ಯ. ಹೆಣ್ಣು ಮಕ್ಕಳು ಚಿಕ್ಕ ವಯಸ್ಸಿನಿಂದನೇ ಇದನ್ನೆಲ್ಲ ಅರ್ಥ ಮಾಡ್ಕೊಂಡ್ರೇನೆ ನಮ್ಗೆ ಈ ಹೆಣ್ಮಕ್ಳು ಬೇಗ ವಯಸ್ಸಿಗೆ ಬರೋದನ್ನ ನಾವು ತಡೆ ಹಿಡಿಬಹುದು. ಏನಕ್ಕಂದ್ರೆ ಹೆಣ್ಮಕ್ಳು ದೇ ಆರ್ ಬಾರ್ನ್ ವಿತ್ ಅ ಫಿಕ್ಸ್ ನಂಬರ್ ಆಫ್ ಓಸೈಟ್ಸ್. ಇವತ್ತು ನಮ್ಗೆ ಇಷ್ಟು ಎಕ್ಸ್ ಇದೆ ಅಂತಂದ್ರೆ ನಮ್ಮ ಇಡೀ ಜೀವಮಾನಕ್ಕೆ ಅಷ್ಟೇ ಎಕ್ಸು. ಬೇಗ ಮುಟ್ಟು ಸ್ಟಾರ್ಟ್ ಆಗ್ಬಿಟ್ರೆ ಬೇಗ ಮುಟ್ಟು ನಿಂತು ಹೋಗುತ್ತೆ. ಬೇಗ ಮುಟ್ಟು ಸ್ಟಾರ್ಟ್ ಆದ್ರೆ ಮಗು ಬೇಕು ಅಂತ ಆಸೆ ಇರೋರು ಬೇಗ ಮಗು ಮಾಡ್ಕೊಳ್ಬೇಕು ಅಂತ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳೋ ಸಮಯ ಇದು. ಹೆಣ್ಣು ಮಕ್ಕಳಿಗೆ ಈ ನಾಲೆಜ್ ಕೊಡೋದೇ ನಮ್ಮ ಕರ್ತವ್ಯ. Path to Parenthood. This is a very, very good initiative with which we are trying to tell the world that taking treatment for infertility or subfertility is nothing but path to parenthood. You're actually walking towards a good cause. You're trying to have a child. There is nothing to hide. There is nothing to feel bad that you're entering into a fertility center. You are doing something good. You're trying to create a family. And what is wrong in trying to create a family? You can create a family with your own eggs and sperms, so why not go ahead? And we have so many advancements nowadays. Regenerative medicine in the intra-ovarian PRP, intra-ovarian stem cell therapy idella ಮಾಡ್ಬಿಟ್ಟು reduced ovarian reserve ಗೂ ನಾವು ಮತ್ತೆ egg reserve ಹೆಚ್ಚಿಗೆ ಮಾಡೋ ತರ ಮಾಡ್ಬಿಟ್ಟು ಅವರು ಸ್ವತಃ eggs and sperms ಅಲ್ಲಿ ಮಗು ಮಾಡಕ್ಕೆ ಎಷ್ಟೆಲ್ಲ ಸೌಲಭ್ಯಗಳು ಇರುವಾಗ I don't think somebody should get scared or feel ashamed to enter into a fertility center. It's my right to have a child, and if I want to do something for myself, why should I hesitate? ಈ ಮಾಡರ್ನ್ ಥಿಂಕಿಂಗ್ ಬರಬೇಕೇ ಹೊರತು ಬೇರೆ ಮಾಡರ್ನ್ ಮೆಥಡ್ಸ್ ಶುಡ್ ನಾಟ್ ಕಮ್ ಇನ್ ಟು ದಿಯರ್ ಮೈಂಡ್ಸ್.
ಮ್ಯಾಮ್ ನಿಮ್ಮ ಮಾತನ್ನ ಕೇಳ್ತಾ ಇದ್ರೆ ಕೇಳ್ತಾನೆ ಇರೋಣ ಅನ್ಸುತ್ತೆ. ಬಟ್ ನಂದು ಇನ್ನೊಂದು ಕ್ವಶನ್ ಇದೆ. ನೀವು ಮಾತಾಡ್ಬೇಕಾದ್ರೆ ಮೆನ್ಷನ್ ಮಾಡಿದ್ರಿ ಕುಡಿಯೋದ್ರಿಂದಾಗ್ಲಿ, ಸಿಗರೆಟ್ ಸೇದೋದ್ರಿಂದಾಗ್ಲಿ ಅಥವಾ ಕಾಸ್ಮೆಟಿಕ್ಸ್ ಇಂದಾಗ್ಲಿ ಇವೆಲ್ಲವೂ ಕೂಡ ಇನ್ಫರ್ಟಿಲಿಟಿಗೆ ಲೀಡ್ ಮಾಡುತ್ತೆ ಅಂತ. ಸೊ ಅದನ್ನ ಒಂದ್ ಸ್ವಲ್ಪ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡ್ಬೋದಾ? ಕುಡಿಯೋದು ಮತ್ತೆ ಕಾಸ್ಮೆಟಿಕ್ಸ್ ಯಾವ ತರ ಸಮಸ್ಯೆ ಆಗುತ್ತೆ ಅಂತ.
ಆಕ್ಚುಲಿ ನಾನು ಹೇಳ್ದಂಗೆ ಸಿಗರೆಟ್ ಸ್ಮೋಕಿಂಗ್ ಇಂದ, ಈ ಟೊಬ್ಯಾಕೋ ಇಂದ AMH ಕಡಿಮೆ ಆಗುತ್ತೆ. AMH ಅಂದ್ರೆ ಇಟ್ ಈಸ್ ಲೈಕ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡಿಂಗ್ ವಾಟ್ ಈಸ್ ಯೋರ್ ಬ್ಯಾಲೆನ್ಸ್ ಆಫ್ ಎಗ್ಸ್ ಇನ್ ಯೋರ್ ಬಾಡಿ. ಎಗ್ ಬ್ಯಾಲೆನ್ಸ್ ಕಡಿಮೆ ಆಗ್ಬಿಟ್ರೆ ಬೇಗ ಮುಟ್ಟು ನಿಂತು ಹೋಗುತ್ತೆ ಹೆಣ್ಮಕ್ಳಿಗೆ. ಈ ಎಗ್ ಡಿಸ್ಟ್ರಕ್ಷನ್ ಆಗೋದೇ ಸಿಗರೆಟ್ ಸ್ಮೋಕ್ ಇಂದ. ದಟ್ ಈಸ್ ವೈ ದ ಫಸ್ಟ್ ಥಿಂಗ್ ಅಂಡ್ ದ ಫಸ್ಟ್ ರಿಕ್ವೆಸ್ಟ್ ಟು ಆಲ್ ದ ಲೇಡೀಸ್ ಔಟ್ ಹಿಯರ್ ಇಸ್ ಪ್ಲೀಸ್ ಡೋಂಟ್ ಸ್ಮೋಕ್. ಇಫ್ ಯು ಆರ್ ಎನ್ ಇಂಡಿಯನ್, ಪ್ಲೀಸ್ ಡೋಂಟ್ ಸ್ಮೋಕ್ ಬಿಕಾಸ್ ಇಟ್ಸ್ ನಾಟ್ ಗೋಯಿಂಗ್ ವೆಲ್ ವಿತ್ ಯೋರ್ ಜೀನ್ಸ್. ಎಗ್ ರಿಸರ್ವ್ ನ ಕಾಪಾಡ್ಕೊಳ್ಳೋದು ಬಹಳ ಮುಖ್ಯ. ಅದು ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಥಿಂಗ್. ಎರಡನೇದಾಗಿ ಕೆಲವೊಂದ್ಸತಿ ಕೆಲವೊಬ್ರು ಹೆಣ್ಮಕ್ಳು ಆಲ್ಕೋಹಾಲ್ನ ಒಂದು ಸ್ಟ್ರೆಸ್ ಬಸ್ಟರ್ ತರ ಟ್ರೀಟ್ ಮಾಡ್ತಾರೆ. ಬಟ್ ಇಟ್ ಇಸ್ ನಾಟ್ ದ ಥಿಂಗ್. ಮೊದ್ಲಿನ ಕಾಲದಿಂದ ನಮ್ಮ ಹೆಣ್ಮಕ್ಳು ವೆನೆವರ್ ದೇ ಹ್ಯಾವ್ ಬೀನ್ ಸ್ಟ್ರೆಸ್ಡ್, ಅವ್ರು ಮಾಡಿರೋದೇನು ದೇವಸ್ಥಾನಕ್ಕೆ ಹೋಗಿ ಪೂಜೆ ಮಾಡೋದು ಅಂಡ್ ಟಾಕಿಂಗ್ ಟು ಪೀಪಲ್. ಇವೆರಡೂ ಇಸ್ ದೇರ್ ಇಂಬೈಬ್ಡ್ ಇನ್ ಅಸ್. ದಟ್ ಇಸ್ ವೈ ವಿ ಆರ್ ನೌ ಟೆಲಿಂಗ್ ಪೀಪಲ್, ಮೊದ್ಲಿನ ತರ ನಾವು ದೇವಸ್ಥಾನದಲ್ಲಿ ಹೋಗಿ ಕೂತು ಪೂಜಾರಿಗಳ ಜೊತೆಗೆ ಮಾತಾಡಕ್ ಆಗದೆ ಇದ್ರೆ ಇವಾಗಿನ ಜನರೇಷನ್ ಅಲ್ಲಿ ಯು ಶುಡ್ ಸ್ಟಾರ್ಟ್ ಮೆಡಿಟೇಟಿಂಗ್ and you should start connecting yourself with God, and you should try and talk to counselors. There is nothing wrong in going and approaching a counselor. ತುಂಬಾ ಜನ ಹೆಣ್ಮಕ್ಳು ಇವಾಗ ಏನ್ ಮಾಡ್ತಾರೆ, they don't want to share their problems with anybody because they are all independent, they are working, they are financially independent. ಅವರಲ್ಲಿರೋ negative points na ಅಥವಾ what they are going through, they don't want to expose and tell others. At the same time, they should also realize that there is nothing wrong in going and talking to a counselor, telling what they feel to a counselor who can give them the confidence. And I'm sure every counselor, every psychological counselor has it in them to keep it very confidential. ಅವ್ರಿಗೆ ಹೇಳಿರೋದನ್ನ ಇನ್ನೊಬ್ಬರ ಮುಂದೆ ಅವರು ಖಂಡಿತವಾಗೂ ಶೇರ್ ಮಾಡೋದಿಲ್ಲ. ಇದನ್ನ ಅರ್ಥ ಮಾಡಿಕೊಂಡು ಕೌನ್ಸಿಲಿಂಗ್ ಅನ್ನೋದನ್ನ ಎಕ್ಸೆಪ್ಟ್ ಮಾಡ್ಕೊಳ್ಳೋದು ಬಹಳ ಮುಖ್ಯ. ಇದರಿಂದ ಸ್ಟ್ರೆಸ್ ಲೆವೆಲ್ಸ್ ಕಮ್ಮಿ ಆಗುತ್ತೆ. ಇವತ್ತಿನ ಜನರೇಷನ್ ಅಲ್ಲಿ ಡಿಪ್ರೆಷನ್ ರೇಟ್ಸ್ ಆರ್ ವೆರಿ ಹೈ. The incidence of suicides have increased so much. ಇದನ್ನೆಲ್ಲ ತಡೆ ಹಿಡಿಬೇಕು ಅಂತಂದ್ರೆ psychological counseling should be given the utmost importance, and I think programs like Path to Parenthood will make every couple realize that going to a fertility center, taking help from psychologists and counselors is something which is very natural, and there is nothing wrong in doing it. I feel these are the most important things that have to be focused on in today's
Thank you,
date.
ma'am. Thank you so much. ತುಂಬಾ ಚೆನ್ನಾಗಿ ಮಾತಾಡಿದ್ರಿ. Thank you so much.
Thanks for the opportunity. And yes, people, check your fertility score. Try and understand where you stand in this, whether your ovarian reserve is good and your sperm counts are good, and then only postpone the pregnancy. Think about conception before contraception. This is one message to everybody. And my talk will not be complete if I have not addressed on a very, very important topic. The important topic is erectile dysfunction. ಇವತ್ತಿನ ಜನರೇಷನಲ್ಲಿ because of the stress men go through for the kind of work they do, and because of the targets they have in their professional life, and because of inability to face multifaceted challenges in their life, they have problems with erection, and this is something which is not talked about. Erectile dysfunction is common, but people don't know that it is common because it cannot be openly spoken. That is why men should not hesitate when they have erectile dysfunction, and they should not feel that they are losing their self-esteem in front of their wife and try to avoid having sex at all. That is something which has to be taken as a natural phenomenon. Try to work towards it by doing things like regular exercises. You can take medical help. Try and understand. Sometimes diabetes is a very important cause for erectile dysfunction. People are not aware of this. Erectile dysfunction iddaga checking your blood sugar levels is the most important aspect that has to be given importance to. That is why seeing a doctor in such situations will make things easier. ಇದು ಒಂದೇ ಒಂದು ಫ್ಯಾಕ್ಟರ್ ಇರೋದಕ್ಕೆ ಹೆಣ್ಮಕ್ಳನ್ನ ಹಾಸ್ಪಿಟಲ್ಗೆ ಕರ್ಕೊಂಡು ಹೋಗ್ಲಾರ್ದೇ ಇದ್ದು ತುಂಬಾ ಸಮಯ ಆದ್ಮೇಲೆ ಹೆಣ್ಮಕ್ಳನ್ನ ಹಾಸ್ಪಿಟಲ್ ಕರ್ಕೊಂಡು ಹೋಗಿ ನಮ್ಗೆ ಮಗು ಬೇಕು ಅಂತ ಕೇಳಿದಾಗ ಹೆಣ್ಮಕ್ಳ ವಯಸ್ಸು ಮೀರಿ ಹೋಗ್ಬಿಡುತ್ತೆ. ಆದ್ರಿಂದ ಇದೆಲ್ಲ ಪ್ರಾಬ್ಲಮ್ಸ್ ನ ಒಂದು ಕಾಮನ್ ಸಿಚುವೇಶನ್ ಅಂತ ಅನ್ಕೊಂಡು trying to shun the ego and going ahead for treatments is something very, very important. And I thought if I don't talk about this, it will not be complete. Thank you.
ಸೊ ಇದಿಷ್ಟು ಡಾಕ್ಟರ್ ರಶ್ಮಿ ಅವರು ನ್ಯೂಸ್ ಫಸ್ಟ್ ಗೆ ಹೇಳ್ತಾ ಇರುವಂತಹ ಮಾಹಿತಿ. ಅಂದ್ರೆ ಕೇಳಿದ್ರಲ್ಲ, ಸ್ಟ್ರೆಸ್ ಅಂತ ಸಿಗರೇಟ್ ಸೇದಬಾರ್ದು.
The sperm too, but when do we select is very important. That has been formulated by ICMR. Okay, a girl below 21 years cannot take any donor eggs or the sperms, and a married couple are eligible to take, and that too a married couple staying together for 2 years can take these donor sperms and donor eggs. Okay, and this is recommended. It is not a commodity, right? So it has to be approved by the medical personnel, and the idea behind that is they cannot produce egg quality one or a quantity one. And that is the reason where we go for the donor eggs and for the donor sperms. So the main guidelines which we follow is, if a woman is at the end of the reproductive age, that is round about 40-42, where they cannot produce healthy and quality sperms, then they are offered this. Or if they have a premature ovarian failure, that is if they attain menopause before the age of 40. Apart from this, if a woman is suffering from any of the health conditions, like any genetic conditions, the sexual chromosome conditions which are transferred in the family, and she won't be having any live baby, they are recommended. And also we have to remember, nowadays cancer are booming so much and the young girls are having cancers. So a cancer treatment patient or who have undergone chemotherapy, radiotherapy, they are all offered the donor eggs. And coming to the males, okay, and I want to tell you here one thing, even if a woman, a single woman can take a donor sperm and have a baby, okay. And coming to the men, it is the quality which is important. Quality, that is the quality or the quantity, it is not a concern. Only the morphology and motility of the sperm. If it is too low and if there are failed IVF cycles, then they can opt for the donor sperms. And even the males who have undergone any radiation, chemotherapy, not suitable sperms, azospermia, which is very important nowadays. But nowadays we have advanced so much that even with azospermia, we do TISA, we collect the sperms. But sometimes there is testicular condition where FSH, LH, they are resistant to the Sertoli cells, the Sertoli cell syndrome, where cannot get the sperms or a good quality, or where we will be transmitting the diseases from the X and Y chromosomes. That is, we call it as autosomal recessive, autosomal dominant conditions. Common ones in our country which we have seen is thalassemia, hemophilia, dystrophy, okay? Dystrophy, and many of the condition, neurofibromatosis, okay, and metabolic disorders. We select the sperms by doing the genetic testing for the donors and for the males, and then we choose the sperms. So they play a very vital role in formulating the family. That is giving a hope for childless couple. Isn't it great?
Yes, yes, definitely, doctor.
ಮೊದಲಿಗೆ ಫಸ್ಟ್ ನ್ಯೂಸ್ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮನ ಹಮ್ಮಿಕೊಂಡು ನನ್ನನ್ನು ಇನ್ವೈಟ್ ಮಾಡಿರ್ತಾರೆ. ಅವರಿಗೆ ಕ್ಯಾರಿ ಫರ್ಟಿಲಿಟಿ ಪ್ರೈವೇಟ್ ಲಿಮಿಟೆಡಿಂದ ಕೃತಜ್ಞತೆಗಳು. ಇದು ಒಂದು ಒಳ್ಳೆಯ ಪ್ರಯೋಗ. ಇದುವರೆಗೆ ಈ ಥರದ ಕಾರ್ಯಕ್ರಮಗಳು ನ್ಯೂಸ್ ಚಾನಲಿಂದ ಆಗಿರಲಿಲ್ಲ. ಇವತ್ತು ಫಸ್ಟ್ ನ್ಯೂಸು ಚಾನಲ್ಲು ಹಮ್ಮಿಕೊಂಡಿದೆ. ನಿಮಗೆಲ್ಲ ತಿಳಿದಿರೋ ಹಾಗೆ ಬಂಜೆತನ ಅನ್ನೋದು ಒಂದು ಸೋಷಿಯಲ್ ಸ್ಟಿಗ್ಮಾ ಅಂತ ಹೇಳ್ತೀವಿ. ಈ ಒಂದು ನಿವಾರಣೆಗೆ ಸತತವಾಗಿ 40 ವರ್ಷಗಳಿಂದ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಗಳನ್ನು ಅಸಿಸ್ಟೆಡ್ ರಿಪ್ರೊಡಕ್ಟಿವ್ ಟೆಕ್ನಾಲಜಿಯಿಂದ ಹಮ್ಮಿಕೊಂಡು ಬಂದಿದೆ. ಇದರಲ್ಲಿ ಹಲವಾರು ಪ್ರಯತ್ನಗಳನ್ನು ಮಾಡಿ ಸಂಶೋಧನೆಯನ್ನು ಮಾಡಿ ಇವತ್ತು ನಾವು ಬಂಜೆತನ ನಿವಾರಣೆಗೆ ಅತ್ಯಮೂಲ್ಯವಾದ ಕೆಲಸವನ್ನು ಮಾಡಿ ಒಳ್ಳೆ ಸಕ್ಸಸ್ ರೇಟನ್ನು ತಂದುಕೊಡ್ತಾ ಇದ್ದೀವಿ. ನಾನು ಈ ಒಂದು ಫೀಲ್ಡ್ನಲ್ಲಿ ಸುಮಾರು 30 ವರ್ಷದಿಂದ ಕೆಲಸ ಮಾಡ್ತಾ ಇದ್ದೇನೆ. ನಾನು ಭ್ರೂಣತಜ್ಞನಾಗಿ 30 ವರ್ಷದಿಂದ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಇದ್ದು, ನಾನು ಮೊದಲನೇ ದಿನದಿಂದನೂ ನಿಮಗೆ ಹೇಳಬೇಕು ಅಂತಂದರೆ ಇಷ್ಟು ಅವೇರ್ನೆಸ್ಸು ಇರ್ತಿರಲಿಲ್ಲ. ಬಂಜೆತನ ಅಂತಂದರೆ ಮದುವೆ ಆದ ಮೇಲೆ ಅವರು ಸುಮಾರು 1-2 ವರ್ಷ ಕಾಯ್ತಾಯಿದ್ರು. ತದನಂತರ ಟೆಂಪಲ್ಗೆ ಹೋಗೋದು, ಆಯುರ್ವೇದ, ಈ ಥರದ ಟ್ರೀಟ್ಮೆಂಟ್ಗಳು ನಡೀತಿದ್ವು. ಇದನ್ನೆಲ್ಲ ಆಗಿ ಅದಾದ ಮೇಲೆ ಇನ್ನೂ ನಮಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗಲಿಲ್ಲ, ನಮಗೆ ಮಗು ಬೇಕು ಅಂದಾಗ ಮಾತ್ರ ಅವರು ಈ ಇನ್ಫರ್ಟಿಲಿಟಿ ಟ್ರೀಟ್ಮೆಂಟ್ಗೆ ಸೆಂಟರ್ಗೆ ಹೋಗ್ತಾಯಿದ್ರು. ಇವತ್ತು ಆ ಥರ ಇಲ್ಲ. ಈ ನ್ಯೂಸ್ ಚಾನೆಲ್ಗಳಿಂದ ಇರೋದರಿಂದ ಅವೇರ್ನೆಸ್ಸು ತುಂಬ ಇದೆ. ನಮ್ಮ ಇನ್ಫರ್ಟಿಲಿಟಿ ಸೆಂಟರ್ಗೆ ಅಪ್ರೋಚ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಅವ್ರಿಗೆ ಬಂಜೆತನ ನಿವಾರಣೆ ಮಾಡೋದ್ರಲ್ಲಿ ಇನ್ಫರ್ಟಿಲಿಟಿ ಸೆಂಟರ್ಗಳು ಪ್ರಯತ್ನ ಮಾಡಿ ಅವ್ರಿಗೆ ಒಳ್ಳೆಯ ಸಕ್ಸಸ್ ರೇಟ್ ಕೊಡ್ತಾಯಿದ್ದಾರೆ. ಮತ್ತು ಮೇಡಮ್ನವರು ಹೇಳ್ತಾಯಿದ್ರು, 1-2-3 ಪಾಯಿಂಟನ್ನ ನಾನು ಆ್ಯಡ್ ಮಾಡಲಿ ಇಚ್ಛೆಪಡ್ತೇನೆ. ಏನೇ ಒಂದು ನಾವು ಸಂಸ್ಥೆಯಲ್ಲಿ ಕೆಲಸ ಮಾಡಬೇಕು, ಒಂದು ಗೈಡ್ಲೈನ್ಸ್ ಅಂತ ಇರ್ತದೆ, ಒಂದು ರೂಲ್ಸ್ ಆ್ಯಂಡ್ ರೆಗ್ಯುಲೇಷನ್ ಅಂತದೆ. ವೆದರ್ ಅದು ಹೆಲ್ತ್ ಸೆಕ್ಟ್ರಲ್ಲೇ ಇರ್ಬೋದು, ಯಾವುದೇ ನರ್ಸಿಂಗ್ ಹೋಮ್ನಲ್ಲಾರು ಇರ್ಬೋದು, ಹಾಸ್ಪಿಟಲ್ಲಾರಿದ್ರು. ಈ ಒಂದು ಸಂಸ್ಥೆ ಈ ಒಂದು ಇನ್ಫರ್ಟಿಲಿಟಿಗೆ ಗೈಡ್ಲೈನ್ ಅನ್ನೋದು ಇರಲಿಲ್ಲ, ರೂಲ್ಸ್ ಆ್ಯಂಡ್ ರೆಗ್ಯುಲೇಷನ್ ಅನ್ನೂ ಇರೋದಿಲ್ಲ. ಮತ್ತು ಇದು ಏನು ಅಂತಂದರೆ ಈ ಒಂದು ಟ್ರೀಟ್ಮೆಂಟು ಗೌರ್ಮೆಂಟ್ ಫೆಸಿಲಿಟಿನಲ್ಲಿ ಇರಲಿಲ್ಲ. ಈಗ ಕ್ರಮೇಣವಾಗಿ ಇದು ಗೌರ್ಮೆಂಟ್ ಫೆಸಿಲಿಟಿನಲ್ಲಿ ಬರ್ತಾ ಇದೆ. ಹಾಗಾಗಿ ಪೂರ್ ಕಪಲ್ ಆಲ್ಸೋ ಇವತ್ತು ಇನ್ಫರ್ಟಿಲಿಟಿ ಟ್ರೀಟ್ಮೆಂಟನ್ನ ತಗೋಬೋದು. ಯಾಕೆಂದರೆ ಇನ್ಫರ್ಟಿಲಿಟಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಅನ್ನೋದು ತುಂಬ ಎಕ್ಸ್ಪೆನ್ಸಿವ್ ಅಂತಂದರೆ ಅದು ಖಂಡಿತ ಕಾರ್ಪೊರೇಟ್ ಸೆಕ್ಟರ್ಗೆ ಹೋಗ್ತಾರೆ. ಏಕೆಂತಂದರೆ ಅವ್ರಿಗೆ ಒಳ್ಳೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಬೇಕಾಗ್ತದೆ. ಕೆಲವು ಟೈಮು ಸ್ಟ್ಯಾಂಡರ್ಡ್ ಸೆಂಟರ್ಗೆ ಹೋಗ್ತಾರೆ. ಈ ಥರದಲ್ಲಿ ಹೋದಾಗ ಅವ್ರಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕಾಸ್ಟು ವೇರಿ ಆಗ್ತದೆ. ಗೈಡ್ಲೈನ್ಗೆ ಬಂದಾಗ ಮೊದಲು ನಮ್ಮದು ಗೈಡ್ಲೈನ್ ಅಂತ ಇದ್ದು, ನಾನು ಕೂಡ ಅದರಲ್ಲಿ ಒಬ್ಬ ಎಕ್ಸ್ಪರ್ಟ್ ಕಮಿಟಿ ಮೆಂಬರ್ ಆಗಿದ್ದೆ. ತದನಂತರ ಇದು ಸೆಂಟ್ರಲ್ ಗೌರ್ಮೆಂಟ್ಗೆ ಹೋಗಿ ಅವರು ART ರೂಲ್ ಮತ್ತು ಸರಗಸಿ ಕಾನೂನು ಅಂತ ಮಾಡಿ 2022ರಲ್ಲಿ ಇದಾಯಿತು. ಇದಾದ ನಂತರ ಯಾವುದೇ ಸೆಂಟರ್ಗಳು IVF ಮಾಡಬೇಕು ಅಂತಂತಂದರೆ ಪರ್ಮಿಷನ್ ತೊಗೊಬೇಕಾಗುತ್ತೆ, ಲೈಸೆನ್ಸ್ ತೊಗೊಳ್ಬೇಕಾಗುತ್ತದೆ, ಅದರದ್ದೇ ಆದಂಥ ಕಾನೂನು ಇರ್ತದೆ. ಕಾನೂನನ್ನ ಪಾಲಿಸ್ಕೊಂಡು ಒಂದು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡೋದು. ಯಾಕೆಂದರೆ ಈ ಒಂದು ಸಂಸ್ಥೆಯನ್ನು ಮಾಡಬೇಕಾದ್ರೆ ಮ್ಯಾಲ್ ಪ್ರಾಕ್ಟೀಸ್ ಆಗ್ತದೆ, ಇದನ್ನು ರೆಗ್ಯುಲೇಟ್ ಮಾಡಬೇಕಾಗುತ್ತದೆ ಅಂತಂತ ಹೇಳ್ಬಿಟ್ಟು ಗೌರ್ಮೆಂಟು ಮುಂದೆ ಬಂದು ಇದನ್ನು ಮಾಡಿರುತ್ತೆ. ಯಾಕಂದರೆ ಇದನ್ನು ನಾವು ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ ಅಂತೀವಿ. ದಾನಿ ವೀರ್ಯಾಣು, ದಾನಿ ಅಂಡಾಶಯ ಅಂತಂದರೆ ಮೊಟ್ಟೆ ಒಂದು ಫೀಮೇಲ್ನಲ್ಲಿ ಇಲ್ಲ ಅಂತಂತಂದರೆ, ಅಥವಾ ವೀರ್ಯಾಣುಗಳು ಸರಿಯಾಗಿ ಪ್ರೊಡಕ್ಷನ್ ಆಗಲಿಲ್ಲ ಅಂತಂದರೆ ಮೇಲ್ನಲ್ಲಿ ಯಾವ ಥರದವಾಗಿ ನಾವು ಅದನ್ನು ಡಯಾಗ್ನೋಸ್ ಮಾಡಬೇಕು, ಯಾವ ಥರವಾಗಿ ಅದನ್ನು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಬೇಕು ಅನ್ನೋದನ್ನು ಅದು ಅತ್ಯಾಧುನಿಕ ಟ್ರೀಟ್ಮೆಂಟಿಂದ ನಾವು ಅದನ್ನು ಸಾರ್ಟ್ ಔಟ್ ಮಾಡ್ಬೋದು. ಇವತ್ತು ಏನು ಟೆಸ್ಟಿಕಲ್ ಇಂದ ಸ್ಪಮ್ನ ರಿಟ್ರೀವ್ ಮಾಡ್ಬೋದು, ಎಗ್ಗು ಅಂಡಾಶಯದಲ್ಲಿ ಇಲ್ಲ ಅಂತಂದರೂ ಅಂಡಾಶಯದಲ್ಲಿ ಎಗ್ಗು ಬರೋಗೆ ಮಾಡ್ಬೋದು. ಇದೆಲ್ಲ ಆದ್ರೂ ಕೂಡ ಮುಂದೆ ಸಂಶೋಧನೆ ಆಗುತ್ತಾ ಅದೇ ಒಂದು ಫೀಮೇಲ್ ಅದೇ ಒಂದು ಮೇಲ್ನ ಸಂಬಂಧಪಟ್ಟಂತೆ ಸ್ಪರ್ಮು ಅಂದರೆ ಏನು ವೀರ್ಯಾಣು, ಮೊಟ್ಟೆ, ಎಗ್ ಅನ್ನೋದನ್ನು ಮಾಡಬೇಕು ಅಂತ ಮಾಡೋ ಪರಿಸ್ಥಿತಿಗೆ ನಾವು ಬಂದಿದ್ದೀವಿ. ಹೀಗಾಗಿ ಅವರಿಗೆ ನಾವು ಈ ಒಂದು ಟ್ರೀಟ್ಮೆಂಟಿನ ಅತಿ ಶೀಘ್ರವಾಗಿ ಅತಿ ಕಡಿಮೆ ಖರ್ಚಿನಲ್ಲಿ ಮಾಡ್ಬೋದು ಅಂತ ನಾನು ಹೇಳಲು ಇಚ್ಛೆಪಡ್ತೇನೆ.
ಥ್ಯಾಂಕ್ ಯು ಡಾಕ್ಟರ್ ಫಾರ್ ದ ಎನ್ಲೈಟ್ಮೆಂಟ್. ಈಗ ನೀವು ಸೈಂಟಿಫಿಕ್ ಆಗಿ ಎಕ್ಸ್ಪ್ರೆಸ್ ಮಾಡೋದಾದರೆ ಹೇಗೆ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡ್ತೀರಾ ಡಾಕ್ಟರ್ ಎಗ್ ಆ್ಯಂಡ್ ಸ್ಪರ್ಮ್ ಡೋನರ್ ಬಗ್ಗೆ?
ನೋಡಿ, ಯಾವುದೇ ಒಂದು ಕಪಲು, ಬಂಜೆತನ ಇರುವಂಥ ಕಪಲು ಯಾವುದೇ ಒಂದು ಇನ್ಫರ್ಟಿಲಿಟಿ ಸೆಂಟ್ರಿಗೆ ಹೋದಾಗ ನಾವು ಬೋತ್ ಮೇಲ್ ಆ್ಯಂಡ್ ಫೀಮೇಲ್ಗೆ ಡಯಾಗ್ನೋಸ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಡಯಾಗ್ನೋಸ್ ಮಾಡಿದಾಗ ನಮಗೆ ಗೊತ್ತಾಗ್ತದೆ. ಕ್ಲಿನಿಷಿಯನ್ಸು ಅದನ್ನು ಯಾವುದೇ ಸಿಮೆನ್ ಅನಾಲಿಸಿಸ್ ರಿಪೋರ್ಟಿಂದ ಸ್ಕ್ಯಾನಿಂಗ್ ಮಾಡಿದಾಗ ಅವ್ರಿಗೆ ಗೊತ್ತಾಗ್ತದೆ ಅವರು ಎಷ್ಟು ಏಜ್ ಇದೆ, ಏನು ಹಿಸ್ಟ್ರಿ ಇದೆ, ಯಾವ ಥರವಾದ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಟ್ಟರೆ ನಾವು ಅವರಿಗೆ ಬಂಜೆತನ ನಿವಾರಣೆ ಮಾಡ್ಬೋದು ಅಂತ ಹೇಳ್ತೇವೆ. ಮೊದಲಿಗೆ ಇಂಟ್ರಾಯುಟ್ರೈನ್ಸ್ ಇನ್ಸೆಮಿನೇಷನ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಅಲ್ಲಿ ಫೀಮೇಲ್ಗೆ ಏನೂ ತೊಂದರೆ ಇಲ್ಲ, ಅವ್ರಿಗೆ ಮುಟ್ಟು ಸರಿಯಾಗ್ತಾ ಇದೆ, ಮೊಟ್ಟೆಗಳು ಸರಿಯಾಗಿ ಉತ್ಪತ್ತಿ ಆಗ್ತಾ ಇದೆ, ಓನ್ಲಿ ಮೇಲ್ ಫ್ಯಾಕ್ಟ್ರಿ ಇದೆ ಅಂತಂದರೆ ವೀರ್ಯಾಣುವಿನಲ್ಲಿ ಚಲನವಲನಗಳು ಸರಿಯಾಗಿಲ್ಲ, ಮೋಟಿಲಿಟಿ ಸರಿಯಾಗಿಲ್ಲ, ಅದರ ಕ್ವಾಂಟಿಟಿ ಸರಿಯಾಗಿಲ್ಲ ಅಂದಾಗ ಅದನ್ನು ಹೆಚ್ಚಿಗೆ ಮಾಡಿ ಈ ಒಂದು ಪ್ರೊಸೀಜರಿಂದ ಅವ್ರಿಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಹೇಗೆ ಕೊಡ್ಬೋದು ಅಂತ ಪ್ರಯತ್ನ ಒಂದು ಹಂತದಲ್ಲಿ ಮಾಡ್ತೀವಿ. 1-2 ಸೈಕಲು ಈ ಥರ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಿದಾಗ ಅವ್ರಿಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗಿಲ್ಲ ಅಂದ ಮಾತ್ರಕ್ಕೆ ಪ್ರಣಾಳ ಶಿಶು ಅಂತ ಹೇಳ್ತೀವಿ ನಾವು, IVF ಅಂತ ಹೇಳ್ಬಿಟ್ಟು. ಈ ಒಂದು ಪ್ರೊಸೀಜರ್ನಲ್ಲಿ ಯಾಕಂದರೆ ಒಂದು ಋತುವಿನಲ್ಲಿ ಒಂದು ಫೀಮೇಲು ಒಂದೇ ಎಗ್ಗನ್ನ ರಿಲೀಸ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಮಾಡೋದು ನಾವು ಈ ಒಂದು ಪ್ರಣಾಳ ಶಿಶು ಪ್ರೊಸೀಜರ್ ಮಾಡಬೇಕಾದ್ರೆ ಅವ್ರಿಗೆ ಹಾರ್ಮೋನ್ನ ಕೊಟ್ಟು ಅತಿ ಹೆಚ್ಚು ಮೊಟ್ಟೆಗಳನ್ನು ಬರೋಂಗೆ ಮಾಡ್ತೀವಿ. ಯಾಕಂದರೆ ಈಗ ನಮ್ಮ ಗೈಡ್ಲೈನ್ನಲ್ಲಿ 7 ಎಗ್ಗು ಮಾತ್ರ ರಿಟ್ರೀವ್ ಮಾಡಬೇಕು ಅಂತ ಇದೆ. ಹಾಗಾಗಿ ಯಾಕೆಂತಂದರೆ ನಾವು ಏನೇ ಒಂದು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಬೇಕಾದ್ರೆ ಆ ಫೀಮೇಲ್ನ ಆರೋಗ್ಯ ತುಂಬ ಇಂಪಾರ್ಟೆಂಟ್ ಇರ್ತದೆ. ಹಾಗಾಗಿ ಅವರು ಹೈಪರ್ ಸ್ಟಿಮ್ಯುಲೇಷನ್ಗೆ ಹೋಗಬಾರ್ದು ಅಂತೇಳಿ ಅತಿ ಮೈಲ್ಡ್ ಸ್ಟಿಮ್ಯುಲೇಷನ್ ಮಾಡಿ ಅವರಿಗೆ, ಯಾಕಂದರೆ ಈ ಹಾರ್ಮೋನ್ ಕೊಡೋದ್ರಿಂದ ಅವ್ರಿಗೆ ಆರೋಗ್ಯಕ್ಕೆ ತೊಂದರೆ ಇರುತ್ತೆ ಅಂತಲೂ ರಿಪೋರ್ಟ್ಸ್ಗಳು ಇರೋದ್ರಿಂದ ಪದೇ ಪದೇ ಕೊಡೋದ್ರಿಂದ ನಾವು ಅವ್ರಿಗೆ ಮೈಲ್ಡ್ ಸ್ಟಿಮ್ಯುಲೇಷನ್ ಮಾಡಿ 7 ಎಗ್ಗು ಬರೋಂಗೆ ಅಥವಾ ಬಂದರೂ ಪರವಾಗಿಲ್ಲ 1-2-3 ಹೆಚ್ಚು ಆ ಒಂದು ಮೊಟ್ಟೆಗಳನ್ನು ನಾವು ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಇಲ್ಲಿ ಭ್ರೂಣತಜ್ಞ ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟು ಈ ಒಂದು ART ಸೆಂಟ್ರಿಗೆ ಬ್ಯಾಕ್ ಬೋನ್ ಆಗಿ ಕೆಲಸ ಮಾಡ್ತಾರೆ. ಈ ಭ್ರೂಣ ತಜ್ಞ ಅಂತ ಏನು ಮಾಡ್ತೀವಿ ಅಂತಂತಂದರೆ ಮೊಟ್ಟೆ ಮತ್ತು ಸ್ಪರ್ಮ್ನು ಎರಡನ್ನೂ ಒಂದು ಇನ್ಕ್ಯುಬೇಟ್ರ್ ಅಂತ ಇರ್ತದೆ. ಅದು ಆ ಇನ್ಕ್ಯುಬೇಟ್ರು ಒಂದು ಫೀಮೇಲ್ನ ಯುಟ್ರಸ್ಗೆ ಕಂಪೇರ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಆ ಥರದ ಎನ್ವಿರಾನ್ಮೆಂಟ್ನ ಕ್ರಿಯೇಟ್ ಮಾಡಿ ಅಲ್ಲಿ ಒಂದು ಭ್ರೂಣ ಉತ್ಪತ್ತಿ ಮಾಡಿ ಭ್ರೂಣ ತಜ್ಞ ಅದನ್ನು 5 ದಿವಸದವರೆಗೂ ಕಾಪಾಡ್ಕೊಂಡು ಬರ್ತಾನೆ. ಇದನ್ನು ಮಾಡಬೇಕಾದ್ರೆ ತುಂಬ ಕ್ವಾಲಿಟಿ ಕಂಟ್ರೋಲ್ ಅಂತ ಇರ್ತದೆ. ಎಕ್ವಿಪ್ಮೆಂಟು ಏನು ಯೂಸ್ ಮಾಡ್ತೀವಿ, ಅಲ್ಲಿ ಏರ್ ಕ್ವಾಲಿಟಿ ಹೇಗಿರ್ತದೆ, ಪ್ರತಿ ದಿವಸ ನಾವು ಅದು ಹೇಗೆ ಮಾನಿಟರ್ ಮಾಡ್ತಾಯಿದ್ದೀವಿ, ಅದನ್ನು ಡಿಸ್ಟರ್ಬ್ ಮಾಡ್ಬೋದು. ಆದ್ದರಿಂದ ನಮಗೆ ಯಾವ ಥರದ ಭ್ರೂಣ ಬರುತ್ತೆ ಅಂತ ಗೊತ್ತಾಗುತ್ತೆ. ಖಂಡಿತವಾಗಿ ಒಳ್ಳೆ ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟು, ಒಳ್ಳೆ ಕ್ವಾಲಿಟಿ, ಒಳ್ಳೆ ಟೀಮ್ ಇದ್ದಾಗೆ ಒಳ್ಳೆ ಭ್ರೂಣ ಉತ್ಪತ್ತಿ ಆಗುತ್ತೆ. ಆ ಭ್ರೂಣನ ನಾವು ಇನ್ಫರ್ಟಿಲಿಟಿ ಫೀಮೇಲ್ಗೆ ಟ್ರಾನ್ಸ್ಫರ್ ಮಾಡಿದಾಗ ಪ್ರಿಪೇರ್ ಮಾಡಿ ಅವ್ರದ್ದು ಎಂಡೋಮೆಟ್ರಿಯಮ್ಮು ಖಂಡಿತವಾಗಿ ನಮಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಬರೋ ಚಾನ್ಸಸ್ ಇರುತ್ತೆ.
ಓಕೆ ಡಾಕ್ಟರ್ ಭಾರತಿ, ಈಗ ಈ ಎಗ್ ಇವ್ರಿಗೆ ಸೂಟ್ ಆಗುತ್ತೆ, ಈ ಸ್ಪರ್ಮ್ ಇವ್ರಿಗೆ ಸೂಟ್ ಆಗುತ್ತೆ ಅಂತ ಹೇಗೆ ನೀವು ಸ್ಕ್ರೀನ್ ಮಾಡ್ತೀರಾ ಕ್ಯಾಂಡಿಡೇಟ್ಸ್ ಬಂದಾಗ?
See, we first before anything, okay, when the patient walks in, ask for the donor, they will be having priorities. They have to express their choices. So we keep in consideration those choices. Okay? So when we are selecting a donor, we keep certain criteria which gives a success for them. That is, the first and foremost is the age. As age advances, the fertility decreases. So the ICMR guidelines has given that when we select a woman, she should be around about 25 to 35 years of age, because they have a healthy egg and good genetic baby will be formed. Okay? To make it sure that this is so, what we do is, we personally, have a dialogue with the patient. So when we have a dialogue, we extract their history from them. Okay? The first consideration as soon as anyone walks in is the age. Okay? The next we see their BMI. That is the weight and the height, because even the obesity reduces the fertility, because it acts like an inflammation tissue. So keeping the age and this, and we take the physical characteristics of the woman. What are the physical characteristics? That is a woman. So the recipients who are taking the eggs, really they will be in despair to know if the baby is born, will it be resembling me? Will it have the ears like me? Or will it have the eyes like me? And will it be intellectual? There won't be any problem. So all this we keep in the mind before we selecting a donor egg or the donor sperm. So when we extract the history of the family, we exclude the family history. And if the donors have got particularly genetic diseases, because if they are carriers, we offer them genetic testing too. Apart from this, we take the blood group which is into consideration. The eye, the weight, the color, the hair, the blood group are the prominent. And usually we counsel the patient when we take the donor or the sperm. See, no two brothers are alike and no two sisters are alike. Isn't it? Little bit mismatch should be there, but
twins are only not
resembling you. Yes. Nimtara holutte adu, adre exact agi holodilla. But blood group na avadu select martivi. Apart from this, the donors ki navu vigorous agi ella test gulu martivi. Like there is a for us there is a pre-testing scheme, that is the medical screening we call. ಅವ್ರಿಗೆ ಏನು ಕ್ಲಿನಿಕಲ್ ಆಗಿ ಏನು ಕಾಯಿಲೆ ಇಲ್ವಾ ಅಂತ ನಾವು ನೋಡಿ ರೆಸ್ಪಿರೇಟರಿ ಸಿಸ್ಟಮ್, ಕಾರ್ಡಿಯಾಕ್ ಸಿಸ್ಟಮ್ ಇವೆಲ್ಲ ನೋಡ್ಕೊಳ್ತೀವಿ. ಏನು ತೊಂದರೆ ಇಲ್ಲ ಅಂತಾದಾದ್ಮೇಲೆ ವಿ ಪ್ರೊಜೆಕ್ಟ್ ದೆಮ್ ಫಾರ್ ಆಲ್ ದ ಬಯೋಕೆಮಿಕಲ್ ಟೆಸ್ಟ್. ಅವ್ರ ರಿಪ್ರೊಡಕ್ಟಿವ್ ಕ್ಯಾರೆಕ್ಟರ್ ಹೆಂಗಿದೆ, ಎಲ್ಲ ಚೆನ್ನಾಗಿದೆಯಾ ಅದೆಲ್ಲ ತಿಳ್ಕೊಂಡು ದೆನ್ ಓನ್ಲಿ ವಿ ರಿಕ್ರೂಟ್ ದೆಮ್ ಟು ದಿ ಡೋನರ್ ಸೈಕಲ್ ಪ್ರೋಗ್ರಾಮ್. ಇವಾಗ ಸ್ಪರ್ಮ್ಸ್ಗೆ ಹೋದರೆ ಸ್ಪರ್ಮ್ಸ್ಗೂ ನಾವು ಅದೇ ಥರ ನಾವು ನೋಡೋದು. ಓಕೆ, ದಿ ಹೈಟು, ದಿ ವೆಯ್ಟು, ದಿ ಕಲರು, ದಿ ಕಾರ್ನಿಯಾ, ದಿ ಬ್ಲಡ್ ಗ್ರೂಪ್ ಇದನ್ನೆಲ್ಲ ಸೆಲೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ಆಮೇಲೆ ದಿಸ್ ಸ್ಪರ್ಮ್ಸ್ ಯೂಶಲಿ ವಿ ಟೇಕ್ ಇಟ್ ಫ್ರಮ್ ದಿ sperm bank, and for the oocytes there are two. For the eggs we can go for the oocyte bank or we can go for the fresh collection. Fresh collection gives more success than that of the oocyte freezing. Yake andre namge particular we will be seeing them virtually than that. Okay, so all the patient ಇದರಲ್ಲಿ ನಮಗೆ ಸ್ವಲ್ಪ ತೊಂದರೆ ಆಗುತ್ತೆ. ಸ್ವಲ್ಪ ಜನ ಪೇಷಂಟ್ ದಾನಿಗಳು ನಮಗೆ ಏನಪ್ಪ ಈ ರಿಲಿಜನ್ ಅವ್ರು ಬೇಕು, ವೆಜಿಟೇರಿಯನ್ ಫುಡ್ ಅವ್ರು ಬೇಕು, ಈ ಥರ ಇರಬೇಕು, ಎಜುಕೇಷನ್ ಸ್ಟೇಟಸ್ ಈ ಥರ ಇರಬೇಕು, ಆ ಥರ ಎಲ್ಲ ಇರುವಾಗ ಅವನ್ನೆಲ್ಲ ಗಮನದಲ್ಲಿ ಇಟ್ಕೊಂಡು ಫಸ್ಟ್ ನಾವು ಅವ್ರ ಕಾನ್ಫಿಡೆನ್ಸ್ ತಗೊಳ್ತೀವಿ. ಓಕೆ, ದೆನ್ ವಿ ವಿಲ್ ಹ್ಯಾವ್ ಎ ಡೈಲಾಗ್ ಅವ್ರ ಹತ್ರ ಎಲ್ಲ ಪ್ರೊಫಾರ್ಮ ಚೆನ್ನಾಗಾದಾಗ ದೆನ್ ವಿ ವಿಲ್ ಪೋಸ್ಟ್ ದೆಮ್. ಆದರೆ ಏನಾದರೂ ಸ್ವಲ್ಪ ತೊಂದರೆ ಇತ್ತು ಅಂದ್ರೂ ವಿ ವಿಲ್ ಬಿ ಕ್ಯಾನ್ಸಲಿಂಗ್ ದೆಮ್. Okay, and that trust we should have with our clients. So idರಲ್ಲಿ main doctor who is involved is the team is led by the doctor. It is a multidisciplinary approach. ಅಂತಂದ್ರೆ embryologists, supportive group, ಅವರೆಲ್ಲ they stand behind us. So if anything happens, yes, the doctor is in forefront who will answer their questions. So we have to take personal care first to have a trust, and then to build up the further conversation. So expertise management is very much important.
ಕಿಡೋನರ್ ಸಿನಿಮಾ ನೋಡಿದ್ರೆ ಅರ್ಥ ಆಗ್ಬಿಡುತ್ತೆ ಅನ್ಸುತ್ತೆ.
ಎಕ್ಸಾಕ್ಟ್ಲಿ.
ನಾನು ಒಂದು ಎರಡು ಈಗ ICMR ಗೈಡ್ಲೈನ್ ಅನ್ನೋದು ಇಟ್ ಈಸ್ ನಾಟ್ ಇನ್ ಅ ಪಿಕ್ಚರ್ ಮೇಡಮ್. ನಾವು ಇಟ್ ಈಸ್ ಎ ರೂಲ್. Assisted reproductive technology and surrogacy, it is in a rule. It has been passed. ICMR was in a guideline. Now we are bound to follow the rule. If we don't ನಾವು ಈ ರೂಲನ್ನು ಫಾಲೋ ಮಾಡಲಿಲ್ಲ ಅಂತಂದರೆ ಅದರಲ್ಲೇ ನಮಗೆ ಏನು ಒಂದು ಸೆಂಟ್ರಲ್ಲಿ ಯಾರು ಇನ್ವಾಲ್ವ್ ಆಗಿರ್ತಾರೆ, ಯಾರು ಮಾಡ್ತಾರೆ, ಅವ್ರಿಗೆ ಇಷ್ಟು ಪೆನಾಲ್ಟಿ ಅಂತಂತ ಇರುತ್ತದೆ. ಮತ್ತು ಗೈಡ್ಲೈನ್ ಇಸ್ ಟು ಫಾಲೋ ಇಟ್, ರೂಲ್ ಇಟ್ ಹ್ಯಾಸ್ ಟು ಬಿ ಫಾಲೋಡ್. ರೂಲ್ನ ನಾವು ಫಾಲೋ ಮಾಡಲಿಲ್ಲ ಅಂದರೆ ವಿ ವಿಲ್ ಬಿ ಪೀನಲೈಸ್ಡ್. ಬಟ್ ಇದು ಡೋನರ್ ಎಗ್ಗು ಡೋನರ್ ಸ್ಪರ್ಮ್ಗೆ ಬಂದಾಗ ಮೊದಲು ಇದು ತುಂಬ ಸರಳವಾಗಿ ಆಗ್ತಾಯಿತ್ತು. ಯಾಕೆಂದರೆ ಕ್ಲಿನಿಷಿಯನ್ನೇ ಆಗಲಿ, ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟೇ ಆಗಲಿ, ಇದರಲ್ಲಿ ಜಾಸ್ತಿ ಎಡೆಕು ಇರಲಿಲ್ಲ. ಬಟ್ ಈಗ ರೂಲ್ಸ್ ಬಂದಾದ ಮೇಲೆ ನೀವು ಒಂದು ಡೋನರ್ನ ಸೆಲೆಕ್ಟ್ ಮಾಡಬೇಕಾದ್ರೆ ಅವರು ಕನ್ಸೆಂಟ್ ಕೊಡಬೇಕಾಗ್ತದೆ. ಇದನ್ನು ನಾವು ಕಮರ್ಷಿಯಲೈಸ್ ಮಾಡೋಂಗಿಲ್ಲ. ಈಗ ಒಂದು ಡೋನರ್, ಫೀಮೇಲ್ ಡೋನರ್, ಅವರು ಫೈರ್ ಆಗಿದ್ದಾರೆ, ಅವರು ಚೆನ್ನಾಗಿದ್ದಾರೆ, ನನಗೆ ಇದೇ ಡೋನರ್ ಬೇಕು, ನಾನು ಎಷ್ಟು ಬೇಕಾದ್ರೂ ದುಡ್ಡು ಕೊಡ್ತೀನಿ, ಈ ಥರದ್ದು ಇಲ್ಲ. ಯಾಕೆಂದರೆ ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ ಅನ್ನೋದೇ ಇದಕ್ಕೆ ನಾನು ಹೇಳೋದು. ಯಾಕೆಂತಂದರೆ ನೀವು ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ ಯೂಸ್ ಮಾಡಬೇಕಾದ್ರೆ ಅದು ವಾಲಂಟಿಯರ್ಸ್. ಬಟ್ ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ನಮ್ಮ ಇಂಡಿಯನ್ ಸಿನಿಯಾರಿಯೋದಲ್ಲಿ ಇದು ಆಗೋದಿಲ್ಲ. ಯಾರೇ ಮುಂದೆ ಬಂದರೂ ಅವ್ರಿಗೆ ಮಾನಿಟ್ರಿ ವೈಸು ಸ್ವಲ್ಪ ಕಾಂಪನ್ಸೇಟ್ ಮಾಡಬೇಕಾಗ್ತಾಯಿದೆ. ನಾನು ಕೂಡ ಒಂದು ART ಬ್ಯಾಂಕ್ ಅನ್ನೋದನ್ನು ರನ್ ಮಾಡ್ತಾಯಿದ್ದೀನಿ. ಇಲ್ಲಿ ವಾಲಂಟಿಯರ್ಸ್ ಆಗಿ ಸಿಮೆಂಟ್ ಡೋನರ್ಸ್ ಬರ್ತಾರೆ, ಆಮೇಲೆ ಫಿಮೇಲ್ ಡೋನರ್ ಊಸೈಟ್ ಮಾಡೋರು ಬರ್ತಾರೆ. ಅವ್ರಿಗೆ ನಾವು ಮೊದಲಾಗಿ ಸ್ಕ್ರೀನಿಂಗ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಸೆಕ್ಷುಲಿ ಟ್ರಾನ್ಸ್ಫರ್ ಡಿಸೀಸ್ ಇದೆಲ್ಲ ಇದೆಯಾ ಅಂತ ಫ್ಯಾಮಿಲಿ ಪಿಡಿಗ್ರಿ ಮಾಡಬೇಕಾಗ್ತದೆ. ಯಾವುದು ಬ್ಲಡ್ ಗ್ರೂಪು, ಕಂಪ್ಲೆಕ್ಷನ್ ಏನು, ಏರ್ ಕಲರು, ಐ ಕಲರು, ದೀಸ್ ಆರ್ ದ ಮೇಜರ್ ಪ್ರೊಫೈಲನ್ನು ನಾವು ಸೆಲೆಕ್ಟ್ ಮಾಡಬೇಕಾಗುತ್ತೆ. ಇದನ್ನು ಮಾತ್ರ ಮ್ಯಾಚ್ ಮಾಡೋಕ್ಕೆ ಆಗೋದು. ಯಾಕೆಂತಂದರೆ ನಮ್ಮಲ್ಲಿ ಈ ಥರದ ವಾಲಂಟಿಯರ್ಸು ತುಂಬ ಕಡಿಮೆ. ಮಾನಿಟ್ರಿ ವೈಸು ಡಿಮ್ಯಾಂಡ್ ಮಾಡಿದಾಗ ಮಾತ್ರ ಈ ಥರ ಡೋನರ್ಸ್ ಬರ್ತಾರೆ ಹೊರತು ವಾಲಂಟ್ರಿಗೆ ಬಂದು ನಾನು ಐ ವಿಲ್ ಬಿ ಏಬಲ್ ಟು ಡೊನೇಟ್. ನಿಮಗೆ ಗೊತ್ತಿರಬೇಕು, ಒಂದು ಎರಡು ಸೆಲೆಬ್ರಿಟೀಸು, ಬಾಲಿವುಡ್ ಸೆಲೆಬ್ರಿಟೀಸ್, ದೇ ಐ ವಾಂಟ್ ಟು ಗೋ ಆನ್ ಸೊರೊಗೇಸಿಸ್ ಬಿಕಾಸ್ ದೇ ಡಸಂಟ್ ವಾಂಟ್ ಟು ಬೇರ್ ದ ಚೈಲ್ಡ್. ದಿಸ್ ಈಸ್ ಬಿಫೋರ್ ದ ಆ್ಯಕ್ಟ್ ಹ್ಯಾಸ್ ಕಮ್ ಇನ್ ಟು ದ ಪಿಕ್ಚರ್. ಇದನ್ನು ನಾವು ಕಮರ್ಷಿಯಲೈಸ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ, ಫೀಮೇಲ್ನ ಅಬ್ಯೂಸ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ ಅಂತ ಆದಾಗ ಮಾತ್ರ ಇದು ಬಂತು. ಈಗ ಒಂದು ಸೊರೊಗೇಸಿ ಮಾಡಬೇಕು ಅಂದರೆ ಸುಮಾರು ಸ್ಟೆಪ್ಸ್ಗಳಿದೆ. ಅವ್ರಿಗೆ
ರೂಲ್ಸ್ ಏನಿದೆ ಸ್ವಲ್ಪ ಕ್ರಿಸ್ಪ್ ಆಗಿ,
ಅವ್ರಿಗೆ ಮೊದಲು ಸರ್ಟಿಫಿಕೇಷನ್ ಆಗಬೇಕಾಗ್ತದೆ. ಈಗ ಯಾವುದಾದ್ರೂ ಒಂದು ಫೀಮೇಲನ್ನ ನಾನು ಐಡೆಂಟಿಫೈ ಮಾಡಿದೆ ಅಂತಂದರೆ ರಿಸಿಪಿಯೆಂಟ್ ಕಪಲ್ಗೆ, ಗಾರ್ಡಿಯನ್ ಕಪಲ್ಗೆ ಅವರು ಮೊದಲು ಐ ವಿಲ್ ಟೆಲ್ ಯು ಮೈ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್. ಐ ಹ್ಯಾವ್ ಟು ಸೆಂಡ್ ಟು KC ಜನರಲ್ ಹಾಸ್ಪಿಟಲ್. ಅಲ್ಲಿ ಗೌರ್ಮೆಂಟ್ ಗೈನೆಕ್ಸ್ ನೋಡ್ತಾರೆ, ಸೈಕಾಲಜಿ ಬೇರೆ ಬೇರೆ ಡಿಪಾರ್ಟ್ಮೆಂಟಲ್ಲಿ ಅವರು ಹೋಗಬೇಕಾಗುತ್ತದೆ. ಅವರು ಸೂಟಬಲ್ಲ, ಕಮರ್ಷಿಯಲ್ ಆಗಿ ಮಾಡ್ತಾ ಇದ್ದಾರಾ, ಯಾವುದು ಮಾನಿಟ್ರಿ ವೈಸ್ ಮಾಡ್ತಾ ಇದ್ದಾರಾ, ಇದನ್ನೆಲ್ಲ ಮಾಡ್ತಾರೆ. ತದನಂತರ ಅವರು ಕೋರ್ಟ್ಗೆ ಹೋಗಬೇಕಾಗ್ತದೆ. ರಿಸಿಪಿಯೆಂಟ್ ಕಪಲು ಕೋರ್ಟ್ಗೆ ಹೋಗಬೇಕಾಗ್ತದೆ, ಅಫಿಡೇವಿಟ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಕೋರ್ಟ್ನಲ್ಲಿ ಮ್ಯಾಜಿಸ್ಟ್ರೇಟರು ಓಕೆ ಈ ಕಪಲ್ಗೆ ನೀವು ಸೊರೊಗೇಟಿ ಮಾಡ್ಬೋದು. ಅದಾದ ನಂತರದ ಆರೋಗ್ಯ ಭವನಕ್ಕೆ ಹೋಗಬೇಕಾಗ್ತದೆ. ಅಲ್ಲಿ ಇದಕ್ಕೆ ಸಂಬಂಧಪಟ್ಟಂತೆ ಒಬ್ಬರು ಚೇರ್ಮನ್ ಅಂತ ಇರ್ತಾರೆ, ಮೇಯ್ನಾಗಿ ಕಮಿಷನರು. ಅವ್ರ ಕಡೆಯಿಂದ ಸರ್ಟಿಫಿಕೇಟ್ ಬಂದರೆ ಮಾತ್ರ ಆಗ ಆ ಸರ್ಟಿಫಿಕೇಟ್ಗೆ 2 ವರ್ಷಗಳ ಕಾಲ ಇರ್ತದೆ. ಆ 2 ವರ್ಷ ಕಾಲದಲ್ಲಿ ಅವರು ಈ ಸೊರೊಗೇಸಿಗೆ ಹೋಗ್ಬೋದು. ಏನಕ್ಕೆಂದರೆ ನಾನು ಅಲ್ಲಿ ಒಬ್ಬ ಎಕ್ಸ್ಪರ್ಟ್ ಕಮಿಟಿ ಆಗಿ ಮೆಂಬರ್ ಆಗಿದ್ದೀನಿ. ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಇದ್ದಾರೆ, ಹೆಲ್ತ್ ಮಿನಿಸ್ಟ್ರು. ಅದ ನಂತರ PCPNDT ಆ್ಯಕ್ಟ್ರು ಡಾಕ್ಟರ್ ವಿವೇಕ್ ದೊರೆ ಅವರು ಬಂದಿದ್ದರು. ಆಮೇಲೆ ಇದು ಒಂದು ನ್ಯಾಷನಲ್ ಬೋರ್ಡ್ ಆದ ನಂತರ ಸ್ಟೇಟ್ ಬೋರ್ಡು ಈಗ ನಾವು ಒಂದು ಸಾಫ್ಟ್ವೇರ್ ಅಂತ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಯಾವುದೇ IVF ಸೆಂಟ್ರಲ್ಲಿ ಏನೇ ಪ್ರೋಗ್ರಾಮ್ ಮಾಡಿದ್ರು 1 ವೀಕ್ ಆದಮೇಲೆ ಅವರು ಎಂಟ್ರಿ ಮಾಡಬೇಕಾಗ್ತದೆ, ಸ್ಕ್ರೂಟಿನಿಗಳಾಗ್ತದೆ, ಮ್ಯಾಲ್ ಪ್ರಾಕ್ಟೀಸ್ ಆಗಬಾರ್ದು ಅಂತ. ಸೊ ಹೀಗಾಗಿ ನವೆಡೇಸ್ ಇಟ್ ಈಸ್ ಬಿಕಮಿಂಗ್ ವೆರಿ ಟೀಡಿಯಸ್ ಫಾರ್ ಕ್ಯಾರಿಂಗ್ ಔಟ್ ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್.
ಆದರೆ ಈಗಲೂ ಅಷ್ಟೇ, ನನ್ನ ಹತ್ರನೂ ಅಷ್ಟೇ ಎಷ್ಟೋ ಜನ ಈಗ ಬರ್ತಾರೆ. ದೇರ್ ಆರ್ 2 ಟೈಪ್ ಆಫ್ ಅಪ್ರೋಚಸ್, ಆಲೋಯಿಸ್ಟಿಕ್ ಅಪ್ರೋಚ್ ಆ್ಯಂಡ್ ಕಮರ್ಷಿಯಲ್ ಅಪ್ರೋಚ್. ಹೇಳ್ತಾರೆ ನಮ್ಮ ಅಕ್ಕ, ನಮ್ಮ ತಂಗಿ, ನಮ್ಮ ಕಸಿನ್ ಸಿಸ್ಟರು ನಮಗೆ ದುಡ್ಡು ಆಗೋದಿಲ್ಲ, ಸೊ ಅವ್ರನ್ನ ನಾವು ಮಾಡ್ಬೋದಾ ಅಂತ. ಎಸ್, ನಾವು ಈಗ ಸ್ವಲ್ಪ ರೂಲ್ಸ್ ಸ್ವಲ್ಪ ವೇವ್ ಆಗಿರೋದ್ರಿಂದ ವಿ ಕ್ಯಾನ್ ಟೇಕ್ ದಾನಿಗಳು ಫ್ರಮ್ ಅವರ್ ರಿಲೇಟಿವ್ಸ್, ಬಟ್ ನಾಟ್ ಫ್ರಮ್ ಪೇರೆಂಟ್ಸ್ ಆರ್ ಎನಿಥಿಂಗ್. ಇಟ್ ಶುಡ್ ಬಿ ಕಸಿನ್ಸ್, ಸಿಸ್ಟರ್ಸ್ ಆರ್ ಫ್ರಮ್ ದಿ ರಿಲೇಟಿವ್ಸ್ ಹೂಮ್ ದೇ ನೋ. ಆವಾಗ ಅವ್ರಿಗೆ ಸ್ವಲ್ಪ ಫೈನಾನ್ಷಿಯಲ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ಗೆ ತುಂಬ ಈಸಿ ಆಗುತ್ತೆ. ಓಕೆ, ಸೊ ಅದೊಂದು ಸ್ವಲ್ಪ ರೂಲ್ ಸ್ವಲ್ಪ ವ್ಯತ್ಯಾಸ ಆಗ್ತಾ ಇದೆ. ಸೊರೊಗೇಸಿನೂ ಅಷ್ಟೇ ಅವ್ರ ಕಡೆಯಿಂದ ಕರ್ಕೊಂಬಂದು ಅವ್ರು ಮಾಡ್ಬೋದು ಈಗ. ಸೊ ಆದರೆ ಲಿಗ್ಯಾಲಿಟೀಸ್ ಎಲ್ಲ ಇದೆ, ವಿ ಹ್ಯಾವ್ ಟು ಗೋ ಥ್ರೂ ದ ಲಿಗ್ಯಾಲಿಟೀಸ್. ಇದಕ್ಕೆ ಕಮಿಷನಿಂಗ್ ಏಜೆಂಟ್ಸು ಇದ್ದಾರೆ, ಬಟ್ ಕಮಿಷನಿಂಗ್ ಏಜೆಂಟ್ ವಿಲ್ ಬಿ ಮೋರ್ ಎಕ್ಸ್ಪೆನ್ಸಿವ್. ಆವಾಗ ಅವರೇ ಹೋಗಿ ಅಫಿಡವಿಟ್ ಮಾಡಿಸಿ ಡಾಕ್ಟರ್ ಹೇಳ್ದಂಗೆ, ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ ಹೇಳ್ದಂಗೆ ಮಾಡ್ಬೋದು. ಓಕೆ, ಸೊ ಇಟ್ ವಿಲ್ ಬಿ ಯೂಸ್ಫುಲ್ ಪ್ಲ್ಯಾಟ್ಫಾರ್ಮ್ ಸೊ ದಟ್ ಯಾರಿಗೆ ಆಗಲ್ಲ, ಯಾವ ಯಂಗ್ಸರಿಗೆ ಫಿಸಿಕಲಿ ಫಿಸಿಕಲಿ ಹ್ಯಾಂಡಿಕ್ಯಾಪ್ ಇರ್ತಾರೆ, ಅಥವಾ ಕಾರ್ಡಿಯಾಕ್ ಡಿಸೀಸಸ್, ಮೆಡಿಕಲ್ ಡಿಸೀಸಸ್, ಅಥವಾ ಅವ್ರಿಗೆ ಮಗು ಆಗಲ್ಲ ಅಂತ ಇರುತ್ತೋ ಅವರು ಸೊರುಗೇಟೋರ್ನ ತಗೊಳ್ಬೋದು.
ಈಗ ಒಂದೇ ಒಂದು ಟರ್ಮ್ನ ಆ್ಯಡ್ ಮಾಡಿದ್ದಾರೆ ಮೇಡಮ್ ಹೇಳ್ದಂಗೆ, ಅಲ್ಟ್ರುಸ್ಟಿಕ್ ಅಂತ. ಅಲ್ಟ್ರುಸ್ಟಿಕ್ ಅಂತಂದರೆ ಇಟ್ ಈಸ್ ವೆರಿ ಕಾಮನ್. ಯಾರು ಮುಂದೆ ಬರ್ತಾರೆ ವಾಲಂಟರಿಯಾಗಿ ಹೆಲ್ಪ್ ಮಾಡೋದಂತ. ಇಟ್ ಮೇ ನಾಟ್ ಬಿ ಓನ್ ಫ್ಯಾಮಿಲಿ, ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಅದರ್ ಫ್ಯಾಮಿಲಿ ಆಲ್ಸೋ. ಅದಕ್ಕೋಸ್ಕರ ನಾವು ಯಾವಾಗಾದ್ರೂ ಕಾನೂನು ಮಾಡಬೇಕಾದ್ರೆ ನಮ್ಮ ಈ ಜಿಯೋಗ್ರಫಿಕಲ್ ಇದರಲ್ಲಿ ಯಾವ ಥರ ಪಾಪ್ಯುಲೇಷನ್ ಇದೆ, ಅವ್ರದ್ದೆಲ್ಲ ಲೈಫ್ ಸ್ಟೈಲ್ ಹೇಗಿದೆ, ಹೇಗೆ ಯುಟಿಲೈಸ್ ಆಗುತ್ತೆ, ಆ ಥರ ಮಾಡಬೇಕಾಗ್ತದೆ. ನಮ್ಮ ಇಂಡಿಯನ್ ಸಿನಾರಿಯೋ ಇಫ್ ಯು ಟೇಕ್ ಇನ್ ಎ ನಾರ್ತ್, ಸೌತ್, ವೆಸ್ಟ್, ಲೈಫ್ ಸ್ಟೈಲ್, ಜಿಯೋಗ್ರಫಿಕಲ್ ಡಿಫ್ರೆನ್ಸ್, ಎವ್ರಿಥಿಂಗ್ ಈಸ್ ಡಿಫ್ರೆನ್ಸ್. ನಾವು ಅದನ್ನು ಮಾಡಬೇಕು. ಈಗ ಅದಕ್ಕೋಸ್ಕರ ಅಲ್ಟ್ರಿಸ್ಟಿಕ್ ಅಂತ ಆದಾಗ ನಾವು ನಮ್ಮ ಫ್ಯಾಮಿಲಿಲೇ ಯಾರು ಬಂದರೆ ಇಟ್ಸ್ ಓಕೆ, ಇಲ್ಲ ಅಂತಂದರೆ ದೋಸ್ ಹು ಕಮ್ ಇನ್ ಫೇವರ್ ಆಫ್ ಹೆಲ್ಪಿಂಗ್ ಔಟ್ infertile couple, that is accepted.
Actually many of them are not aware of these rules.
ಇದಕ್ಕೊಂದು ತುಂಬಾ ಇಂಪಾರ್ಟೆಂಟ್ ಇದೆ. ಯಾಕೆ ಅಂತಂದರೆ ಡೋನರ್ ಸ್ಪರ್ಮ್ಸು, ಡೋನರ್ ಎಗ್ಸ್ಗೆ. ಯಾಕೆ ಅಂದರೆ ಲೆಜಿಮಿಟ್ ಏನಪ್ಪ ಆ ಮಕ್ಕಳು ವಾರಸ್ದಾರಾಗ್ತಾರೆ ಆರ್ತಿಗೆ. ನಾನೊಂದು ಎಕ್ಸಾಂಪಲ್ ಹೇಳ್ತೀನಿ. ನಾನು ಒಂದಲ್ಲೇ ಹಾಸ್ಪಿಟ್ಲಲ್ಲಿ ನನ್ನ ಕೆಲಸ, ಆ ಹಾಸ್ಪಿಟಲ್ ನೇಮ್ ಎಲ್ಲ ಹೇಳೋದಿಲ್ಲ. ಓಕೆ, ಈ ಮೆಟ್ ವಿತ್ ಆಕ್ಸಿಡೆಂಟ್ ಆದಾಗ ಓಕೆ ಈ ವಾಸ್ ಬ್ರೈನ್ ಡೆತ್ ಆಗಿತ್ತು. ಸೊ ಹಾಸ್ಪಿಟ್ಲಿಂದ ಆರ್ಗನ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ಗೆ ಹೋದರು. ಆರ್ಗನ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ಗೆ ಹೋದಾಗ ಲಿವರ್ ತಗೊಂಡ್ರು, ಕಿಡ್ನೀಸ್ ತಗೊಂಡ್ರು. ದೆನ್ ದೇ ಗೇವ್ ಮಿ ಇಮಿಡಿಯೇಟ್ ಕಾಲ್, ಡಾಕ್ಟರ್ ದ ವೈಫ್ ಈಸ್ ಆಸ್ಕಿಂಗ್ ಫಾರ್ ಹಿಸ್ ಸ್ಪರ್ಮ್ಸ್, ವಾಟ್ ವಿಲ್ ಯು ಡೂ? ಸೊ ಐ ಟೋಲ್ಡ್ ಪ್ಲೀಸ್ ವೆಯ್ಟ್, ಐ ವಿಲ್ ಕಮ್ ಡೌನ್. ಓಕೆ, ಬಿಕಾಸ್ ಆಲ್ರೆಡಿ ದೇ ವರ್ ಇನ್ ದ OT. ಐ ಟೋಲ್ಡ್ ದೇರ್ ಈಸ್ ನೋ ರೂಲ್ ಟು ಟೇಕ್ ದ ಸ್ಪರ್ಮ್ಸ್ ಫ್ರಮ್ ದಿ ಡೆಡ್ ಪರ್ಸನ್, ದೋ ದ ವೈಫ್ ವಾಂಟ್ಸ್ ಆರ್ ದೋ ದಿ ಫ್ಯಾಮಿಲಿ ವಾಂಟ್ಸ್. ಯಾಕೆ ಅಂತಂದರೆ ಅವ್ರು ಆ ಮಗು ಮಾಡಿಕೊಂಡು ವಾರಸ್ದಾರರಾಗಿ ಅವರು ಅವ್ರದ್ದು ಮುಂದಿನ ಇದಾಗುತ್ತೆ, ಅವ್ರದ್ದು ಪ್ರಾಪರ್ಟಿ ಎಲ್ಲ ತಗೊಳ್ಬೋದು ಅಂತ. ಸೊ ಎ ವಿಡೋ ಈಸ್ ನಾಟ್ ಅಲೌಡ್ ಟು ಟೇಕ್ ಎ ಸ್ಪರ್ಮ್ಸ್ ಫ್ರಮ್ ದಿ ಡೆಡ್ ಪರ್ಸನ್.
No madam, let me clarify. Very recently Supreme Court has reviewed it actually. Not only the female, parents also can go use that sperm sample of the husband posthumously, because parents has gotten a right. And in your case actually, if she is married, her sperm sample can be, see, their vested interest is different. That lady has a right, she is legitimately married. Okay,
but
if the husband is dead, husband is dead,
sperms from the dead person.
No, with a consent.
No, not with the consent.
If the brain dead,
they have to get legal